prominent on prolonged standing and decreases on lying down, associated with heaviness and dull aching pain, which increases by the end of the day. History of the pain in the lower limb was dull aching in nature, aggravated on walking or exercise, or relieved on taking rest, not associated with tingling sensation, sensory or motor loss. See also complaints of dark pigmentation and itching of skin over both ankles for last 2 years. No history of pain or redness along the course of the veins, no history of trauma to the limbs, no history of bursting pain or swelling in the calf associated with fever, no history of intermittent claudication or neurogenic pain, no history of long hospital stay or prolonged immobilization, no abdominal or urinary complaints. Past history, no history of hypertension, type 2 diabetes mellitus, asthma, tuberculosis, or COPD, no surgical intervention in the past. Personal history, she consumes mixed diet, her bowel and bladder habits are regular, appetite and sleep cycles are normal menstrual cycle, no history of any addiction. The family history, no history of similar complaints in the family members. Summarizing the history, a 30-year lady, homemaker by occupation, presented with dilated tortuous vein over the inner aspect of the left and right leg, extending up to mid-thigh for last 10 years and 6 years respectively, associated with heaviness and dull aching pain in both legs, which was more towards the end of the day. Patient also complains of dark pigmentation and itching of the surrounding skin.
Dr. Krishna,
Yes.
what do you think your lady patient has?
Some venous disorder, suspecting.
At present, she is 30 years old.
Yes, ma'am.
And all the problems had started 10 years back.
Yes.
That means she was 20 years old.
Yes.
Right?
Yes, ma'am.
So, 20 years, and did you talk about her profession? Is she
a homemaker?
She's a homemaker?
Yes, ma'am.
20 years?
It was started below the knee.
Did you give us her ops history? I don't see that history here.
No, ma'am.
Is she married?
Married, ma'am.
The history is missing.
Yes.
You think that history is important?
Yes, ma'am, important.
How?
Married people have exposure to estrogen and progesterone. That will lead to dilated veins, ma'am.
What about your patient? Is she married?
Yes, ma'am, married.
How long?
For last 10 years only.
10 years she has been married. How many children?
2 children.
2. So she is already exposed to all those ups and downs of hormonal.
Yes, ma'am.
Right. So what is the symptom series that she presented with? What was the first thing that occurred?
First thing was
the symptoms.
Symptoms, man. Pain was appeared first.
Pain. Where was the pain?
Pain in the lower limb, ma'am. Dragging pains.
Whole of the limb?
Not whole of the limb, ma'am. Lower side initially, which was at the end of the day, ma'am.
She must have specified, no? Lower side means what?
Around the ankle region, ma'am.
Around ankle. How is the typical pain of you presented? Actually, that should not be done. You started off with your case, introducing it as I am presenting the case of varicose veins.
Yes.
None of our patients, they come with the diagnosis. Correct?
Yes, ma'am.
They come with complaints. They don't come with diagnosis.
Yes.
Yeah? That should not be done.
Okay, ma'am.
You can't say I'm presenting a varicose veins case here.
Yes, ma'am.
Right? That is not okay. And then, what is the typical symptom of varicose veins for general population when they present?
Ma'am, dull aching pain.
Where is this pain?
Around.
Patient may have variation.
Yes, ma'am.
Every patient is in itself has a set of complaints. But general, when we talk about symptomatic pain of varicose vein, they just generalize few things. Where is this discomfort usually?
In the lower leg, ma'am.
Be specific.
Around the calf region.
Calf muscle, the prominence of that musculature. Yes?
Yes, ma'am.
Yes. So, what is it typically described as?
Bursting pain, ma'am. Starting with first, typical pain is dull aching in nature towards the end of the day and aggravated by prolonged standing, ma'am.
Your patient had pain around ankle.
Yes, ma'am.
Did you examine joints of this patient?
Yes, ma'am. Joints were normal, ma'am.
They were all normal.
Yes, ma'am.
Okay. So you ruled out any joint involvement.
Yes,
in
ma'am.
this patient. Okay. So what do you think has happened around joint, ankle joint? Why she had this discomfort there?
Due to chronic venous insufficiency, ma'am, there may be perforators at that area that may be causing reflux of the blood, ma'am, and causing the symptoms. In that area, ma'am, perforator veins are present or pressure is highest in the gators area. Maybe that will be the cause of that symptom, ma'am.
And you also asked history about the claudication.
Yes, ma'am.
Any reason?
To rule out, ma'am, other causes like neurogenic
When
or
was this pain aggravated or peak of the pain?
peak of the when aggravated by prolonged standing, ma'am, and towards the end of the day, and it was relieved by lying down or legging the race,
So
ma'am.
what is the difference between the two systems, the arterial system and the venous system?
Arterial system, ma'am, it is pain is started by some work exertion, ma'am. There is some claudication distance, and it is relieved by taking rest.
Claudication.
Yes, ma'am.
What
Intermittent
is the
claudication.
definition of claudication?
It is, ma'am, reproducible pain, which is started on exertion and relieved by taking rest, ma'am.
Walking.
Yes, ma'am.
If
Walking.
we say that pain comes when the patient stands, there is a different differential diagnosis for it. What is it? Just pain coming on standing position.
Maybe neurogenic pain, ma'am.
Yes, it could be arising from the spine, the cord compression. Right?
Yes.
So 20 years she has been having with no family history. What do you think has started off with this? Like, did you ask history of swelling during pregnancy, after pregnancy, and all that is not seen there, that history?
It was normal, ma'am. Obstructive history was normal.
Dr. Krishna, then you have to mention it.
Sorry, ma'am.
That forms a very important part of the history, especially when lady has already had 2 pregnancies, and we need to add that history.
Yes.
Okay?
Yes, ma'am. Yes, ma'am.
Right. Go to the examination.
On general examination, patient was examined in well-lit room with informed consent. Patient was cooperative, well-oriented to time, place, and person. Thin built, hydrated with vitals. Patient was examined in sitting and supine position whenever required. Patient was afebrile, pulse 88 per minute, regular, normovolumic. Blood pressure was 114 by 76 millimeter of mercury. Respiratory rate was 16 per minute. Thoracoabdominal, her weight was 53 kg. BMI of 20.7. Pallor, icterus, cyanosis, clubbing or generalized lymphadenopathy was absent. JVP not raised. Gait was normal. There was no apparent limb deformity. This is the clinical picture. On inspection of left lower limb, there is dilated, engorged, and tortuous veins present over the medial and posterior aspect of the leg and mid thigh. And dilated veins disappeared on limb elevation. Localized eczema and pigmentation noted around the ankle. Inspection of right lower limb, dilated, engorged, and tortuous veins present over the medial and posterior aspect of the leg, and dilated veins disappeared on limb elevation, and localized eczema and pigmentation noted on around the ankle. Hyperpigmentation around and eczema around the ankle joint, both bilateral ankle. The palpation, there is no local rise of temperature, no tenderness or thickening of veins along its course. Calf tenderness was absent. All arterial pulsation, dorsalis pedis, anterior, posterior tibial, and popliteal and femoral are well palpable. Bilateral lingual nodes not palpable. These are the tests. Brody Tenderloin were test 1 and 2, which was found incompetent left SFJ and incompetent perforators. And Perthes test and Fagan's test. Fagan's test shows multiple dilated incompetent perforators, and Morris's people test was uh, positive. The right side, Tenderloin test 1 was positive. It shows incompetent right saphenofemoral junction and competent right leg perforators by Brody Tenderloin test 2, and multiple tourniquet test also showed competent leg perforators. Perthes test showed no deep vein was patent, and Fagan's test showed no incompetent perforators. Morris's cup impulse test was positive. On percussion, thrill is felt at the saphenofemoral junction, tapping over the course of the vein. On auscultation, no murmur or breathe were heard. On per-abdominal examination, no dilated veins present over the abdomen. Abdomen is soft, non-tender, no other lump palpable, no lump palpable.
Go back to
Yes, ma'am.
inspection. Can we see the pictures?
Yes, ma'am.
Are there few pictures? Yes. So what is the superficial system like? What are the named veins?
And the superficial venous system mainly of two types, ma'am. Great saphenous venous system and short saphenous venous system, and deep vein system are there.
No, we're talking about only superficial.
Yes, ma'am. Superficial venous system, the great saphenous vein starts from the medial.
That's okay.
Yes, ma'am.
So see, they are one set.
Yes, ma'am.
They are one set of veins categorized as axial veins, right?
Yes, ma'am.
Both veins fall in this group.
Yes, ma'am.
Axial one. Then there are accessory veins.
Yes, ma'am.
Accessory veins, they run parallel to the axial veins.
Yes,
That's
ma'am.
how we look at these veins. And then there is a third group. They are oblique veins. Oblique veins to the axial veins,
Yes, ma'am.
right? And the fourth group is the perforators.
Yes, ma'am.
They are compartment based. Wherever the superficial veins are, the perforator veins, they just go inside the respective compartments.
Yes, ma'am.
Right. Now, if we talk about the inspection, we
Yes,
need to talk about these groups.
Yes, ma'am.
Why is it important?
Because by looking by inspection, we can see wherever the dilated veins are present. We can tell which perforators or which group of is involved.
But finally, you have to treat this patient.
Yes, ma'am.
So if you focus only on great saphenous vein, short saphenous vein, and you miss out on those other two groups, there can be a failure of treatment.
Yes, ma'am.
So it's very essential that you look at all these groups.
Yes, ma'am.
People treat the axial veins and they miss out on the two more categories.
Yes.
Oblique and the accessory veins.
Yes, ma'am.
Patients come back.
Yes, ma'am.
Treatment is different. Right?
The treatment for each of these veins is different. So you got to make sure that which are the veins present and what would be the treatment. Go on, please.
You talked about the multiple tourniquet tests.
Yes,
You
ma'am.
think that there was nothing prominent in between? You written like that?
Are you showing some tests now?
Yes.
Sir demonstrated all of them in a long
Yes.
video. Now, you're showing it now.
Do you have any picture?
No.
Are you trying to show or
No.
what are you trying to do?
Are you done with your presentation?
Yes.
Okay, so
I was summarizing,
was
sir.
hoping that you're showing the video. Now, can you have your slides back? Please don't remove the slides, Harsh.
It's
Your slides are there, no? Might be closer.
go down. Yeah, that's it.
Yeah. Show us that picture first. Have you described the limb adequately or you think you need to do more? Please focus on your slides.
I need to do more, sir.
So you should have told more about that. No, it's never the examination of a vein. or an artery, it's examination of the limb as a whole, no?
Yes, sir.
Rather than the hole in the limb. So please show us what is it. Just show that picture and start talking.
It's like this needs to be shown once again to
Yes.
online people.
Because it just went on. Stay there. Don't do it. Are you stopping the
No,
shooting?
sir.
Harsh, don't take it away. Just let it be. Let him control. तुम अपना करो ना काम.
Yes,
Don't
sir.
click around. Describe this limb. There are
The,
lots of people watching
yes,
it
sir.
online. उतनी जल्दी मत भागे.
Yes, sir. Attitude of the limb was normal. There is no obvious bony deformities, and there is dilated tortuous veins present over the uh, medial and posterior aspect of the leg, and there is a skin pigmentation around the ankle, and there is
Dr. Nagarajan,
yes, sir.
look, when you're describing a limb in a vascular disease, you must make sure by examination you are ruling out arterial disease, neurological disease, and focusing on to venous disease. So
Yes, sir.
limb length, limb girth, color of the limb, color of the integumentary, the status of the integumentary system, they all have to come out to rule out arterial system first,
Yes, sir.
right? Then you focus on neurological, and then finally boil it down to venous. So the two limbs have to be, you have to go by examination to rule out the arterial disease first.
Yes, sir.
And how would you do that?
In arterial disease, sir, on inspection, sir, the skin will be, if there is any compromise, skin will be shiny, hair, loss of hair, and nails will be brittle. On palpation, sir, pulses will be.
You got the hang of it. So now you go and describe the limb.
Do you know what's the reason why we want you to examine arterial system?
It can, ma'am, coexist if there is a venous and arterial disorder may coexist, ma'am.
Coexist, and any other reason?
If we going to apply for compression stockings, we should decrease the pressure class of the compression stockings.
Any other reason?
Before dealing venous system, we should deal with arterial system first, ma'am.
This lady
Yes,
has
ma'am.
lots of veins in the leg. Right?
Yes, ma'am.
What can be one possible condition that can give rise to huge these veins there or anywhere in the leg?
Ma'am, syndrome, sir, ma'am.
Yes, one reason.
Clipper trinone syndrome is there, ma'am.
That's one reason. Any other?
Any collagen vascular diseases, maybe.
Okay. Any history of trauma that's a clue to you?
Any DVT, ma'am.
History of trauma.
Can there be a connection between the vein and the artery?
AV malformation, if there is one.
No.
Arteriovenous fistula.
Okay, that's a different category. We'll give it to you. AV malformation could be there with prominent veins and all, but we're talking about something else.
Don't know, ma'am.
Which, communication was mentioned. So I mentioned to you about communication. Any communication between artery and vein, what will happen?
The veins will be dilated, ma'am. Pressure in the veins will raise.
Don't talk communication at a small size vessel. We talk at a bigger level.
Yes, ma'am.
Huh.
The pressure in the venous system will rise, ma'am. There will be dilatations, ma'am.
Correct. So there will be arterialization of the venous
Yes,
system.
ma'am.
So the veins will present huge like this. Clinically, how will you rule out that?
Ma'am, clinically, there will be the thrill will be felt, ma'am.
Correct. So there will be thrill there.
Yes, ma'am.
And
Bruit may be heard on auscultation.
and
There will be pulsations. Pulsation can be felt, ma'am.
what? If it's a long-standing one, what will happen to this limb?
There will be limb at hypertrophy.
Term for it is gigantic.
Gigantism.
Right?
Yes.
And if it's more proximal, what will happen to this patient?
Don't know.
Something to do with the heart.
Ma'am, cardiac overload may be there, ma'am.
So we're talking about physiology.
Yes,
The whole physiology will change. The more the proximal the communication, more problems, physiological changes will take place. Yes, more.
All I wanted to you
Yes,
to
sir.
highlight was the examination of a limb rather than a venous or arterial system in isolation.
Yes, sir.
When you examine the limb as a whole, they all get included. It's true of anything on the limb, right?
Yes,
You
sir.
could also see the kind of appearance of the limb, the features of chronic venous insufficiency, the kind of, dystrophy that happens, and then inverted champagne bottle
Yes,
kind
sir.
of appearance. All that will fetch you marks if you describe properly, rather than just talking about the veins,
Yes, sir.
which in any case is not done. Please move on.
Summarizing my case, a 30-year lady homemaker presented with dilated tortuous veins over the inner aspect of the left and right leg extending up to mid-thigh for last 10 years and 6 years respectively, associated with heaviness and dull aching pain in both legs, which was more toward the end of the day. Patient also complains of dark pigmentation and itching of surrounding skin. On examination, varicosities involving the left great saphenous vein with finding suggestive of incompetent left saphenofemoral junction and incompetent left leg perforators and varicosities involving right great saphenous vein with finding suggestive of incompetent left saphenofemoral junction and competent leg perforators along with signs of chronic venous insufficiency and no evidence of DVT.
So there's no involvement of the short sapness. Or is there? If you go back, which I think there is.
Yes, sir. Involvement.
So you don't mention anything about it. Okay.
That's why we are mentioning about there are more veins other than great and short saphenous system. In the thigh also, you can see you have put a mark there.
Yes, ma'am.
Veins are away from it also,
The secondary varicosity is also there.
right?
Yes.
That becomes essential for treatment. Proceed. How will you handle this patient?
First, I'll do investigation to confirm my diagnosis and support my diagnosis and treat the patient, ma'am. In the investigation, I will include USG color Doppler with B mode ultrasound and USG abdomen, ma'am.
Okay. So, what is this ultrasound Doppler beam mode?
So B mode it uses ultrasound probe around 2 to 12 megahertz.
So there are two components.
Yes.
There is the Doppler.
Doppler,
and
sir.
there is ultrasound.
Yes.
What are the two components?
The B mode is used for ruling out DVT and the wall of the veins, and if there is any thrombus or
It tells you more of
yes,
anatomy.
anatomy, sir.
So the structures outside the vein, within the wall, and within the lumen.
Yes, sir. And the color Doppler part is provides the about the flow of the blood and reflux.
So have you got the report for it?
No, sir.
Uh,
What's the report expected in this patient?
Report expected, ma'am. There will be no evidence of DVT, ma'am. Arterial system will be normal, and there will be reflux in the both bilateral saphenofemoral junction and multiple perforators present, ma'am.
How do you describe this reflux?
Reflux in saphenofemoral junction more than 0.5 seconds, ma'am.
So if you are the operator, how will you examine this patient while doing the operation?
I will examine the patient in standing position, ma'am, with Valsalva maneuver for checking the reflux, ma'am.
Not in lying down position?
The lying down position, ma'am, there has to be reflux, ma'am. Vein will be emptied in the lying down position.
What about deep veins?
For
Have you heard about the reflux in the deep vein?
yes, ma'am.
So you need to check that out.
Yes, ma'am.
Right? So how will you describe the abnormal reflux?
In the deep veins, ma'am, more than 1 second, ma'am. For deep veins.
Superficial?
Superficial, ma'am, 0.5 seconds, ma'am.
Okay, so you said that there are perforators which are incompetent. and
Yes, sir.
SFJ which is also incompetent.
Yes, sir.
On the right and left, there are only the SFJ.
Yes, sir. Left side only SFJ.
So what kind of perforators are there? There are two kinds of perforators. Can you tell us what are the right and indirect perforators?
Direct perforators communicate between the superficial and deep venous system directly, sir. Or indirect perforators drain into sinuses, which in turn drain into the deep veins.
So what are the deep veins in the left?
In the deep veins in the left, sir, anterior posterior tibial veins and popliteal vein and femoral vein.
There are three veins in the deep in the leg. Anterior tibial, posterior tibial, and peroneal.
Yes, sir, peroneal.
So you've done this. Now, how will you counsel the patient? What will you tell the patient now?
First, I will educate the patient what is the disease and how to manage. And for
You tell me what is the disease, what will you tell the patient?
I will tell the patient if there is a prolonged standing to take rest, and maybe if there is a job to change the job or limb elevation.
Is it possible she's a housemaker? The children will keep on pestering her for food and all. Can she do that?
How does she change her job?
No, sir. In this case, not in this case, sir.
Yeah, how will she change it? It's not possible, no, they can't reverse the roles. Yeah, but then the husband becomes the homemaker, she becomes, then she'll have to do another job. What do you do when you're using a sentence or I'm listening only? You should be careful what you're speaking.
Yes,
What
sir.
about this patient? What will you tell?
What will you do?
I'll tell her to
We call them all as lifestyle changes.
lifestyle changes.
That doesn't necessarily include changing your job. You can modify the way you are approaching the job that she has to do. Correct.
So what are the main components of medical treatment for this patient?
Ma'am, first lifestyle changes, then compression stockings
What will you mean?
to avoid prolonged standing for long durations, and use.
If she's cooking and standing in position, she can sit down and cook.
Yes.
Or she can sit down after some time, or keep one leg raised on a platform while she's standing on the other leg. It's not that kind of thing which you have to do.
Yes, sir.
One. Second,
Advise compression stockings, ma'am.
okay,
What kind of stockings? What kind of
Graded,
above knee, below knee,
the graded compression stockings, sir.
above knee, below knee,
Above knee.
above knee? Have you seen patients using above knee stockings?
They are
They're very uncomfortable, they keep slipping down, no one uses them. And besides the perforators, most of the perforators which are guilty of this problem are down below the knee. So below knee,
Yes.
this thing is sufficient. Right?
Yes,
What do
sir.
you mean by graded stockings?
The pressure is,
The class of stockings.
sir, class 2, 3, 4. One, sir. Class 1, 2, 3, 4, sir.
Okay. So what class do you expect this patient to be doing?
At least class 3, sir.
Why? Why not class 2? Why not class 2?
Class 3, sir. Minimum pressure is at least 30. We should
Why
get.
do you want to give class 3 and not
Camera friend, take care. Left in and left out.
Sir, in the class 3, sir, the pressure is 30 to 35 millimeter.
Pressures. You know the
Yes, sir.
pressures.
Yes, sir.
Stop it. Unless you want it.
Class 1 is given when there are reticular veins. Right, just
Yes.
discomfort. Here this patient is having lipodermatosclerosis, could be impending ulcer also,
Yes, sir.
right? So you have to give a class 3.
Yes, sir.
What else?
Then, sir, proceed for do the investigation for.
Will you tell the patient?
we are at 3 level, right?
Yes, ma'am.
You said lifestyle change,
Compression stockings.
compression stockings,
Care for
avoid prolonged standing, 3, you said? No. What else?
Ma'am, care for the skin, ma'am.
Care for the skin, very good. So what's the care?
To avoid dryness, ma'am.
to avoid dryness. She already has itching.
Yes,
Very
ma'am.
good. What else?
The ma'am, limb elevation, ma'am.
Any soap advice you can give to such patients? What to use, what not to?
Don't know, ma'am. So,
They are not supposed to use harsh acidic soaps. Right?
yes, ma'am.
They supposed to use more neutral type of soaps. You know, baby soaps,
Yes, ma'am.
they are neutral. They don't, we don't use harsh adult soaps on babies.
Yes,
Have
ma'am.
you seen it? No.
No.
The nature of soaps is more acidic, so you have to use little more milder soaps for such stain. What else?
And no bitterness are not used. People use it to watch, no bitterness.
Okay. Or one important component here is
Ma'am, in Biscard Seji, ma'am, educate the patient, ma'am.
that's fine. Education, good, very good. What else? Exercise.
Exercise, ma'am.
Exercise forms a very important component of management. No matter whatever treatment you offer in second step, intervention.
Yes, ma'am.
With or without intervention, you have to give them exercises. And what is it meant for?
For the ma'am, action of the calf muscles, ma'am, it will.
So most of the problems are with the peripheral palm.
Yes, ma'am.
We all know calf is a peripheral palm.
Yes, ma'am.
You have to strengthen that peripheral palm. One. Second, the disease is more around the ankle joint. With more advanced diseases, if there is an ulcer, it has healed, there is fibrosis, a lot of things are happening around ankle joint. What happens with this?
There is a loss of subcutaneous fat, ma'am,
Yes.
and there is a hypertrophy of the calf muscles.
Okay, let me ask you.
Yes,
Why does it happen around the ankles, especially on the medial side?
because there is less subcutaneous tissue and pressure, venous pressure is maximum there, sir.
Yeah, so why on the
And
medial
per-
side? Why not on the lateral side?
And
What's the
perfor
lateral area there?
and perforators are present in that area, sir.
So you have the whole vein running on the medial side, the great saphenous running on the medial side. So the maximum pressure at the medial end of the lower end of the lower limb. Isn't it?
Yes, sir.
All the limb, all the veins are on the medial side. The great saphenous. is on the
Yes, sir, medial side.
That carries the maximum pressure. The pressure goes down below. Once the balls are gone.
So there's a lot of things happening in that area. There's a lot of fibrosis. Finally, there's a big toll hit on the ankle joint, the ligaments around it. There's shortening of ligaments. People tend to walk on toes rather than put heel down. So these are the complications associated. Whenever we have any problem in the body, the adjacent joint needs to be taken care. Right?
Yes,
That's the
ma'am.
ankle joint. So give exercises to strengthen the calf. That's the peripheral palm. Patient will be symptomatically better. Right?
Yes,
The good exercises meant to do this. We can discuss it at some other time. And that's most important, conservative management, wholesome list for you.
yes, ma'am.
Good?
Yes, ma'am.
So,
What's your diagnosis? What did you say? You didn't move further. Must have given the,
Yes.
give a good diagnosis, complete.
My diagnosis is a case of primary varicose vein affecting left and right great saphenous system with incompetent left and right saphenofemoral junction with the left leg incompetent perforators without any clinical evidence of deep vein thrombosis. My CAP classification is for right side C4A, SEP, ASPR and left lower limb C4A, SEP, ASP, PR. Ma'am.
describe right side.
The right side C4A means C4A is for pigmentation and eczema, and S for superficial venous system. E for etiology is primary etiology. A for anatomy. Anatomy is superficial system. P for pathology for reflux, ma'am.
tell me the difference between primary varicosities and secondary varicosities.
Secondary varicosities mostly occur after the incidence of deep vein thrombosis, post-thrombotic. And
And
there will be localized to some areas,
will be,
localized to the area of affected veins.
what do you mean by localized to
The DVT,
No, I'm talking about difference between primary varicosities and secondary varicosities. One you said, primary is seen in younger age group. This is in elder age group. What else? Primary will not, usually they don't proceed to these kind of secondary changes.
yes,
Ulceration and all is not very commonly seen in primary. Right?
yes.
Varicose ulcer. Do you know the difference between varicose ulcer and venous ulcer?
Don't know, sir. The same.
Right. So varicose ulcers are superficial to the fascia. Right? While venous ulcers are deep to the fascia. Also, varicose ulcers can heal, but venous ulcers tend not to heal. They are very difficult to treat. Okay. So do you think this is again primary or is it secondary? Just because she doesn't have evidence of DVT, you think it is primary?
Sir, according to clinical features, now I think it is maybe secondary, sir.
We have not covered that part of history, isn't it?
Yes, ma'am.
Yeah, that was missing.
Any question from the students? Yes, please.
Patient, there is chronic problem of ulcer. They're not. What is the management of that?
Can you be louder in recording? No, you can look at us, but speak loud.
On the patient, they're having chronic problem of ulcer around later stage. Generally don't heal. What is the management of that? Like we operate the patient for varicose veins, that problem is solved. But not that.
See, the ulcers are subsequent to that, the basic abnormality. So if you have chased the abnormality and treated it, the chances are that that should settle. One. Second, any wound anywhere in the body, if it's not healing, look at the quality of the wound. Is it infected? Infection is single most important cause anywhere in the body. It doesn't allow wounds to heal. Take small bit of tissue, send it for culture. Don't take swabs. People tend to take swabs, superficial, multiple organisms. You don't get any culture. Take tissue, piece, send it for culture. You will get the sensitivity pattern. Treat the patient. Do good dressings. One. Second, treat the incompetent perforators. Sometimes there are perforators, they are not reachable because people tend to be away from the wound and they are not treated. You have to focus on the incompetent perforators right close to that or under that. 3. Pressure dressings. Patients cannot tolerate graduated stockings and all that. They cannot pull it up because the ulcers are painful. Right? What is the alternate choice? There is compression bandaging system is available. You get short stretch bandages and apply them. They help the patient. We have done a trial on it. It is of immense help to these patients, but it's not only one thing that will treat. A combination of all that has to be focused on treat the patient, right?
Another important thing is that it still doesn't heal. Then there is an element of deep vein thrombosis that are recanalized. So this is a venous ulcer rather than a varicose. Venous ulcers, if there is a component of deep vein thrombosis, then they tend not to heal. They are very difficult to heal, in spite of doing everything. So you must rule out deep vein thrombosis, which are recanalized. So the valves are gone. The vein is intact, but the valves are gone. This leads to chronic venous insufficiency and a non-healing ulcer.
I think your question was very valid. Very complex situations. And they're all trying to teach you that treat the patient as a whole, not the hole in the patient. You don't look at just that defect. What is the underlying cause? A patient with varicose ulcers or venous ulcers may be having underlying protein deficiency also. He could be having other reasons for not healing. Because eventually it's the patient who has to heal, correct? If there is a venous hypertension or there is a chronic venous insufficiency, you have an underlying cause. That's why you're obsessed with it. But there could be associated other features which also don't let the patient heal properly. So it's a comprehensive management. It's not just one. Nowadays, they have MDTs for vascular management also. So MDTs will involve podiatrists, people who take care of the lifestyle changes, including the use of the the bandages that are applied in layers or Robertson Jones, etc. There's so many things that are included, not just one part. So it's a comprehensive management of the patient as a whole, along with the limb and then what. When describing it in the history, also take the history of the patient, of the limb and the ulcer. Then. Examine the patient, limb and the ulcer and investigate in the same order and finally treat in the same order. So it is not in isolation that you just talk about the venous system and vascular system. Could be having both systems involved, could be having additionally some other problems. So there's more to it than just the case. Okay?
Yes, sir.
Yes, madam.
Another thing is, please advise them to walk. There are a lot of people around, they tell them not to. Right? That goes against them. Walking, we know it's a healthy thing, and for any tissue healing, walking is good, especially for legs. So you have to put that in the prescription.
Yes.
Rather than just verbally telling them.
Okay.
Yes.
Now,
Part of the prescription.
thank you very much. Excellent presentation. Perfect grinding, and you probably everybody learned through you. And in the amongst the online people, any question you can post it in the chat box. We'll take them up. Give a big round of applause for the first presentation. The second is loaded.
Thank you, Krishna.
Thank you.
Krishna. Is the second presentation loaded, Rishi? It's an online, okay. Surya, who is this? No, Krishna is presented. Shivangi, are you there? Please unmute her. Shivangi Mandani, you are there. Please unmute her. Shivangi, unmute yourself, please.
Yes,
So,
sir.
all the students.
Yeah,
she is there.
Shivangi, can you hear me?
Yes, sir.
Yeah, please start sharing. And you're welcome to Scrubs. Start making your presentation. Please start sharing your screen. Can you start sharing the screen, please, Shivangi? Dr. Shivangi is from GMC Mumbai.
Shivangi, keep yourself unmuted. You have muted yourself again. Any question from the floor? How many of you have seen patients of varicose veins?
Everyone must say.
Everyone. And ulcers? Speak loudly.
He wants to know where the VAC is. VAC assisted.
That is What do you understand by that? Right, so what is the concept? What does it do? See, the problem here is not lack of vascularity or the depth. We even talk about depth, where you need tissues to fill. Varicose veins are not deep, like in the musculature, they're deep, big ulcers, wounds. They're very superficial. Another problem with the venous ulcers is they have pain. If they're more superficial, they have pain associated with it. One more factor, it was not venous ulcer phase. Another factor is the element of cellulitis with it. That brings pain. Patients cannot tolerate all these bags and they do.
Here the source, the problem is increased venous volume and decreased venous return, isn't it? So if you put in a VAC, you find more blood inside. You want the blood to, how does the blood go from the lower limb to the heart? What are the mechanisms?
Shivangi, can you unmute yourself, please? They are all trying to call you. Probably you not hear me. You can hear me.
She's off.
Huh?
She's not there.
No, she could have. She may be trying to reconnect. She can't leave like that, no?
She's trying to reconnect.
Yes, please can you stop.
Yes, please.
Actually, the whole concept of topical negative pressure therapy, TNP, is to stimulate angiogenesis by creating hypoxia. In a venous system, that is not going to work. And what did he ask you was a very important question. How does it drain? What is the drainage pattern? Is that what you asked? So you can answer that.
So there are a couple of things. One is negative intrathoracic pressure. Most important, the peripheral heart or the gastrocnemius. And the third is what is known as visa turbo. The artery and the vein and the nerve are in one sheet. So when the artery expands to its system, it presses onto the vein and that pushes out.
Camera इधर ही रखो जो बोल रहे थे चेंज मत करिए वो unnecessary. Just stay, that's okay.
Problem here is not vascularity. They have even found that there may be little communications between arteries and veins, little bit underneath these chronic ulcers. Problem is infection, problem is on surface, not.
It should be moved to the third presentation then, I think she's taking.
And VACs are more, you tend to use where there is oozing, secretions, discharges. And to keep the area neat, all the things are sucked out. And obviously, and they are never applied on infected wounds.
Surya?
You should never apply VAC on infected wounds. You always clean them and then you apply them wherever in the rest of the part of the body, not on infected wounds. Right?
Balakrishna will. They're not able to connect.
Any other question, any doubt?
Actually, when you're examining a patient of varicose veins, there are three important examinations. One, you must know the competence, test for competence of the saphenophrenic. Two, the test to rule out DVT. And three, to find out where the perforators are. These are the three most important tests. All other tests are just ancillary and they just add, but they're not very important. These are the only three tests which are important. And you should proceed to these tests only after you rule out any arterial problem.
And there is one more debate everywhere happens that we do the Doppler while there is a need to examine the patient. Don't overlook it. Examination of the patient is most important. Whenever a patient comes to you, we have already discussed what other things can be there. So that can happen only on examination. Examination of Doppler with Doppler will not lead you to all those accessory veins and all, unless you take the probe and look for them, right? They tend to be more specific for the axial veins. And if you miss other set of veins, the oblique veins and the accessory veins that actually run parallel to the axial veins, you are far away from the treatment. You are only treating part of it and you are missing other veins. This is what happens when patients come back to us or they are treated somewhere else. Axial veins are treated. And for a patient, the visual impression of the leg is the test, right? He doesn't know what you have done inside. You have done RFA for this, laser for that. He has no knowledge about all these things. What he can see is his own leg. And if he still sees that the persistent veins away from the main vein and all, for him, it's a failure of his treatment. So examination is equally important. So there are teachings happening around that go straight away for the Doppler and you fix up the problems of veins. You miss out on these extra veins then, right? So take care of these veins by examination and focus them while you are introducing the treatment, whether it's the endovenous laser ablation or RFA for the actual main veins, or sclerotherapy, foam sclerotherapy for the accessory veins or the oblique veins, right? There are people who have different set of laser probes, different sizes available. They can enter with smaller size of those probes into these accessory veins also. It's not no, but then generally everyone cannot afford to have many probes and the size may not be available. It comes with a big cost. So the foam sclerotherapy is an alternate way of handling these accessory away from the main axial gland veins.
Any question that you would like to ask anybody before we wind up, because they are not able to connect, so I won't be holding back Dr. Anita Dhar. She has to go back to the institute, and Dr. Anand Chai is of course going to stay on. Any question relating to the vascular disorders? We have presentation on day 1 and day, yes, please.
How do I differentiate
What is cellulitis?
So
Feature of cellulitis on the body?
there will be redness,
Yes.
pain, and on examination there will be tenderness, and the redness will be glandular to rest.
Correct. So all these things do happen there.
If there is pigmentation, depigmentation due to.
But that will not mark the temperature. So the first part of the examination is touching. Compare it with the opposite side. You will see a rise in temperature there. It will be warmer than the opposite side. Even if it's mildly warm, that is a clue. Patient will complain of pain and ask history, and sometimes they have recurrent fever. Right? Not always, but on examination, you can see the warmth, compare it with opposite, and also one segment above. See for yourself, even if it's deeply pigmented. Right. Another component is, yeah, you are happy with the answer? Right. So another component is swelling associated with it. It's not only associated with infection, cellulitis. We know all this also brings the element of swelling. There is one more twist. These patients can have lymphatic association also. There's a combination. So patient has venous and lymphatics. So both venous and lymphatics, both together in the same patient, right? So you have to see venous system has cellulitis there, but lymphatic augmentation, it's partial. Its location is around leg, lower leg, and the swelling brings along with it lymphangitis, right? Lymphangitis may bring fever. So patient will complain about fever That could be because of the meningitis, that could be because of the cellulitis per se, because of the ulcer and other things. The treatment is to give antibiotics, and that is not for just for 5 days or so. It's a broad spectrum. You have to sometimes give it for 2 weeks and sometimes stretch it to 3 weeks. They are hardcore infected cases. So I don't know what spectrum you have seen till now, but sometimes you need to give and eradicate that deep-seated organism from their structures. Okay?
Unfortunately, we are not able to get them online. Both of them were online. This is what happens yesterday also we noticed, but we could have it later in the day. So whenever they're able to fix it. Meanwhile, we'll go for the next session, and thank you very much, Professor Anita Dhar. Big round of applause. Professor Anita Dhar is Professor of Surgery and Organist of Medical Sciences and a regular backbone of the SCRUBS course. Vascular session, she's the one who moderates all the time. So we were looking forward to, you have a question? Okay, you can do that. You can have a quick 10 minutes round for them. So Nishi, can you help her with this projection? Images were shown yesterday. We had a presentation by Dr. Sahano. I think let's call somebody. I think Aman, we go together. Amandeep, you come and make a presentation. No, don't connect it without asking it. No, don't group up everything.
Can we see the image?
You show the image here and then we can project it. चलता जाएगा, रुकेगा, कहीं तो कुछ समझ में आएगा।
Is this arterial disease? I think it's a diabetic foot. Not typical. This must be a diabetic foot, please.
It will kind of become an ASCII for you. You heard about.
Okay.
Tell him to.
Change.
No. Tell him to do it. Don't do anything. See, you already have.
It's not an exam for you. Kindly look at the picture and just describe. Nothing beyond that, because you don't know about immediate rates. Just describe this picture.
HP can connect that. There's no problem. In that book.
Meanwhile, if you have understood this picture, you can start speaking. While we are connected.
And doctors keep coming.
HDMI converter.
Okay, it was easier to put on a pen drive and take it.
I'll get.
अरे कुछ नहीं करना था सूर्या, you should have just taken it on a pen drive.
pen drive से दे तुम सुन रहा हूँ because फिर Zoom पे भी डालना
अभी 10 मिनट तक यही करते रहेंगे given a you know we provide.
Okay, have you seen the picture?
Yes, ma'am.
We start this time. Don't worry.
On inspection, there is a pigmentation present on the dorsal side of the right foot. Apart from that, there is a ulcer present on the greater toe, suggestive of trophic ulcer, which are the pressure points. So it is most likely an arterial disease, depending on the location of the ulcer. On inspectory findings, plus there are multiple pigmented points on the left side of the limb, just an inspectory finding. And in palpation of this patient, rest all findings are normal.
You can't palpate picture.
I'm saying that on palpation we have to look for the
Is pigmentation gangrene?
it
हर्ष इतना कॉम्प्लिकेटेड कहाँ से हो सकता है यार, ये इसको पेन ड्राइव में लो और इसमें लगा दो.
सर फाइल ही पूछ रहा हूँ कौन सा
I
वाला
don't
कॉपी
know.
करके डालनी है मेरे को बस.
Learn this also. Don't make simple things complicated, and you just saw an example. Don't do this. Both of them are goofing it around. There was one pen drive to attach, take it and play present. Whole thing got changed. The Zoom has to be connected again. That's absolutely ridiculous. Total waste of time. It'll happen in surgery also. If you can directly see something, you want to go indirectly to reach it. So learn that habit by watching the mistake of others. A classical silly mistake of trying to change the whole system when they could have just got it on a pen drive and played. That's all I was telling you. Okay. Yes, sir.
Yes,
And
sir.
then don't forget to describe the limb.
Yes, sir.
Come to the ulcer towards the end so that the examiner understands that you make an effort. And the ischemic limb would be classical, visibly, all those features that they've described, try to look for them. Look for areas of deformation which are visible, some areas of some callosities or some other places that are cracking, and the color of the skin, nails, character. Spend time doing this so that you're able to get a breather and you settle down into answering the specific questions. I mentioned that I would wish to palpate before I say anything about it. I would like to palpate for the pulses. In the limb is all of these things. It's not just vessels, as I said. Neurological examination is mandatory. And when you say neurological examination, dermatomes. Can you tell us the dermatomes of the limb? You can't?
Not properly.
Put your hands in the pocket, both pockets. You've got different pockets, side pockets if you had. And L2, 3, 4.
Yes, sir.
L5 on the lateral side, and he's walking on S1, S2 up medially, S3, S2, and S3 you sit on.
Yes, sir.
Dermatomes, sensory loss is the first loss. Clear?
Yes,
Motor
sir.
happens later. Examine the attitude of the limb, any visible deformity, apparent shortening, lengthening, visible ulcers, sinuses, color changes, dilated veins, as you see varicose. This is a limb as a whole, and it's no exception in any situation. Clear? Loss of hair or presence of them with any changes that you would suspect to be of different nature, pigmentation, etc., blah, blah, blah. I'm not going there. Then you are getting down to your physical palpation, etc., where you will describe all those features that they've already taught you. But don't forget to mention the movement of the joints, examination of joints, proximal, distal, as well as the joint above. The gait is important, correct? But don't ever forget to examine the normal side first before you examine the abnormal side. And no passive tests to do in movements of the joints. Active first, passive later. I'm now telling you the overview of it. And do not forget to examine then the arterial system, venous system, and lymphatic system, regional lymph nodes, and the spine. And you're done. All cases. When examining the foot, don't just talk about that ulcer. Arches, visible changes, velocities, areas of desquamation. Yeah, any visible deformity you'll find in a diabetic foot, you'll find when you have sharp foot joint, the positioning is different, cracks are different. So everything is to be described, but emphasis to the point which you are asked specifically. They told you examine this foot, they are trying to get into arterial ulcer or arterial, disease, but don't get deviated. You examine the foot as a whole, it gets covered automatically. And don't think I describe the local finding first and then others will happen automatically. No. Describe as per a set pattern, it gets covered.
The most important mistake students do, they just jump to the conclusion, this is a venous ulcer, it's an arterial ulcer. Kindly don't do that. Go by the history and narrow down your DDs, right? I have seen patients, a venous ulcer, typical venous ulcer being present as an arterial ulcer. Nobody knows the diagnosis. How does it happen? It happens after listening to a detailed history and forming a differential diagnosis, ruling out things, right? Ask more questions if you have doubt. After examination, you can go back and ask, you can communicate with the patient while you are examining. There's no hard and fast rule that you finished history. Now the examination is happening, so what do I do? I have already finished. You can go back and talk to the patient. While examining, do a general physical examination. Students finish. Students forget there is something called general physical examination. Right? While you're talking to the patient, start your general physical examination. There are a lot of things that are missed. For example, if you are dealing with a lower limb arterial disease case, upper limb is forgotten. Right? And while you are examining one pulse, radial pulse, don't forget that you should examine the opposite side also. This can happen while you are talking to the patient and you save time. We know there's sometimes limited time available. There's a lot of stress, exam stress and other things. Just calm down. While you're talking to the patient, start examining and do general physical examination. Do not forget about it. Examine upper limbs, pulse, volume, see for match it with the opposite limb. There's a symmetrical layout of the body God has gifted us. Symmetrical, two limbs are there. So examine, compare it with the opposite limb. Right?
Got it?
Yes, sir.
Now, you can describe, I have a better suggestion. Dr. Ratna, you run through the cases. They can answer. You can come here, we'll make it into a speed. Rishi, you can also go.
So what you are describing here, the soul of this patient, it's somewhere healing situation of this. We are not in a very initial phase where the patient has presented. It's all peeled off skin of the soul, which is healing. You can see the remaining part of the soul, that's the skin that is left over. And there's a fresh skin that is seen medially. So don't get confused. This patient is already treated. There is a toe that is missing. The second toe is missing. And that means an amputation of the re-amputation has been done. You can see that wound there. It belongs not to the same patient. It's not- They are two different
I think
patients.
you can, Dr. Ratna,
Dr. Ratan, they are two
take her
different
through the,
patients.
take him through the case and we'll have discussion.
Yeah, so there is this 50 years lady who's a known 50 years
You are
lady,
responding.
the
It's direct asking, we'll chip in.
50 years lady who's a known diabetic and presented to the OPD with discoloration of the foot and an ulcer on the undersurface of the right great toe. She has past history of intermittent claudication
The
also.
right picture. Focus on the right picture, right side. The left picture is some other patient because there are only 4 toes there.
No, which
I think there are
of
two
the
different.
two, Dr. Ratna, you are?
No, I
referring to?
described the
No.
left one,
The one.
the
Can you
lady,
understand?
the lady. I
That
thought
one-
they are
The
are
blue
both.
colored
No,
dress.
madam, they are the images of the same patient. If you see even the hyperpic, this is a zoomed up image.
Yeah, the toes are.
This is a zoomed up image. If you see the area of hyperpigmentation in the left toe.
Here also,
Yeah,
but they're just.
one is, it is, yeah.
You can count 5. That's it.
There is a
Okay,
fasciotomy, yeah.
go by what you said. Please describe the picture. Nobody's interfering, you describe it now. It is visible. Either for you, go ahead.
Hello.
Yes.
अरे बैटरी चेंज करिए please.
On factory findings of the right foot, there is a blackish discoloration present over the dorsal side of the foot. Attitude of the limbs appears to be normal. Also, there are cracks on the between the first and the second toe, and also on the medial aspect of the foot. There is discoloration present over. Hairs are absent on the right foot, and from the.
So you describe the positive findings that you see on clinical imaging. That's all.
Plus there is.
Yeah. Yes, there you can see areas of scaling. You can see that there seem to be nail changes. There is an ulcer which is there at the tip of the toe as well as on the dorsal surface of the toe.
Where
Yeah.
is the area of discoloration? Can you see that? On the sole, what does it indicate?
Healing of.
Desquamation cannot be healing. Desquamation is the first feature of ischemia, no? The topmost layer going off with ischemia because the skin topmost layer. What is the topmost layer? Stratum? Cornea. So that keep peeling off. The other thing, what do you see? Are the toes looking all right? What is the hammer toe?
Flexion at PIP zone and extension at DAP zone.
And what do you see? Now you can speak, just describe the right foot. Okay, we know you would like to speak about the left first and make it a habit to speak about the left, even if you're insisting, somebody's insisting. I would like to describe it, right? So now start describing it so that we say one time.
What is the kind of ulcer you see? What is that wound? Is it an arterial? Is it a neuropathic? Is it a venous? What kind of wound is that?
This is a pressure area, so this is mostly an arterial zone.
No, pressure areas will have trophic ulcers, no?
Trophic ulcer.
And what about the ulcer at the tip of the toe? Actually, diabetic patients can have a combination of neuropathic, arterial, and venous pathology. So what you need to talk about basically is you can talk about any area of discoloration which you see at the tip of the great toe. And hyperpigmentation on the dorsum is not an acute embolic phenomenon which is given rise to gangrene. There is a fasciotomy incision which is there in the interdigital area. Probably there might have been an abscess that had formed. You see some nail changes here and you see areas of scaling and interdigital ulceration.
Okay, Amandeep. You think it's in diabetes, you've got like ma'am said, it's both neuropathic and arterial and venous, right? How do you make sure that this is a wet ulcer or a dry ulcer?
The dry ulcer would have, wet ulcer would have a line of, there will be no line of demarcation.
There's any infection there?
Doesn't seem to be.
You can see sectioning on the blackness of the toe, on the base of the toe.
Focus, there is not only that ulcer there.
Yes.
Look at the proximal part of the big toe.
The great toe is still there.
Narrowed.
Gangrene, it's
Right.
not necrose stain there.
So
Can you
it's
see that?
short.
Yeah,
Below the.
the whole
Right.
toe
So
is involved.
in diabetes, we would expect it to be a wet gangrene, right? So how will you manage this patient? How, the aim is to get the wet gangrene to dry gangrene. How do you do that?
So first we have to give the patient with appropriate antibiotics and the regular dressing.
No, how will you investigate this patient first? How will you make sure that,
We will get an X-ray of the foot done
why?
to rule out if the infection is into the bone or not.
Any clinical way of finding out whether the bone is infected or not?
We can tell to move the patient, move the bone, and loss of sensation would be.
What is the probe
Yes.
test? If you put in a probe onto the ulcer and if it hits the bone is likely to be infected.
And in diabetics, X-ray foot may not be
It's not-
sufficient to talk about. You may need to get a CT foot done because it invariably takes you to an abscess
Okay.
that starts in the
So
separator.
you've done an X-ray. Next, the what else?
And glucose monitoring the patient
Okay, managing the sugar. What else?
and proper dressing,
Any this thing for the infection?
saline dressing,
Any antibiotics?
clindamycin.
Okay, why clindamycin?
Cover the superadded infection. of-
No, you said clindamycin specifically. I want to know why
Clindamycin
clindamycin.
for anaerobic coverage.
Is it? Clindamycin is generally used for soft tissue infections when there is synergistic infection. Right, that's the drug of choice. But you have to give a broad spectrum antibiotic straight away first. Right? Alright, so. Well,
Shown in the.
Yeah, no, what
picture.
ma'am was pointing out was at the constriction and the line of demarcation that you were talking about at the great toe.
Asking- Relating to this, the question.
So what is your impression from this photo?
Infection,
See,
most
we
probably-
want you to clearly rule out, is it a venous disease case? Is it?
doesn't seem like you
It doesn't seem, because more peripheral tissue is involved, right?
So arterial,
artery.
why would you say diabetic? They're all harping diabetic food, we don't know. For that, you need to know the patient is a diabetic, so she gave you that history.
Yeah.
So when you're looking at, like I told you in the beginning, even in a diabetic, it's the management of the patient, the limb, and then finally the foot, or wherever the problem is. And many things will be done. Control of hypoglycemia, glycemic control, mandatory, nutrition control, mandatory, antibiotic cover, mandatory, right? Clinda, you're right, takes care of anaerobes, material or Clinda. And thirdly, but you need to know that they are anaerobes. They're expected, but initially you will be broad spectrum, naturally. And you would need an X-ray put for what?
To see the infection bone involvement.
So for osteomyelitis, although that's not very sensitive, but also for sharp foot joints, you may find. And CT foot is preferred because it gives you more detailed information. CT is nothing but a better X-ray. So don't get confused with CT adding anything differently, but it's more sensitive. Okay, and then of course you need to send the tissue cultures or the pus culture. Where would you take it from? Surface or from the depth? Is it tissue culture or the swab?
The tissue culture.
So tissue can come only from the depth. Why tissue culture? Why not just a swab?
Infection is mostly deep rooted.
What kind of infection is it? If it is deep rooted, because there is no oxygen there. What anaerobe? One. Anything else?
Gram-positive bacteria.
Bacteria done. Anything else? Something worse? Fungi. Okay. So you need to send fungal culture separately. Anything else? Offloading or taking care of the foot wearing. That's why I said patient management, limb management, and then the foot and the ulcer.
So if you,
Now tell me whether it's a diabetic foot or an arterial disease. How will you make the difference?
And here we will look to see whether there is loss of sensation over the area or not. That is present, that goes.
See, that will be only if the nerves are involved. Otherwise, if the nerves are intact, you will not find the difference. What are other features? Most of the diabetic foot patients. Good. So clues from history, clues from examination, maybe that more proximal pulses are absent in this patient. That doesn't happen commonly in pure diabetic foot, right? So examine. Most of the times diabetic foot patients, if it's a pure diabetic foot, ankle, the pulses around the ankle will be palpable. And therefore, more distal vessels get knocked down. Neurological examination, deficiency, loss of sensation, it doesn't happen in every case. Yes, for a long-standing person with the diabetes, it does happen. Right? Sir already mentioned about pure diabetic patient, long-term, we have to be careful if sometimes the ulcers are at the sole. There was one more picture, Dr.
Yeah, that is.
There was one more picture in this.
Yes, I will just
It
get back to
was-
the presentation is here. I'll ask him one question on this. If this patient had dry gangrene of the great toe, would you consider disarticulation or reamputation? We're talking about this patient, if this patient had dry gangrene of the great toe. No, so in a diabetic, you should take them with a pinch of salt, wait, because it's a dry gangrene, no, wait for it to follow. Because a surgery in a diabetic patient may again result in another non-healing wound. So you should wait for it to.
Yeah. When will you do it? In arterial disease case, the timing is very important.
When there is a line of demarcation.
Okay, but if it's a dry gangrene, you will first revascularize the limb. There is no rush to amputate the limbs, the toes. Revascularize, have a good circulation as far as possible, optimize it, and then go for the amputation of the toe. This is the foot that I was talking. There is an ulcer at the sole. Typical case where offloading will help. What is this offloading? There is forefoot offloading and hind foot offloading. So the body weight, it doesn't go through the forefoot. It's lifted from the surface. There are specifically designed chappals available, shoes available that helps to heal these patients. It takes off the pressure from that side.
So this will close it then. Sorry for it. Yeah, done. Sorry for interrupting you.
No, please.
That's okay.
One thing you want to ask something? No,
That's okay. This is, can you tell us what this lesion is? What is this there on the on the sole?
Use the mic closer to your mouth. We are all doing
Yeah.
it. There is no shame, right? Don't keep it blow down.
No, is it just an ulcer? That's an infected callosity on the plantar surface of the foot, and a lot of scalene is there.
Constantly getting a feedback. Please get it close to your mouth.
So callosity, scaling, dry areas happen in patients. So this is an infected callosity on the undersurface of the foot. It's not a plantar wart.
What is the sequestrum? What is the sequestrum?
That happens in the healing phase of.
No, that's a dead bone, no? Sequestrums.
Rajkot has death being good news. The question is dead bone. And what is involucrum? Anybody? So last row people. Anybody who can answer involucrum? Since he asked, I did not ask for it. A dead bone in a living bone. It's like a, it's a tomb.
So that's why you get an X-ray and a CT done. If it is present, you will have to take it out. And if it's a small sequestrum, you can extract it. Otherwise, you may need to consider amputation.
And considering amputation
Yes.
and disarticulation, Dr. Verma,
Yeah.
it would all depend on where the line
Yes,
is.
sir.
And waiting for them to drop off can be challenging, but it can happen. That's auto
yeah.
amputation is good enough. But yes, you're right.
In
Also, you have to
diabetics,
get
it may
to-
be a challenge
to get a-
post-operatively.
Therefore, getting it disarticulated makes it easier to cover it up or close it. Otherwise, it will depend on where the line is.
So another point associated with it is whether you are dealing with a chronic arterial disease or you are dealing with an acute arterial disease, make a difference. Another entity is acute on chronic, right? Fourth one is rest pain. Patient having an extreme degree of arterial disease where the patient is lying in front of you with pain in foot on rest, right? They are the patients most vulnerable to lose limb. If you don't interfere now, you don't treat them now, next visit, if they prescribe something and you tell them to come after 1 month, you will find a dead limb, right? Whatever, take an opinion, do whatever. If the patient has rest pain, that is immediately to be sorted. Patients have very less time with them. Either you heal it or patient has a major amputation. So desensitize yourself whenever such patients come to you, differentiate whether we're dealing with an acute, chronic. Chronics are more or less settled. They do have problems, but you have time. But acute and chronic and rest pain, extreme degree, no time. When we talk about time, we talk about healing, not healing, dying tissues, and that leads to gangrene and major limb loss. When we talk about major amputations, what is the definition of a major limb loss? What is a minor and major? Minor is toes, forefoot, where you can salvage rest of the foot. Major is the ankle is out, the knee is out. They come in major category.
Right. So
Right.
we are late with it. Thank you very much,
Right,
Dr. Ratnam, for covering it up and wonderful auspices for this. Doc, we have, before we conclude the session, the last presentation is by Dr. Piyush Ranjan, who's additional professor of surgery at All Institute of Medical Sciences. Demonstration of examination of the lymphatic system, then we proceed to abdominal exam cases, and finally faculty demonstration by Professor Anubhav. Have you loaded your presentation, Dr. Piyush? You can directly play it, I think.
Good morning, all. So, this is an important system. We have seen throughout all presentations, particularly related to the malignant ones. We were discussing about the lymph node involvements. So that is an essential component of lymphatic system examination. So what else is there? Why do we examine the lymphatic system? So this is, I'm going to tell you what are the different basins, important basins. So essentially there are 600 to 800 lymph nodes in the body, of which you can say more than 250 lymph nodes in the neck, around 300 lymph nodes are there, right? So this give thyroid's example. If the node, the tumor is bulky, lateral compartment nodes are present, they are positive, so you need to take out the central compartment as well. So usually these nodes are not palpable, but there are some areas where they are palpable, but there is a cutoff above which we say that this is a abnormal node. Now, what is generalized lymphadenopathy? Any two non-contiguous area, if they are involved, we call it generalized lymphadenopathy. And if you are dealing with such a case, we need to think of the lymphoproliferative diseases. The lymphomas are malignant one, cancerous one. Otherwise, we have other non-cancerous lymphadenopathies like Castleman's disease and all. And if that is the case, we need to examine the liver and spleen as well. So this completes your lymphatic system examination, right? So most nodal basins are inaccessible, right? Retroperitoneal lymph nodal area, mediastinal nodes, they are inaccessible. You cannot just palpate. Only imaging comes to your rescue. In the head and neck, of course, we have the neck nodes, the cervical nodes beneath the mandible and the neck, anterior posterior part of the neck. In upper limb, trunk and the breast, we have the axilla and rarely epitrochlear nodes. In the lower limb and the genitals, we have inguinal and popliteal nodes. So these are the basins. So now coming to the lymphatic system, what exactly it does? So it is nothing but a fluid which can have antigens, which can have bacteria and other fluids from the connective tissue. What it does, it drains, it takes all the fluid along with it and drains into the larger veins, right? So what are the components? Inside the lymphatic vessels, we have lymph nodes as stations, and we have other accessory lymph nodal tissues like tonsils, spleen, thymus, etc. Right? So here you can see from the connective tissue, this is getting collected, going upwards to the lymphatic capillary, and they are very fragile. If I give you an example, in cases of strangulated hernia, the lymphatics are the first ones to get compressed, followed by vein and then last artery because of the elastin content. So they are very fragile, very thin walled, right? So these are the lymphatic capillaries going to the lymphatic system. Then they go to the lymph node. Then entire half of the body, as you see here, all these go to the thoracic duct. So apart from this area, the right side of the arm, right chest, right head and neck region, this is drained into the right lymphatic chain. But in the left side, entire thing is drained into the thoracic duct, which drains in the great veins, the junction of internal jugular vein, left side, and left subclavian vein. This is the reason that you get from GI, you get left supraclavicular node known as Burkock's node, right? So coming to the different basins, we start with the head and neck. That's the cervical group of nodes. So we have level one. Level one is this area, right? Submental, submandibular. Then we have upper jugular. So upper jugular goes here. Digastric muscle is like this. This is the mastoid here. Level one. Level 2, 3, 4. 5 is this area, the posterior triangle, right? Then apart from these, we have level 6, which is
which drains the thyroid, and level 7, the upper mediastinal part. It cannot be palpated, you can just percuss it if they're enlarged. Apart from these nodes, we have tonsillar, pre-auricular, post-auricular, and I'll show you the video also. So these are the different areas where tumors drain, right? A thyroid malignancy rarely drains to the level 1 nodes. A CA tongue will drain to this area, not to level 5. So farther the nodal basin is, chances of spread is lesser. Axillary node, we have 5 groups. We'll discuss in the videos. We have the lateral one, along with the, you can say the lateral arm, along the humerus. The central one, you can palpate it against the chest wall. Then behind the pectoralis major muscle, this fold, anterior axillary fold, you have the pectoral nodes, and just anterior to the latissimus dorsi fold, you have the posterior ones, and you go up towards this area, directing towards this area, you get the apical nodes. Similarly, with inguinal lymph nodes, we have got 2 groups, superior, superficial, and deeper nodes. Superficial drains skin below the umbilicus, outer half of the anal canal, right? You remember like this. Lower down, and again lower down in the anal canal, right? Outermost part of the anal canal. Whereas the deeper nodes drains the glands, right? Superficial one, they are arranged in a horizontal group and a vertical group. The deeper one, they lie deep to the cribriform fascia, medial to the femoral vein. Now, embryologically, all these lymph nodes, they arise or they develop near a vein. That is why they drain into a vein. So whenever you have a vein, you will get the chain along with the lymph node only, along with the vein only. Right? So these are the 3 areas. I'll show them. So how to start inspection? If they're very large, it is evident during inspection itself. Particularly, if there is asymmetry. If there is infection, the skin, overlying skin may be red or warm. You can even notice discharging sinus, particularly in cases of tuberculosis. And if it is a large mass, so most likely it is a conglomeration of lymph nodes. It's not a single one. So how do we palpate? Starting from the cervical one. So we use this area for palpation. We make the patient sit and we go behind. So this is how we palpate. So these are the areas. Level 1, submental, submandibular. 2, upper jugular, mid jugular is 3. 4 is lower jugular. Then the level 5 here, posterior triangle, and central compartment, level 6. So you are palpating the level 1 nodes. Submental, submandibular. This area will drain into this group. This is pre-auricular, post-auricular, and if you are palpating bilaterally, never ever press this carotid region. Otherwise, we'll be pressing both the common carotid arteries together. So this infraclavicular group. This is on the left side. Same thing. Pre and post. Level 2, 3, 4. This is the level 4. This is the level 5. And again, we go to the infraclavicular. So this completes your cervical group examination. So you see patient sitting, examiner goes behind. Coming to the axillary group, as you can see here, this group has around 25 to 40 nodes, right? And the area of drainage is arm, this area, and upper part of the thorax, breast. So what we do if we are palpating the anterior group, so anterior group is just behind the pectoralis major muscle. So the palm should face outward towards the examiner, and we should be examining from front or lateral, not behind. I'll show you here in the video. So the palm is facing outwards. This is the pectoral group, just behind the pectoralis major muscle. Now, along the chest wall is the central group. This is the lateral group along with the humerus, you can say. Then this is the posterior group along with the latissimus dorsi. Now we insulate our hands upwards to feel the and press this to feel the apical groups. And how does it feel? How does these lymph nodes feel? So if you roll your hand or the palm over the knuckle, you will get a similar finding like this. The nodes will slip unless they're very large and fixed. Now coming to the lingual nodes, here the patient is lysopine. You need to look for any other swelling, any neuralgias, any ulcers. You palpate it along the inguinal ligament. First, you need to delineate where exactly the inguinal ligament is, and there lies the horizontal group of the superficial inguinal lymph nodes. Then you mark the pubic tubercle, go 3 centimeters laterally, and then the vertical group lies, right? Like this. So this is the anterior superior iliac spine. This is the pubic tubercle. This is the inguinal ligament. So you palpate here, you get the horizontal group of superficial inguinal lymph nodes. Now, because of repeated infections, the cutoff for these lymph nodes is a bit different from other lymph nodes. I'll discuss that also. And now coming down, 3 centimeters lateral to the pubic tubercle, the vertical group. So these are the two groups. Now, what do we look at? The size. Because we have got different cutoff or sizes for different lymph nodes. For inguinal region, most of the textbook they write 2 centimeters because there is repeated infection of that area. Otherwise, you may feel that most of us have these lymph nodes palpable, the submandibular one and the inguinal ones. 1.5 centimeter is the cutoff. One more value is there for the inguinal group of nodes. I am talking about the superficial group, the horizontal and the vertical link. All these are superficial, right? They are beneath the fascia of Camper, right? But the deeper one, which is beneath the cribriform fascia, lying medial to the femoral vein, they are not readily palpable. So even they are 1 centimeter or more in size, that is abnormal. For others, it's 2 for the superficial group. Now the rare groups that we can palpate, rare nodes like epitrochlear propagator or even subtrochlear, any size is abnormal, right? A bottom size, what we know, whether they're tender or not. What is the shape, whether it's rounded in shape, where exactly it's located and in relation to which vessels. What is the consistency? It is soft, firm, rubbery, right? Usually if it is firm to hard, we should think of malignancy. What about skin surface? If it is an inflammatory node, there is an abscess, the skin will always get involved and you can have some inflammatory findings if you look at the skin. Now mobility, whether it is fixed to the underlying structure or not, that because that is very, very important. Now there are two things. As surgeons, if someone is asked for a biopsy of the node, you need to see if the size of the node, if the size is say 3 centimeters in the supraclavicle region. So, and it is very difficult to take out that particularly under local anesthesia. So we can take a chunk. If you are thinking of lymphoma, suspecting lymphoma, try to put 1/2 in formalin, other half in normal saline, right? With incisional biopsy that can be done. That's what I'm trying to say. Smaller node, you just take out the node. Now, with PET scan, there is a problem. They'll say that there is an uptake in the, say, axillary node. But when you try to palpate and do ultrasound examination, it's very small. So even smaller nodes can take up the FDG PET. But it's very difficult to take that out. So unless it is visible on anatomical scan, like ultrasound or CT scan, you will not be able to take it out if it is a smaller node. Because PET uptake can be there in very small nodes, which is very difficult to palpate and unless you are able to palpate that, you will not be able to see during dissection. So this is important. Now, apart from this, we have 2 more entities in the lymphatic system. One is lymphangitis. So that is nothing but inflammation of the lymphatics. Lymphatic will drain to a node, right? So you can feel cord-like structures, which is red, thick, and patient can have systemic features as well, right? Second is lymphedema. When there is blockage in the system, we have lymphedema. Clinically, what we'll get a swollen limb. To start with, the edema is pitting, but due to gradual fibrosis, the skin gets thickened. There's a lot of fibrosis in the subdermal area also, and it becomes non-pitting edema. and there is something called a stemmer sign. So if you have a limb edema and not able to make out that this is because of chronic venous insufficiency or because of lymphedema, this sign helps you. In venous diseases, rarely the forefoot, the dorsum of the forefoot is involved, right? So most likely we're dealing with lymphedema. And initially, many years back, this sign was demonstrated by a physician, wherein he tried to pinch the skin of the dorsum of the foot. If you're not able to do so in a swollen limb, most likely it is lymphedema. But nowadays we have got gold standard like lymphoscintigraphy. So with this, I conclude this session. Any questions?
Thank you so much. Any questions? Yes. Anything is covered on the lymphatic system extensively, clearly. And you've been hearing about the generalized lymphadenopathy, the terms have been made very clear now. If there is any question, you should be very happy to answer. Any question from the online attendees? Surya, you can, if there is any, you can note it down. There is? Thank you very much, Dr. P. We'll move on to the next session. We're ready with that. I'll invite on dais Dr. Ratna Chopra and Dr. Sahaj to stay back. Dr. Shamlal is joining us from AIMS Bhopal virtually. Please provide him I hope he's there. And I'll also request Dr. Anubhav Vindar, who's here, to join us on the dais. We'll have a talk towards the end as to how to examine the account. Both of you, please. And the first presenter is Dr. Rishikesh. She's going to present an abdominal lump. Dr. Rishi, have you loaded your presentation? Yeah, kindly start with it. Big round of applause for Dr. Anubhav Vindar, the Professor of Surgery at Malanadar Medical College. Thank you, Dr. You can. Dr. Anubhav Vindal is also the college tutor for the Royal College of Surgeons of Edinburgh. And together we try to do academics to the extent we can, and we try to have some programs that can get linked to the Royal College of Surgeons of Edinburgh. So please stay tuned in. And he is a very passionate teacher. You would find as he makes his presentation that there are many essential aspects of examination of abdomen that don't get covered in the day-to-day presentation. So it's a very useful talk and you should pay attention. So, your case, you can start, Rishi.
Good morning to everyone present here. My name is Rishikesh. I'm presenting the case of abdominal lump. Here's a 64-year-old gentleman, resident of UP, presents to the surgical OPD with chief complaints of abdominal pain, mainly to the epigastrium since 6 months, and abdominal swelling since 6 months, and vomiting since 3 months. The history of presenting illnesses, the patient was apparently normal, well, six months back. The abdominal pain was insidious in onset, persistence, localized to the epigastric and umbilical region, dull aching in nature, non-radiating and non-migrating, associated with vomiting. Since 6 months, 3 to 4 episodes per day, usually 6 hours after the food intake, projectile in nature, non-bilious, containing mainly the gastric content without any blood tension, which has increased in severity and frequency since 5 days. The abdominal lumps, the patient also complains of abdominal lumps in 6 months, insidious in onset, initially small and localized to the epigastrium, now has progressed to the involved the umbilical region. The history of weight loss, approximately 15 kg is significant. And history of sensation of fullness after meals, history of loss of appetite. Now, since 5 days, patient with history of non-touch of stools and flatus. Among the negative history, there's no history of vomiting blood, or there's no history of bleeding per rectum or passage of blackberry stools. There's no history of fever. There's no history of yellow discoloration of eyes or urine or skin. Among the past history, patient has no medical comorbidities, is no history of any similar episode in the past, no past surgical history, and no drug history. Personal history, patient is a known chronic alcoholic and a smoker, consumes mixed Indian diet, normal bowel and bladder habits before the illness, and has a normal sleep-awake pattern. There is no cancer-related deaths among the family members.
So may I present, my, continue, sir?
Anything to ask so far? Any pass?
No, I just want. You describe the pain, right? Pain should be typically described as that Socrates, site, onset, character, right? Aggravating factors, relieving factors, what is the time, what is the extent, what is the severity?
Yes, sir.
So you give us the aggravating, relieving factors.
Yes, sir. Actually, there weren't any aggravate.
So you say there are no aggravating. That whole Socrates has to be described.
Yes, sir.
Perfect. Proceed, please. Reasonable estimate, reasonable description, and as you can always add on, right? And speak slowly so that it's clear, please.
Come to the general physical examination, patient was conscious, oriented to time, place, and person, not alert. Mainly because the patient was dehydrated, the performance status was 50 according to the KPS, and the patient was underweight with BMI 17. Vitally, patient had tachycardia with regular low volume pulse, normal character, with no radiated delay. Patient was hypotensive with BP being 96/54 in the right arm supine. Rest rate was 15 beats per minute and saturation was well maintained in room air. Among head-to-toe examination, patient was had pallor, icterus. There was no clubbing of pedal edema, and patient had temporal following, loss of buccal fat fat. Moving on to the system examination, per abdomen. The patient was examined in supine with arms kept on the side and exposed from mid-chest to thigh. There was a visible epigastric and umbilical fullness. Umbilical was shifted downwards and inverted. There was a discoid scar present in the right lumbar region, probably due to a healed abscess. All quadrants move equally with the respiration apart from the epigastrium and umbilical region. There was a visible peristalsis from left hypochondrium to epigastrium. The visible swelling moves with respiration. There was no swelling or cough impulse in the bilateral hernial side. Palpation, the inspector findings were confirmed that there was no local relative temperature, no superficial tenderness. Abdomen was soft, distended. There was no guarding rigidity. There was a single firm intra-abdominal lump because it was moving with respiration. It's palpable in the epigastric and umbilical region, globular in shape, of approximately size 15 centimeter in diameter, with irregular surface with no fixation to the skin. The lower part of the liver was palpable, much lower than normal, which is 8 centimeter below the right costal margin, which is firm in consistency. Percussion, the tympanic node over epigastrium was present, indicating the distended stomach. Dull node over the lump. The liver dullness, the upper limit, the upper border was, there was a dull node of 4 intercostal space, and the lower limit was 8 centimeter below the right costal margin. There was no shifting dullness or fluid. This is the picture posted under the patient, showing the lump, and on the right side, the lower border of the liver compared to the right costal margin. Auscultation bowels of the absent, there is a suckle splash present. Auscultative percussion revealed the greater curvature of the stomach to be below the umbilicus. On digital rectal examination, the inner tone was normal. There was neither fecal stain nor blood stain. Rectum was collapsed. The mucosa was free. The other systems were unremarkable. I conclude with a summary. A 64-year-old gentleman who is a chronic alcoholic and smoker, present with abdominal pain, abdominal lump associated with projectile vomiting, anorexia, loss of appetite, weight loss since last 6 months, with pain and vomiting aggravating in the last 5 days with non-presence of stools and places. On physical examination, patient's nutrition is poor with presence of pallor and icterus, tachycardic, and dehydrated. On per abdomen examination, there was fullness in the upper abdomen with umbilical displaced inferiorly, visible peristalsis characteristically moving from left hypochondrium to epigastrium. The single globular palpable lump of size 15 centimeter, the region of epigastrium and umbilicus, which moves with respiration, with sufficient flap present, with greater curvature of the stomach below the umbilicus, with no other palpable lump with hepatomegaly. I like to conclude with the provisional diagnosis of query metastatic CA stomach with a gastric outlet obstruction.
Can you go back to the picture of the lump, the abdomen that you showed? Now, we got a little confused with your liver. Now, you mentioned that it is 8 centimeters below the costal margin, and it's in the 4th intercostal space. So, how much did it come to, the liver span?
So, the upper border was 4th intercostal space.
No, we don't know. You must have measured, no?
Yes, sir.
So, how much is the liver span?
So, around 14 centimeters.
So, you should have said that. That also is important. How do we measure it, right?
Yes, sir.
So for us, that is what is important.
Yes, sir.
And so that if there is hepatomegaly, which you mentioned, and then describe the liver properly. So what was there in the liver? What did you mention about liver?
So the border was firm consistency without any nodularity.
Border is just well.
Yes, sir.
Border doesn't have all these elements. The surface is nodular, consistency is
Firm, sir.
firm, non-tender.
Non-tender. It was non-tender, sir.
Please carry on. Both lobes are enlarged or it is just the right lobe?
The right lobe, sir, the right lobe,
Yes.
firm in consistency, non-tender, with regular border, sir.
Sharp edges on regular borders. And for this you mentioned,
So this is a lump occupying.
this too moves on respiration. It is moving on respiration, no?
Yes, sir.
I'm just trying to find out what you've spoken.
It moves with
And you could get above this swelling, this one.
Yes, sir.
Yes or
Yes,
no?
yes, sir, yes, sir.
What is the normal span of liver? You said it was 14 centimeters, and you said it's much enlarged than.
So I don't know the exact thing. I said it's enlarged because normally the
No,
liver.
forget that. Answer the
What's the normal span of the liver?
So I don't know the exact.
It's about 34 centimeters, 12 centimeters. So it's not so enlarged that you're describing. Okay.
It was in any case not required.
He's made a guess here.
Right.
Because from fourth intercostal space to 8 centimeters below, it has to be enlarged.
It is a large one.
Yeah.
So it's no.
So you should know the normal span of the liver.
Yes, yes.
So you read about it 9 to 11, 9 to 12. So don't speak extra.
Okay, sir.
Oh, I think it is very, very large. We're not having a conversation, we're having a presentation. Important, no?
Yes, sir.
Yeah.
Also, you mentioned something, loss of fat pad at the temporal region. What has got to do with this?
So I said there was temporal hollowing and loss of buccal pad of fat, just emphasizing that.
So then
we
you
are
treat, that's okay. So I'll read that. Yes, Dr.
So I'm going back to the clinical examination of abdomen. You said that his BMI is 17, but you made no mention, you said, that you made no mention of all this fullness in the flanks. What do you think it is because of? Is the rest of the patient emaciated and there is only fullness in the flanks, or is there free fluid in the abdomen with the transversely stretched out like this?
Ma'am, there's no free fluid in the abdomen as per percussion, ma'am.
Just that either the abdomen doesn't have the tone you're looking at. Okay.
So now you talked about the lump and you talked about lower border of stomach. What I'm confused about is that is what you're palpating stomach, or is there a separate lump also?
You can answer that. Is it stomach only according to you?
You have
I'm
talked about,
I'm going towards the stomach itself.
But that's the only lump you're talking about?
Yes, sir.
so then you should not talk about the lump separately and then that I can feel the lower margin of the stomach here and.
Just say the lump's low.
So lump and loop have to be very.
Don't make it an organ to begin with.
And if it is if it is stomach, you were saying that you could reach the upper margin of the lump.
Yes, from the heart, the firm lump.
How much
inside-
part of stomach lies behind the costal margin?
What was the upper margin according to you?
So as shown, this is the upper
Can you
margin.
take the cursor? Sure.
This is a part of
No, one
stomach.
minute. Maybe he's using the wrong terminology.
The firm consistency lump which I felt the upper border was this, sir.
No, I mean, here, maybe the stomach has come down, it's possible, but mostly, stomach is higher up, no? So you're not able to get there. With lump, you're probably referring to this part where you could get above. This is what I thought. No, this is not. The upper parts are not the lower part, there's a border above. There's no line over there. Yeah, this. Above that, maybe you had some space, but here you can't be finding a space. Abdominal examination will be discussed in detail, but you try to stay where you are. Unnecessary words should not be used, that's what creates confusion. Okay, any question?
You put your diagnosis as metastatic carcinoma stomach. So what in the history and the examination made you think about it being a metastatic disease?
So one, it's a 60-year-old.
I'm sorry, you'll answer that question and then please answer.
A 60-year-old male, sir.
That does not make it metastatic. You're talking
Yes, sir.
about
The
metastatic.
patient did not, on examination, patient was icteric and there was hepatomegaly with the palpable lump. So I'm going towards the probably the hepatomegaly is due to the mets. That was one of the reasons, sir. And
What is a metastatic liver like on examination? What are the characteristics of a metastatic liver?
Is the surface smooth?
No, sir. Surface will be smooth, will be red.
Before that, I'm sorry, we're speaking, I'll just butt in. Your diagnosis, the way it is written is creating that confusion. You don't have to start by using, I told you in the beginning also, don't be casual about terms. This is, how old is your patient?
64.
64-year gentleman with a lump in the abdomen, right? Likely to be carcinoma of the stomach with hepatomegaly, which can be metastatic. That would have kept you balanced and protected.
Yes, sir.
How did you write it? Metastatic carcinoma of the stomach. It may be just an enlargement of liver or with proptosis, as he mentioned, with a very mild enlargement or congestion. So I'm not trying to say it is not. But then that question, Professor Bindal wouldn't have asked you directly. Why are you saying metastatic? Because that catches the eye of the examiner. Dr. Bindal, carry on, please.
So you said because of icterus, you are thinking in terms of metastatic disease of the liver. So how does metastasis lead to icterus?
So here the icterus is the late presentation because the patient himself did not notice it.
What is the mechanism which leads to icterus in terms of metastasis to the liver?
How would metastasis to liver produce jaundice?
So restriction of intrahepatic bile radicals.
So will it happen sooner or later?
So later, sir.
Would that be a liver which is studded in metastasis or a liver which is very fine otherwise? You described a very smooth, nice looking liver.
Yes, sir.
So if there is jaundice, why do you think there is jaundice? Suppose there are no beds in the liver. It's a cirrhotic liver enlargement, right?
Yes, sir.
So why do you think there is jaundice there? What could be the other cause of jaundice?
So that would take us to a periampullary type.
No, wait,
No, you can't change your diagnosis.
very improved.
Can't move your goalposts. The primary diagnosis remains the same. Can there be any other mechanism which can give rise to the same presentation in absence of florid liver metastasis?
And if you don't know, say you don't know, so that you can answer. Don't waste time, please.
Can there be extrahepatic obstruction?
Yes, sir. The lump is
Not just by the lung, but the presence of lymph nodes.
What is common, a lump or the lymph node?
lymph node.
They can be pressing on this could be an obstructive jaundice. That is what you should have been forthcoming with. Rather than calling it a metastatic carcinoma gallbladder, this is not always the right way to approach it. That is why you got into trouble. You can't be casual and suddenly you jump to periampullary. I don't understand how did it firstly come to your mind. Just because the patient is jaundice won't make it periampullary, right?
Yeah, okay. You said succussion flash. What is succussion flash?
So in case of a gastric outlet obstruction, if the contents of the gastric gas tubes we can elicit it if it's completely
Okay,
filled.
how do you perform that?
So the patient lies supine and we keep the patient NPO for at least 3 hours. We keep the stethoscope in the epigastrium and we hold both the hands with the thumb. Then we
Okay, that's fine. And you said local rise of temperature. Why do you look for, where do you look for local rise of temperature in that room?
So there wasn't any, but it's
No, I mean,
Suppose you were to look for it, where would you look for it? Everybody is saying it since yesterday. First day we are down the case. I think somewhere you get infected with this thought. It's like moves on degradation but doesn't move on position of tongue. Every thyroid swelling doesn't move. That's the wrong way to put it. So answer the question. Where did you look for local rise of temperature?
so all quadrants.
What for what? There is absence of liver. Will it produce local rise of temperature?
No, sir.
There are 3-4 layers of muscles before it comes to the surface. So this is something which is not very relevant anymore. It's used very casually. Next. Dr. Anubha, Dr. Ratna.
I think it is very important to elicit correct findings because things you've not been able to explain because this lump, because you're saying upper border is palpable and it is firm and it is dull. Probably this must be the lymph nodal mass. And the stomach must be lying somewhere above and maybe behind it with some kind of a succussion slash and obstructions. I think your clinical findings are wrong. That's why.
Suppose it is right. Let's give you the benefit of doubt. It still can be explained. You can palpate some. There can be a growth of some. There can be succussion slash obstruction. There is a presentation in gastric outlet obstruction. The jaundice can happen due to metastasis to the lymph nodes. That is understandable, no confusion. But things are missing in which you could have added on to make it relevant. I would call it a lymph node mass also. It depends on how you present. It's your case, you examine it, but you're not able to defend it. That's why they're all asking you different questions. You getting what I'm saying? To jump to one conclusion based on inadequate and suboptimal examination leads to these problems. You must understand. You said gastric outlet obstruction due to malignant cause or the benign cause? Naturally malignant cause. What is typical of a malignant outlet obstruction? As in, what type of vomiting do you get?
The projectile vomiting.
You get it in malignant obstruction. See, malignant obstruction, except in the early phase, don't produce projectile vomiting. In fact, I will go to ask you why.
Because of the involvement of the muscles, it won't.
There you are. They don't have the power to push it that way. So gradually it just becomes a drooling over. They're not able to vomit like in idiopathic pyruvate hypertrophic stenosis, where you have classical or post gastric ulcer kind of a picture. Initially, when the cancer is not yet spread or infiltrated into the muscle. So it in fact is one feature which was not right. So what did you do? You made a classical case of a gastric outlet obstruction in history. You then got disconnected. Then you made a classical case of carcinoma stomach by all the features that you can have in a stomach. And then you use that liver to be the metastatic condition. And you created a case. This is what everybody's trying to do. That's why those questions keep getting asked. Your finding should be justifiable. If I examine it, I know whether it's a lymph node or a stomach. Stomach can be palpable. Either due to cell being a diseased organ or distally obstruction being there, because you did auscultal toe percussion, right? Where did you find was the lower border of stomach?
It's just below the umbilicus.
So one thing it proves is that it is stomach, right?
Yes.
Only then you will be able to find it if you're trying to say that, but you should be able to defend what you're saying. That's why these questions are being asked.
Okay. Now this patient comes to your OPD. How do you manage this patient?
So I would, if the patient is dehydrated and I'm going to the lateral obstruction, patient will be having dysheteronemia. So I would resuscitate him first, sir, with IV fluids and probably.
What sort of dysheteronemia do you find?
So the characteristic that we find is hypochloremic metabolic alkalosis with paradoxical aciduria with hypokalemia also.
So what is paradoxical aciduria?
So since the body has a metabolic alkalosis, now the body tries to push out bicarbonate. Along with bicarbonate, sodium is lost.
Is that so? The body is, the patient is alcoholic. So it's trying to push out bicarbonate to get rid of bicarbonate. So that's why you get aciduria. It's trying to push out bicarbonate.
I was able to complete that. The bicarb gets pushed out along with the sodium follows. Now patient is in dehydration and more water follows the sodium. So the hemostasis to achieve euvolemic is more important here. So the body tries to absorb sodium. Now to exchange sodium first, potassium is lost.
Okay.
After potassium,
I'll give you the answer. It is basic because the patient is dehydrated. So there's secretion of aldosterone.
Yes, sir.
Now aldosterone what does aldosterone do is that it conserves sodium because water cannot. So sodium is a positive ion. It wants to conserve sodium. So it lets go of hydrogen ions. So that is the basic mechanism. Nothing to do with want to push out bicarbonate and all that kind of stuff. Nothing to do. So what fluid will you give?
So renal lactate is recommended.
No, you'll give. Why not renal lactate in this patient?
Yes, somebody can answer me. Somebody will speak. Yes. Can you speak? Stand up and speak, please.
Lactate in renal lactate will be converted into bicarbonate in the liver and it added fat to the metabolic acidosis and it causes alkalosis.
That should be good for acidosis, no?
But the patient is in alkalosis. Okay.
So there you are.
Right. So it is what does the water body want? It wants water and it wants sodium. So that's what we got to give. No regular lactate, it's normal slide. Right?
Right. Dr. Rupa, any question?
What is the difference between acute dilatation of stomach and chronic dilatation?
He doesn't know.
No.
Proceeds. How do you proceed in this case? But let me tell you.
So acute dilatation of stomach is a surgical emergency where the patient will have large volume. It happens in patients who are extremely sick. You said your patient was in shock. And these patients will pass large volumes of blood-stained fluid, which can become a reason for shock. In chronic dilatation, you'll have all this visible peristalsis, which you will not have in acute dilatation.
Okay, so you give IV fluids. What else will you do?
All right, you should proceed, clinical case will stick to, or you optimize the patient. Those parts will come again, we'll discuss them again. How do you approach this case now?
So I'd like to indicate,
Suppose your diagnosis by any means, it is not very difficult to consider this to be carcinoma of stomach. We are not surprised. This is not a very difficult thing to imagine, but still you should be able to answer all those questions. How do you proceed?
so I'd like to investigate further to confirm a diagnosis. Or by doing an esophageal endoscopy, sir.
That's the first test you will do?
Yes, sir. Because, so since the patient is in obstruction, even endoscopy will confirm.
1 minute.
And be
Please relax now. Is that what you really do? He said you patient has come to your OPD. You have a patient with a lump in the abdomen with suspicion of gastric outlet obstruction. All things taken all right. IV started, nasogastric tube put in, all done. Is that the first investigation you do?
The first would be X-ray, abdomen, ultrasound.
Is it a very casual thing that you will do? What do you do normally?
It's been hammered in. What is the next session of your clinical examination?
Yesterday, you don't attend the classes, so this is what happened. From day one, we've been talking it. That's why I'm getting a little worked up on this because we've talked about it at length. How can you put in a scope without having known what is it? You put in a scope and there's nothing inside, it's not even stomach, then what do you do?
You will not see anything also because it is full of fluid.
You
and
know what you
blood.
do, why do you suck out? But then you may not have the disease inside the stomach. So do you do invasive investigation first or do you do a non-invasive one?
Non-invasive.
And what is an X-ray going to tell you? In a patient with gastric outlet obstruction, there's a lump there. We talked about it yesterday at length. It was discussed.
Ultrasound. Okay?
Yes, sir.
What do you look for in an ultrasound? What do you want to see on an ultrasound?
All right, so your findings are correct. Ultrasound is being done. So what are you expecting in a patient who's got carcinoma? You said yourself diagnosis. So what do you expect to see on us? And don't get worried. It's all right. If you don't know,
This is a teaching session. It's not
we don't take exams here. This is a teaching session. What would you see? You see what are the diagnosis?
What were your clinical findings, your
You could
examination?
find the lump
You
is
said
there.
there's a large liver. Ultrasound will, what will it tell you?
It will tell more about the liver.
Okay,
There is a
you stand. He's probably puzzled. So think for a moment. We'll give you some break. What do you expect to see now on us? First, you know the organ of origin of this. Agree? Next. Properly, please.
We look for thickening and mass arising from the stomach and or any other side, any other place where the mass is arising. And we will see the distal bowel that is dilated or not, and any free food collection present in the abdomen.
And you'll also look for those lymph nodes and that liver that they're all talking about. You'll probably get a diagnosis on ultrasound. That should be enough actually. You agree or no? So I'm giving you a bleeding time. What next do you do? Ultrasound suggests the disease is in the stomach and there is a liver enlargement which has some metastatic deposits that were not clinically palpable. It can happen. What do you do now? Next.
So with keeping, rather than suggesting a mass arising from stomach and keeping in mind the obstruction, like now I would like to do the endoscopy, sir.
Okay, to confirm your diagnosis.
Confirm the diagnosis, morely since the patient is not fit, like we have to relieve the obstruction. Endoscopy, like we can see the little mass, we can see it, take the biopsy and even do a perform a stenting. That is my main reason why I'm pushing towards EUS. However, we have to go.
What was EUS?
So it's an endoscopic ultrasound.
And why are you pushing towards it?
Since the patient is in obstruction, so it
So
could
is
be.
that the endoscopic stenting is the first step that you will go for?
So since if the
The
patient.
patient has a BP of 86, you described it,
Yes, sir.
yes? You'll optimize the patient first.
Okay.
First, you need to have a diagnosis in your hand.
Yes, sir.
Then you'll think about various options. Why would it need stenting all the time? It may need surgery and you may actually get rid of the problem. But you have a problem in the form of metastasis. So you would like to first rule out, establish the disease. If you don't have a diagnosis, how are you going to proceed?
Then CT whole of them.
I was a little concerned because you're trying to defend what you said earlier by saying, sir, that's why I was pushing towards it because patient has obstruction. You have no diagnosis as of now. You'll put in a stent. So that's the wrong way to approach it. That's why I corrected you there. Ultrasound, all right, to know the organ of origin. It's a hollow vessel, that is stomach. Now upper GI endoscopy to get the tissue, to get a diagnosis. It is cancer, treatment is different. If it is non-cancerous, it's possible that the jaundice is due to something else. You find out the etiology for jaundice also. You find out if it's hepatic or post-hepatic. You find out if there are lymph nodes. You will do blood investigation. You get everything done. You don't stent a patient first thing in the OPD as Dr. Rai asked you, the patient has come to the OPD for you. You use some common sense, the way you should approach it. What next would you do? Anybody? The lady there? Okay, Surya, what you can do?
Sir, after establishing the diagnosis of CA stomach, we would I'll go for CCT for the thorax and pelvis. We look for the nodal status and any metastasis elsewhere in the body, lungs and liver. And if there's any doubtful lesions in the liver, which can be suggestive of metastasis, I would like an image guided FNA or biopsy to be taken from there to prove my case.
Okay, suppose the ultrasound shows what you're looking for. Would you still need a CT or you're okay with it?
I would still need a CT because I will delineate the lump and
No, you got an ultrasound which shows it to be a stomach lesion. Then you did an endoscopy which shows it to be an adenocarcinoma. And you have metastasis in the liver which you got with the ultrasound guided FNA. Would you still need a CT or you can stop there?
once I think.
What is the stage of the
It has become metastatic.
So how is CT going to change your management? Same thing you mentioned about workouts, no? If it was positive, what would you have done? Would you do all this drill or it will be easier?
No, sir.
You can answer.
Then it would have been easier. If it's workouts not positive, it's metastatic disease.
If you can do an FNA and confirm. Yes, sir. Pass.
Sir,
It is on. Don't fiddle.
in case if it is metastatic, then or not resectable, then we will do an X-ray. Surgery will be changed. In case if it is operable, then we will get gastrectomy. Otherwise, we will go for X-ray.
Gastrectomy in a metastatic disease.
In case if it's resectable, not metastatic.
No, resectable is different. Metastatic is different.
Then
Resectable means where you can get a clearance.
that's the only. Fitting the
Dr. Malik made a presentation on resectable and operable, so I think we're repeating it. If it is a metastatic disease, do you think in terms of surgery, carcinoma stomach? That is what I.
Generally not, sir.
Then why are you trying to make an exception here?
FJ we can do for.
No, that is a different thing. So you can do something for relieving the obstruction or doing the enteral nutrition making it possible.
Yes.
That's what you are saying?
Yes.
So, Dr. Anubhav, sorry. Last few questions.
Okay, understanding that this is an advanced disease and the patient is pediatric. So how best will you evaluate this patient? What are the things that will be in your mind while deciding on the palliative therapy of this patient?
So once you have established relieve the obstruction, start enteral nutrition, with some chemotherapy can be started. So
Relieving the obstruction.
once we relieve the obstruction, we can go ahead with
How
adjuvant.
will you relieve the obstruction?
So if it's once the CT is there, we have once it's.
We have already said CT is not required. It is metastatic to the liver on ultrasound.
Yes, sir.
On endoscopy, you have found that there is a growth. You have sampled it. It is turned out to be adenocarcinoma of the stomach.
Yes, sir.
So we have discussed that CT is not required because it is already metastatic. Now what?
So if it's resectable, we can do a gas.
1 minute, you're wasting time. Somebody else, because we can't waste time. We have talked about no surgery right now. We already crossed that point. You came back to again doing some kind of a resection.
It's palliation.
We are talking about palliation now. If you know the answer, say you answer that. Otherwise, say I don't know. You don't waste time. Don't give absurd answers. Yes. So Surya, what do you do? Answer the question that
So
was.
we can go ahead with stenting, sir, for palliation.
Okay, one palliation is stenting. What else?
We can do a gastrointestinal, we can bypass.
If the patient is operable. Resectable is when you can get an R0. Operable is any patient who is fit for anesthesia. And then the surgery would depend on what you want to do. And I'll cut it short so that we can able to it. Dr. Anwar has asked a very pertinent question towards the end. Palliation is symptomatic relief, right? And you talk about resection. In colorectal, it's a different story. How would you palliate? Maybe you will answer. He has answered partly. This is the same thing you're doing, or you can do FJ at least and provide. Importantly, the case will be discussed in the MDT and you'll take a call, like we've been doing since yesterday and day before yesterday. That is why it is important to attend sessions. We have kept a provision of virtual attendance also. You cannot say you were so busy that you did not get a chance to even look at the virtual presentations. I'm sorry I'm being harsh, but we are going back to day one, unfortunately. This is very shabby. You should have done better. I'm sorry. We don't pamper people here. This is training place. You should have gone through the presentations. There was a discussion on cancer stomach also. That's why I'm finding it difficult to repeat the same thing. But you're doing it. I'm not trying to say that you shouldn't have made an effort to present, but prepare and come. You can answer that. Let students answer. Anybody wants to answer that part? Palliation more. So when you're answering this question for future, for you all, palliating the patient as a whole. So nutrition, hydration, taking care of the palliation of the jaundice because he'll have no appetite. He may have enteral route, but he doesn't want to take. Fourthly, pain that is persisting with and take care of his blood pressure. So everything as a whole. And naturally, you need to relieve the obstruction. Correct? Now talk about, you can't give chemotherapy to such a patient with a performance status dropping and nutrition being so poor. So they are not really fit even for a haircut. And you're talking about surgery or resection. So that's not it. Is that clear? Yes, Doctor. So that's not.
When you would do an endoscopy, you will see whether it is complete obstruction or incomplete. If it is incomplete, you may be able to pass a nasojejunal tube, which will take care of feeding, right? And if it is complete obstruction, then you may try some palliative endoscopic metallic stenting there, which will take care of the obstruction as well as feeding. If both these things are not possible, not available, then you will go in for a feeding jejunostomy, and maybe then you will have to palliate obstruction in some other form, either by GJ, and if the patient is very sick, maybe by just either a tube or a yes.
We're trying to make a case out of it because many things were not covered. What kind of a GJ? You mentioned gastrojejunostomy. What kind of a GJ do you do in malignancy?
We do retrocolic.
Take the mic, please.
Normally we do retrocolic.
See, retrocolic more or less disappeared.
The question is very clear. Sir has asked, what kind of GJ will you do in a malignancy? And this is advanced malignancy. Would you go ahead and do a retrocolic GJ in this patient?
I've seen that.
No, he smiles. It's very cute. See, the point is, most of the time the answer is in the question itself. If it was the standard retrocolic, I wouldn't have asked you. Anticolic, most of the time. Most people don't, now there's enough data to suggest either way, it doesn't matter. Drainage doesn't change. Anticolic is better. I don't need to ask you the second question now because that would be wrong because you couldn't answer the first one. And the second question is why? Because you don't want to open up another channel of spread, and it's this anastomosis is going to get involved very soon if you do it. Anticolic and that will little high. Is that okay? Do you remember that?
Yes, sir.
That's about the GJ. But many a times you can manage, as she rightly mentioned, if it is possible, then even the endoscopic dilatation, taking an nasojejunal tube, which is very cumbersome but useful. It avoids the surgery. And these patients are not fit for even feeding, Jason. Considering this patient, how are you going to do feeding? Right? With obstructive jaundice. So it will be percutaneous feeding days, which you can do with some methods which are easier, we'll not go there, because you have two more cases to discuss. But do prepare your case before you come. Randomly, don't just do it, please. And there was enough discussion on this. Go back and go watch it. There's no point in being casual about things. You just very casual in many answers that you gave. And that's why I pressed on this. That's why I thought of that. It is not, this is not how science works. You have to give a logical answer to these questions.
Yes.
Examination of abdomen would be discussed at length, so we are not going there because it will be presented in the video. Maybe you want to ask something?
Well, when you come for a presentation, just go back and look at this YouTube presentations of a similar case and see what the questions are being asked and then prepare and come so that you make a good presentation here. So always come prepared.
Certainly of the scope presentation, they've all been watching it. All of them come, I mean, at least some basics and read. That watching them on YouTube is okay, but do read about it. You're presenting a case, you should take pride in the fact that you came here and made a presentation. Give a round of applause for coming up and presenting. And we move to the next presentation. Do you have a question? You were saying back. Do you have a question? Yes, no. How could you be so silly in asking such stupid questions? Is that what you're asking us? So, did you know that? But I should know that. Yeah.
So I just said, like, could venting gastrostomy be a last palliative measure also to relieve an upset?
1 minute. You tell me what is it first.
So I didn't know.
No, you question it. Could it be an option? No gastrostomy is an option in a gastric cancer. It's just one type of it, Witzel or STAM or venting. That makes no sense at all. The obstruction is distal to where you're going to do a gastrostomy. It's always going to help you. If I block the ring road at South X and I expect you to come to this place, will you reach?
So it's saying if you're not able to place a stent or put in a nasojejunal tube, then gastrojejunostomy he's talked about, internal diversion is always better than external diversion. If you're in the periphery somewhere where nothing is present, then you can place a gastrostomy tube to just prevent the patient from aspirating whatever is getting connected there. That's the last option.
If you can do a gastrostomy, you can do a feeding. Okay, so we have done gastrostomies in the past. Even for esophagus now, they are not common. In most situations, people avoid it. Now, feeding J is considered more easily done, and it can be, closed more easily. It's easier to manage, etc. Any other question?
No, sir.
Thank you. Now, the next presentation is with Dr. Faiz Khan from JNMC and Lincoln. Dr. Faiz, are you doing virtually or are you present here? Virtual, so are you, can you unmute yourself, please, Faiz? Hello?
Yes, sir, I've unmuted my chat. Good afternoon, sir.
Very good afternoon, and it's morning still. Thank you. You can start.
Yes, sir, good morning, sorry, sir. Sir, my name is Dr. Faiz Khan Yusri, and I'm a resident of general surgery. Today I'll be presenting my
slideshow, please, Faiz, if you don't mind.
Yeah, okay, sir. Sorry. Sir, I'll be presenting a case of abdominal lump, and my patient is a 60-year-old male. He's a resident of Lakhimpur Kheri. He's a farmer by occupation. He presented to us with a complaint of generalized weakness for the last 4 months and intermittent pain in the lower abdomen, mainly on the right side for the last 2 months. He also had a complaint of altered bowel habit for the last 2 months and the swelling in the right lower abdomen for the last 1 month. The history of presenting illness. My patient was apparently well 4 months back when he had complaints of easy fatigability at work for the last 4 months, but he can perform his normal daily activities. He has a history of loss of appetite for the same duration, and according to him, his appetite has reduced to less than half of his previous intake. He also has a history of unintentional weight loss, which he tells by is loosening of his clothes, but he has not measured that from the last few months. The patient has a history of right lower abdominal pain, which is insidious in onset and has gradually progressed. The pain is dull aching in nature and is intermittent. And the pain has not radiated, and there is no aggravating factor. and the patient took some over-the-counter analgesics for which he got relieved for his symptoms. And the patient has a complaint of a mass which is approximately 5 into 5 centimeter according to his gestures, and for the last 1 month, and he felt that mass while bathing. And for the last 2 months, patient has a complaint of altered bowel habit, which is in the form of intermittent loose stool on and off. There's also a history of passage of foul smelling black stools, which are foul smelling and which are soft in consistency and are difficult to wash during the defecation. So there is no history of cough, fever, and swelling any elsewhere in the body. Also, there is no history of jaundice, backache, hemoptysis, chest pain or headache, or any history of hematuria or dysuria. Past history. So there is no any history of major ailment or surgical intervention in the past. Patient is a known hypertensive and he is on medication for the last 10 years. There is no comorbidity with the patient, and there is no history of pulmonary tuberculosis or any anti-tubercular drug intake or any contact with TB in the family members. Personal history. So the patient is married and his spouse is alive and he has 2 children, both are healthy. Patient belong to a low socioeconomic group and takes a mixed diet. Sleep is normal, but his appetite has decreased. Bowel habits have altered for the last 1 month, and the bladder is normal. Addiction history for patient. My patient is a smoker for the last 40 years and he had 20 pack years. There is no history of any alcohol intake. Family history, both the parent had a natural death. He has 4 younger siblings, 3 brother and sister. They don't have any similar complaints. There is no history of any cancer or any cancer related death among the family members. There is no history of any allergy to drug or food. Treatment history, the patient has frequently taken analgesics for the last 1.5 months, and for generalized weakness, he took some medication from the cracks, but there's no record available for that. To summarize my history, a 60-year-old gentleman presented to our OPD with a complaint of generalized weight loss for the last 4 months and a dull aching intermittent pain mainly in the right lower abdomen for the last 2 months with associated passage of loose stool. And there are a few episodes of melena in the form of black tarry stools, and a history of from the last 1 month, there's a history of a lump in the right lower abdomen with unintentional weight loss without any history of fever or jaundice.
Thank you. Good history. Dr. Anupam, please.
What is the significance of this generalized weakness and unintentional weight loss that you have spoken about in the history?
Sir, unintentional weight loss can be in the form of generalized weakness, or there can be since the patient has it can be any tuberculosis which could lead to a weight loss, and but there could be a history of fever and ulcer also, and there could be that could be due to any malignancy in the fecal malignancy and or colonic malignancy, which could lead to the general anemia and subsequently leading to weakness and weight loss.
Out of these two, which one is more probable in your case?
So since my patient is old age with no history of constitutional symptoms, it is more probable that he would have any cancerous etiology rather than being a tubercular etiology.
Nice, very nice history.
Yeah, very nice history. Drug history is important, which I don't like this word, visited a quack. Don't say that. Don't demean anyone, anyone's profession. Just say you've gone to a local doctor. We don't know his qualifications. Never do that.
Yes.
What specifically were you wanting to ask when you took the history of no past history of surgery?
Ma'am, there could be a history of cholecystectomy, which could lead to increased chances of malignancy due to the bile being a carcinogenic agent, or ma'am, mostly that, or any abdominal surgery.
What specifically did you ask for in family history?
Ma'am, in family history, since the history points
When you
towards the
said no
malignancy.
similar complaints in the family, what was at the back of your mind?
Ma'am, to rule out mainly any cancer-related etiology in the family or any tuberculosis history
Yeah.
in the family members.
Cancer related and even any history of familial polyposis or anything, right?
Yes, sir.
Any
Yes, sir.
endoscopic interventions that may have been done in the family or in the patient also in the past. How are left-sided malignancies different from the right-sided malignancies?
Ma'am, in the left-sided colonic malignancy, because they are annular, they generally more commonly present with a obstructive type of symptoms, and right-sided malignancy being ulcerative type, they present mainly bleeding and melena.
Rectal malignancies in others also. So how is the diagram rectal malignancy different from the right-sided malignancy?
Ma'am, rectal malignancies.
So you may have frank red blood and rectal
Yes,
malignancy, and you
yes,
may
ma'am, sir.
have calcium
Yes,
mucus along with.
yes, ma'am.
And also left side would have many other people, no, feeling of incomplete evacuation, spurious diarrhea, etc. So you can use that to your advantage when you are making the presentation. Let's move to examination now.
Okay. Examination. I examined a patient in a well-lit room with informed consent with adequate exposure, and patient was lying comfortably in bed. On general survey, patient was conscious, alert, cooperative. He was well oriented to time, place, and person. Vitally, he was stable. There was pulse rate 86, BP was normal. On medication, respiratory rate was 18 per minute, and temperature was not raised, 98.4 degree Fahrenheit. On general survey, the patient build was average and he was nutritionally malnourished. BMI was 17. Carnosy performance status was 80. ECOG is 1. Generalized skin appearance was normal. Tissue is normal. There's pallor present, but there was no icterus. On the cyanosis clubbing, pedal edema was absent. There was no dehydration. There's no veins engorgement, neck veins or any abdominal veins engorgement. There's no gland palpable in the neck. There's no deformity in the spine. On upper abdominal examination, the shape of the abdomen is normal scaphoid. Umbilicus is midline, inverted in central. Flank fullness is not seen. All quadrant are moving equally with respiration. There's no any scar pigmentation on venous engorgement on any pulsatile movement on inspection. There's no visible lump or peristalsis. Hernial orifices are intact. Both the genitalia or genital examination is within normal limit. There's no flexion deformity of hip. On palpation, superficial palpation, abdomen is soft. Local temperature is not raised in all the quadrants. There is no tenderness in the right iliac fossa region. On deep palpation, a mass is palpable in the right iliac fossa on deep palpation, which is approximately size of 5 into 5 centimeter. Globular margins are well defined, and the surface was smooth and the consistency is firm, and the lump was not non-mobile. On straight leg resin test was done, the lump became less prominent, and the skin over the lump is normal. The liver and spleen are not palpable. On bimanual palpation, kidney was not palpable or ballotable. There is no lump or mass palpable on the abdomen. On percussion, the over the lump, the mass was dull on percussion. Shifting dullness is absent. Liver span is 11 centimeter in the right mid clavicular line. The splenic dullness was absent. Normal tympanic note is noted all over the abdomen. Bowel sound are heard normally and they are not exaggerated or absent. On per rectal examination, fecal staining is present with yellow colored stool, no blood tinged. Normal anal tone, there is no growth or any pelvic deposit felt. Rest of the systemic examination being cardiovascular, respiratory, neurological examination are within normal limits. To summarize my case, a 60-year-old gentleman presented to me with a to our OPD with a generalized weakness for the last 4 months and a dull aching intermittent pain in the right lower abdomen for the last 2 months, with the passage of loose stools with few episodes of melena and the lump in the right lower abdomen, with unintentional weight loss without any history of fever. On examination, patient was anemic with intra-abdominal lump of 5 into 5 centimeter, non-tender, smooth, well-defined and firm, and globular with no mobility palpable in the right iliac fossa, with no free fluid, no organomegaly was seen, and the on DRE and proctoscopy were normal. So this was the summary of my case.
So we can move to the next slide also, and we can then discuss it.
Sir, my differentials are mainly three differentials. That could be a cecal mass. More probably is a cecal mass, which is likely of malignant etiology. The second differential could be ileocecal tuberculosis, and the third differential could be retroperitoneal sarcoma.
All right.
Dr. Perez, a good presentation. So can you tell me the points in favor of your first diagnosis? Why we kept a cecal mass, a malignant cecal mass as the first diagnosis?
So, a patient has a history of a melena with and a lump is palpable in the right iliac portion, which is not mobile. Oh, sir, and the patient has a history of melena and a lump, and a history of lump. And on examination, the patient is anemic, and the lump is palpable, which is not mobile, which favors the diagnosis of cecal mass, and the lump has rapidly increased in size, which favors the malignant etiology.
Okay, so basically what you're saying is there's a firm lump which is fixed and which has a rapid increase in size and which is non-tender on palpation and which is associated with signs of blood loss. So all these, considering the age of the patient, make you think that this is a cecal mass of malignant etiology. Is that right?
Yes, sir.
Why don't you specifically say it is a cecal mass and not from the ascending colon? And cecal is a large structure which is partially mobile.
Ma'am, mainly because it is mainly located in the right iliac fossa region,
Okay.
and on the it is on upper margin is 5 centimeter in the mass is 5 centimeter, and the mobility is restricted. Not mobile, though most probably it is a cecal mass.
So maybe others can also take on. Is there an appendicular malignancy that could present in a similar kind of a fashion?
Ma'am, appendicular lump can be a diagnosis, but appendicular malignancy are relatively rare, but they can also present. But in the case of appendicular mobility,
Chronic malignancy, probably cecal, probably ascending, I think could have been a safer diagnosis.
okay.
See, before he gets his mic switched on, in the examination, and I could see that it's all the laundry list that you completed. And many things you just were reading, probably they are not done. Like coming to the leg raising after you describe the lump completely, doesn't make sense. You can start by saying it's an intra-abdominal lump, and that story is over. Leg raising, etc. MBBS students boast of it. Only the examiner will ask you how did you arrive at that conclusion that it is abdominal, and then next question would come, is it intraperitoneal or retroperitoneal, which you covered up later on. So this leg raising, head raising kind of stuff is just a method of knowing what you're going to tell us. Secondly, your description of many other aspects of abdominal examination, I won't go there because Professor Anubhav is going to talk about it. But generally, you can go back. Yes, I'll tell you the points. Glad you're going back so that you can correct. The mass on deep palpation, superficial palpation, that's okay. Smooth, confirm, mobility restricted, it's perfectly okay. When it is 5 into 5 centimeters, you should be very careful in drawing it and showing that it's not just confined to right iliac fossa. It's going up, or it's getting to the lumbar region, which you spoke already. And importantly, that can cover up some part of the answer that you were offering to Dr. Ratna. Next slide. Then you mentioned about something here. On bimanual palpation, kidney was not palpable or not velocical. I mean, what do you mean by this statement? Is the renal angle full or renal angle is not full?
Sir, renal angle was not full. There was no tenderness
After that, the
present.
story is over, sir. And what is palpable is not palpable by. What is ballotment and what is palpating in bimanual? If you know it, you can say that. No other
Yes, sir,
lump.
Yes, sir. Basically, by this method, it was trying to rule out the mass was not relating to kidney, and sir, by menu on ballotment is
1 minute.
okay.
It will be what undescended kidney or unascended kidney?
Sir, it could a right iliac lump could be undescended kidney could be or undescended testis could be a differential diagnosis for
No,
a right iliac fossa lump.
if you don't mind, please, what I'm asking is on
Yes, sir.
bimanual palpation. So you did
Yes.
bimanual palpation and found that there is no kidney. Every kidney is not bimanually palpable, no? It has
Yes,
to be enlarged to be bimanually palpable. So you were out of that situation when you said renal angle is not full. So you're not
Okay.
suspecting it to be kidney in that case, unless
Yes.
it is not ascended, right? It's
Yes.
other way.
Yes.
Now,
Yes.
I don't want to spoil your presentation by getting more into it. And straight leg raising here. Then you mentioned about liver spleen not palpable. We are okay. And then you mentioned again that no splenic dullness. Go to the next slide.
Yes, sir.
Now, mass is dull on percussion. We are okay with that. Shifting dullness absent or not present. There is no shifting dullness. That's how residents present. Absent, present is like attendance. Liver span is 11. So the liver, there is no hepatomegaly. That takes care of it. Which is
Yes, sir.
Splenic dullness absent. What do you mean by that?
Sir, basically there was no splenomegaly.
That's over. So why should we worry about its dullness? And how would it be absent?
Sir,
It is still present, no? Like liver
yes, sir.
dullness is present, splenic dullness is also present.
Yes, sir.
Then normal tympanic note in the rest of the abdomen. It is understood when you're describing it here. So I think a lot of terms were probably written down just to cover up for whatever you're presenting. Novel bowel sounds is okay. Next slide. I'm sorry I'm taking you there, but it's important for us.
Yeah, yes, sir.
The per rectal is called DRE now, digital rectal examination. Fecal stain in gloves, no blood tinge, normal anal tone, no growth, pelvic deposits. So what will come first?
Sir,
Fecal
firstly,
stain only when you're withdrawing your fingers, no? So
anal tone,
basically the anal tone, then the growth or pelvic
growth,
deposits, and then finally when you get the fingers out, you find that there is no fecal, there is no melena or
blood tinge.
That's what we are interested in.
Yes.
Next slide. This is okay, you made it short and sweet. And next, I'm sorry I'm taking you there. No abdominal examination is complete without examining the spine and also mentioning about the workhouse node. This is what we discussed and genitalia. You know that because these things are important. They were covered earlier, but you should be mentioning them. Even if it is negative, it makes sense to us. Yes.
Right. So examination of testes is very important. Your spine, you have to rule out Schwartz abscess, any tenderness, any scoliosis, any lordosis should be there. And these two have been missed. So they're important in a case of right iliac fossa lump.
Yes.
Also, I want to know in history whether there were repeated admissions or this was the first episode which is come to the hospital.
Sir, this is an index admission, first episode, sir.
Great. So can we proceed? How do you proceed with this diagnosis? And you can come to your last slide. Cecal mass likely to be malignant etiology, ileocecal tuberculosis, retroperitoneal sarcoma. Now, are they connected or it's like apples to orange?
No, sir.
So what is common to all three that makes
Sir, all of them present with a complaint of right iliac fossa lump in a right lower lump in right lower abdomen. Sir, mostly, sir, in case of cecal mass, the lump won't be
no, in all three there is common, something common. Is it a classical intraperitoneal lump that moves?
Sir, yes, sir, it is. All of them present with an intraperitoneal lump.
No, retroperitoneal sarcoma, how will that present as intraperitoneal? Most of the cecum is retroperitoneal. Ileocecal tuberculosis is also not a mobile lump usually. So most of them present with a relatively restricted mobility of the lump, mostly fixed. That's why I thought you put them down nicely, so I'll ask you this question. Okay, justify your first diagnosis.
Yes, sir.
For first diagnosis, I asked you that question. So, second, the differential, anything about it? How do you suspect it? Anything to support it?
Sir, tuberculosis, sir.
Yes, sir.
Sir, for tuberculosis, mainly it is highly prevalent in India, and secondly, patient has a history of a lump, and he's malnourished, patient malnourished there, and there is a history of weight loss. Mostly these are the, but there's no
Like we
history of
got on day one, all in
constitutive.
answer this by saying points in history and points on examination. What are the
Yes, sir.
points in history that can make it tuberculosis, except for a lump being there and the loss of appetite and weight, which you mentioned?
Yes.
Is there anything else? And it's
No,
relevant
sir.
to India, that's okay. Anything else in history which is suggested?
No, sir, that's.
What would you expect in a patient with allergic tuberculosis? A classical case with this size lump.
Sir, in case if the ileocecal tuberculosis of this size, the patient will be of well built. He will have a good immunity.
I don't know what did you understand the question? With this size lump, would you expect some features of obstruction?
Sir, ileocecal tuberculosis can present with a lump of small bowel obstruction symptoms can present with intermittent history of diarrhea and obstruction, sir.
Don't get worked up. I was just asking to know whether it makes sense to you. And how do you rule out retroperitoneal sarcoma here?
Sir, retroperitoneal sarcoma can also present with a complaint of a lump, right iliac fossa lump, and with it could present with a altered bowel habit due to irritation of the cecum, and it could also, but and it is that's it.
Which of the three most likely when it presents very silently?
Sir, most probably retroperitoneal sarcoma will present most silently.
Next.
And next, sir, would be cecal mass, then will be
It's a
ileocecal
large
tuberculosis.
human, so it may not produce immediate symptoms, it may be a little delayed. And tuberculosis will not miss it, usually will produce some obstructive features. All right. Tell me, how do you proceed now?
Sir, first we will do a blood workup to see the general blood workup to see hemoglobin. Then we'll do a chest X-ray to rule out to see if there's any findings suggestive of tuberculosis, and then we'll go for imaging in the form of ultrasound to basically look for the size of the lump and an organ of origin, and if there is any sort of infiltration or in the basically the surround connection with the surrounding structures, vascularity and the lymph nodes are there or any fluid is there. And if the ultrasound will help us to mostly never tell us if what is the most probable diagnosis, then according to that we'll proceed further.
Look, we discussed it repeatedly again this thing. Investigations to confirm the diagnosis.
Yes, sir. Investigation is investigation supportive of diagnosis. Then then we will do an investigation to confirm a diagnosis. If the lump is if a lump is a cecal mass, then we will do a lower GI endoscopy guided biopsy to confirm if there is a cecal mass, malignant cecal mass.
We'll do an
And
ultrasound to see the
yes,
organ of origin, then you'll put in a scope
if
to
the
biopsy.
yes, sir. If the ultrasound is
And we'll do
suggestive
CT
of
to stage it. We will cut
yes,
it
sir.
short, contrast and CT scan to stage the
To
disease.
stage it, yes.
We have had one right leg fossa lump presented on day 1. Today is day 4. So if you have attended, then many things are covered. But for revision of everyone, tell us about the various stages based on CT, how you stage this, the TNM classification based on the AJCC condition division.
TNM classifications are basically TNM T1 is if the mass is located into a submucosa, has infiltrated, but is it limited to that? T2 is in muscularis propria, and T3 is if the mass is in the retrocecal tissues, And the T4 is if the T4A is if the mass
You
is
can refer to
infiltrated
the
to
day one presentation, so we'll save time there also. Anything now directly? Yeah. We are at the staging. You've done you've done the colonoscopy, you've got a biopsy. What all information you want from your pathologist in the biopsy?
the pathologist. I want to know the type of carcinoma and the grade of grading, differentiation, basically well differentiated or poorly differentiated. And sir, other than that, I want to see if there is any basically
Microcephaly stability with the stuff, MSI, we'll take all of them,
micro
grade, type, and
grade type, grade type, and if there is any immunohistochemical marker.
Yes, sir.
Dr. Faiz, once you have now taken the biopsy, the histopathologist has confirmed that it is in fact an adenocarcinoma, and it's a well differentiated adenocarcinoma. You've done the CT, and it's a localized disease. So, what will you do?
Sir, we'll first go for surgical resection in the form of right radical hemicolectomy.
What do you understand by right radical hemicolectomy?
So in right radical hemicolectomy, we will be removing the terminal ileum, 10 to 20 centimeter of terminal ileum, cecum, ascending colon, and proximal 2/3 of the transverse colon up to the right middle colic artery, right branch of middle colic artery.
What is the principle behind removing the last 10 to 20 centimeters of terminal ileum?
Sir, ileocolic artery, which is a branch of middle superior mesenteric artery, is also, so we have to remove that segment to limit the lymphatic to see the lymph node spread.
So all this you do in right hemicolectomy, even otherwise. How is radical hemicolectomy different from right hemicolectomy for benign diseases?
I mean, in a radical hemicolectomy,
did you watch the presentation by Dr. Manoj Jandle yesterday? So you were all, those who could not join, they were joining virtually. So it's all your take on things, right? What was shown there? You can answer what is radical about this right hemicolectomy. Did he answer that? Then terminal ileum. Total mesocolic resection is what was shown yesterday. We need to get adequate lymph node dissection. So we start from the base. And any thoughts on Turnbull technique? Have you heard of it?
Yes, sir. Sir, in Turnbull technique, there is no touch. It is also known as no touch technique. In that, we first we'll be isolating the vessels and the GIT before mobilization to limit the spread of the tumor cells.
Is it considered evidence-based, or is there any no difference whether you go periphery to center or center to periphery?
Sorry, sir. Sorry, sir.
There is no evidence to support it, but when you're doing laparoscopically, as was shown yesterday, we go the vessel first, because otherwise the bowel will keep falling on your camera. So it doesn't matter which way you go. Handling doesn't cause spread, which is what was thought to be responsible. And we need to take out adequate number of lymph nodes. So you need to go right down to the base of the pedicle, right? And the lymphatics come automatically. And total mesocolic section is basically circumferential.
Right?
Yeah, like in TME, you have CME. So very important to understand complete mesorectal excision, mesocolic excision. Any number of lymph nodes that are supposed to be optimum?
Sir, 14, at least 14 lymph nodes will be removed.
14 is optimal. And actually, you can refer to the presentation that was made on that day. So we won't repeat it unnecessarily, because you people should attend each lecture, every talk that is delivered. Before we go there, when you're working up a patient for the, when you're staging the patient, you're getting the biopsy done. I mentioned about asking for microsatellite instability and also doing some gene panel. You said immunohistochemistry. What is its significance in colorectal cancer?
Sir, a colorectal cancer could be associated with any gene mutations like KRAS mutation.
Right?
In that it could be used for giving monoclonal antibodies if the disease is advanced metastatic disease, so we can give monoclonal antibodies.
Excellent. What tumor markers you should have done beforehand? You
Sir,
mentioned the blood test.
CEA could be done, a tumor marker for your antigen, but it is done.
It is what? You were right. What is the problem with CA?
Sir, it is only positive in 70 to 80% and 20%.
Present in non-malignant conditions also. What are those conditions?
Sir, non-malignant. Sir, it could be present in the any hepatic.
Yes.
Uh,
You're right. Cirrhosis.
Cirrhosis, sir.
Any
benign
what is that?
hepatic.
Antiform mole in women or smokers. So it is non-specific. Alcoholics. Wherever liver is a problem, you may have it. And also in studied liver, you may have no CA produced. And in some non-secreting tumors, CA may not be present. So baseline can be wrong. But you need to have the baseline before you go for any definitive attempt to treat. Okay.
Yes, sir.
Actually, in CA colon, it is very important to know that there are no synchronous lesions. So all these tests, colonoscopy, MSI, gene study, they all are there to point whether there is, because if you just remove this portion, after 6 months, something else will come. So it is very important to rule out synchronicity before we proceed.
Yes.
Now, if the patient had a stage of T3 onwards, is there a difference in approach or you do surgery?
Sir, we'll do surgery, sir.
At what stage you will think of neoadjuvant chemotherapy?
Sir, if the tumor is at sorry.
All right, I'll give you a hint. What is the end staging here for colon cancers?
And staging, sir, on the basal lymph nodes, sir, N1 is 1 to 3 lymph node, and N2 is more than 3 lymph nodes are seen, sir.
And what about the M stage in colonic cancers?
Staging, sir, M staging is M1A, sir, if the tumor is located to the single organ. M2 is 2 or more than 2 organ, and M3.
M1,
sorry,
A and B, not M2.
Sir, N1, sir, sorry, and M1B is if the tumor is located 2 or more than 2 organs, and M1C is, sir, if the tumor has spread to the peritoneum.
Or if there are deposits outside.
Out sub-zero, sir, or sub-zero,
So
peritoneum.
you can divide them, and M1 is still resectable. Now, suppose this patient had a liver metastasis. How do you approach it? In addition to writing a collective, what else can you do?
Sir, I will give basically palliative treatment, and we will give neoadjuvant chemotherapy.
That's I mean, you know the answer or you don't. This is a synchronous approach, or you can stage it. You can do, a serial approach. Synchronous is when you do both at the same time. The best palliation for colorectal cancer is surgery only. But patient should be fit for surgery and you should get a clear margin. You can do the resection of primary as well as liver metastasis. If it is confined to a single lobe or a segment, or it is possible to resect it, then you can go for it. And patient is fit for it. Otherwise, the other protocol is putting the patient on neoadjuvant chemotherapy and looking at response from the metastasis and then going for the surgery subsequently. So you don't necessarily need to do at the same time. Both options exist.
Yes.
Right? Clear? You understood?
Okay, sir. Yes, sir.
Synchronous surgery or stage surgery. You can do both. The other options are for the metastasis, what can be done?
For
liver metastasis. Any non-surgical approaches?
Yes, non-surgery is the form only. Neoadjuvant, sir, chemotherapy was a palliative treatment could be done.
No. Have you heard of radiofrequency ablation or hepatic artery embolization? These are options, right? They are given to take care of the bulk, to reduce the disease or some type of response. because the metastases spread by portal blood, but they live on arterial blood. So you can block their supply, they shrink. And also to, if they do portal embolization, they have to go for resection to make the other side of the liver grow up and take care of it. I just thought, since you've done well so far, to cover that up and give you that. So, you're happy? Dr. Anubhav, you're happy? Very well done. Well done, Faiz. One wonderful presentation. And stay on to listen to other talks also. You missed
Yes,
out
sir.
on what was presented rightly, of course, earlier, that a lot of questions would have been actually covered. Well done. That we
Thank you,
close and stop sharing, but do keep attending. We
Thank
want
you,
to
yes,
last
sir.
presentation in this session before we have our demonstration. The last presentation is by Dr. Shreya Dalla.
Yes, thank you, sir.
You have a question, sorry. Amandeep. Your name is Amandeep, only. Huh? Amandeep, okay, both.
Like to confirm the diagnosis. To confirm the diagnosis, we do USC first. That is.
No, actually, this is a very dicey thing, because I've seen an exam, the examiners don't like it straight away. So nobody's saying this is the only way to do it. Always is always wrong. What you can say to save yourself is that as an extension of clinical examination, I would like to do an ultrasound. And a definitive diagnostic test is of course endoscopy, that is colonoscopy and biopsy.
Yes, sir. Sir, what after USC, like we do.
You've done an ultrasound? Why are you fussy about a non-invasive test first? Because you don't want to put in a scope and find that something is outside the colon. Suppose his, God forbid, his third diagnosis was correct. Then you would be in the colon, but you find nothing. Suppose there was a gist outside. You may miss out. So therefore, it's safer. And now it is a stethoscope of a surgeon. Ultrasound is done everywhere. In fact, in the AJCC 8th edition, node staging is done either by imaging by CT or ultrasound. Clinical staging is losing relevance in breast and head and neck.
After USC, CT first or colonoscopy first?
Sir, you tell me. I want answer from you only. I won't even give it. Ultrasound shows there is a lesion in the colon or cecum. Right? CT makes a diagnosis or staging. It's basically staging work. You haven't got a diagnosis. You've done a colonoscopy.
Just on the basis because CT is non-invasive diagnosis. That's
No, I know. That PET scan is even better. Then you can simply sing a song and get a diagnosis. That's not what I meant. Logically speaking, as far as possible, avoid an invasive test before you have done your non-invasive test. But that doesn't mean exhaust all your non-invasive tests. Is that okay? The question is good. What I'm saying is, if you read a red book of American College of Surgeons, where because I was an editor in that, so I know what the problem is. Their first test, imaging test for appendix is CT. For intestinal obstruction, CT. For cecum, they'll do CT. Because ultrasound is taken along with it. All sort of radiologists would also do ultrasound. But you're answering the exam. So I was trying to be on your side to give you a defensive answer so that you can be safe. If you do a CT before, what is the disadvantage? Suppose I ask you, common sense.
podcast is given.
CT is not a joke all the time. Your exposure, prophylaxis, preparing for it. How easily is it done in your institute? I don't know. You're from which college? SMS Jaipur. So it won't be happening at the drop of a hat. Although the place where I've gone, they do CT even before you ask. So it is possible that it can be done faster, but no. Ultrasound is your extension. You can do it straight. Getting the point. So once you have a diagnosis, would it help doing the CT in a different way? Like yesterday we talked of pancreatic protocol. If you know where it is and what the disease is, then the rest can follow. Okay. Are you happy or you don't like the others? Good.
Actually, there's a controversy there because gastrosurgeons, they put in a colonoscope before they do anything.
Earlier, can I add a word here? Earlier, the problem was that we did not have good colonoscope, so people used to miss out findings. So they used to say for upper GI bleeding or problems, you do an upper GI scopy first and then a contrast study. And for colonoscopy, they used to say that you first do a contrast study because it's a huge area and you may miss out on findings in colonoscopy, so that will guide you as to where the lesion is. Here, ultrasound has already guided you where the lesion is. And even for synchronous, the colonoscopes available are able to visualize almost all areas properly.
You don't think we need a CT now before that?
Actually, this, what next, it was the reason why we divided that in scope when we started, 2011, 12, I have to say. Investigation to confirm the diagnosis, to support the diagnosis, to stage the disease, and to treat the patient. Because I observed in many examinations that the candidate said ultrasound and the examiner said, it's a job, subtle jaundice patient, would you do an LFT? Nobody's saying you'll do one before the other. Whatever you can do, you do. But it is good, therefore, safer and defensive to divide them this way and leave it to the examiner to ask you what is it that you do. Right? Stool examination also important, but that doesn't mean to start with the stool examination because your laundry list will never finish. Safer to divide it that way for your own sake. In practice, you may do this all of them in one day. So it's not that one is before the other. Correct? Thank you. She's joined. She's joined.
Yes, sir, I'm here.
Oh, you're audible. Great. Great slides. Where was this picture taken? Yes, please start share. She's from SMBT.
Yes, sir,
I don't know if I'm pronouncing it correct.
is my screen visible?
Your screen is visible. Please share the slides.
Is it visible?
Yeah, we can now see.
Okay.
Share data.
Good afternoon.
Good afternoon.
Yes,
Can you
sir.
make it into a slideshow from the slideshow?
Yes, sir.
From Narshet.
Good afternoon to panel members and all the audience.
The slides have disappeared, actually.
Yes, sir, loading them.
If slideshow is a problem, you can continue as you were.
So may I continue?
No, we can't
that
see your
way?
slides. Harsh, what is happening?
Like I'll exit slideshow.
Until you exit.
Oh, okay.
Now you please do it as it is happening. Okay.
Yes, sir. A 69-year-old male, a resident of Sangoda Thane, farmer by occupation and Hindu by religion, came with the complaints of lump in left paraumbilical region since 2 years, associated with gradual increase in size. He also complained of swelling on the umbilicus since 2 years, which is not associated with pain or increase in or a change in size. He complains of colicky pain in abdomen since 15 days in the left paraumbilical region, associated with loss of appetite and weakness since 15 days, and also complains of constipation since 15 days. The patient was apparently all right 2 years ago when he noticed a lump in the left upper abdomen, which was insidious in onset, progressively increased in size from about 4 by 4 centimeter to a present size of about 10 by 12 centimeter, spreading more towards the right side, not associated with pain, not having any aggravating or relieving factors. He noticed another swelling 2 by 2 centimeter on the umbilicus 2 years ago, which was insidious onset, did not progress over time. It was not associated with pain or change in size, did not reduce on its own, did not have any aggravating or relieving factors. He also complains of pain in the umbilical region since 15 days, gradually progressive, colicky type, which was not radiating, aggravated with meals, and was relieved with rest. He also complained of loss of appetite and weakness since 15 days, which hindered his ability to work and was relieved with rest. He complained of constipation since 15 days intermittently, which was sudden onset, non-progressive, did not have any aggravating factors, and it was relieved on taking medication. He also gave a history of weight loss of around 5 kgs over 2 months. There was no history of fever, nausea, vomiting, no history of trauma, no history of jaundice, melena, or hematemesis. There were no urinary complaints, no history of dyspnea, no history of metastasis, no cough, convulsions, chest pain, breathlessness, headache, or any other swellings in other part of the body. In past history, there were no similar episodes in the past, no known comorbidities, no surgical history, and no history of blood transfusion. The patient had normal bowel habits till 15 days ago when he started experiencing constipation. He takes a vegetarian diet. He does not have any addictions, no known allergies, and his sleeping habits are unaltered. He sleeps 8 hours a day. In family history, there are no similar complaints in any of the family members, and there's no cancer-related deaths in the family. I would like to give a summary. A 69-year-old male farmer came with complaints of swelling in the left paraumbilical region since 2 years, which was not associated with pain, swelling on umbilicus since 2 years, which was not associated with pain, pain in umbilical region and constipation, loss of appetite since 15 days, and no significant past and personal history or family history. At this point, I would like to give differential diagnosis based on the history. It could be a GI malignancy, a retroperitoneal tumor, a left renal tumor, a case of splenomegaly, or abdominal tuberculosis. Should I continue, ma'am?
No, we just want to ask you. Okay, your differential says GI malignancy goes right from esophagus down to the ass. Can you be more specific?
Yes, sir.
Patient of malignancy.
Yes, sir. So, given the history of left lumbar, paramedical region swelling,
You decide, you said it's left upper abdomen, then it says it's paraumbilical, then you say it's, where's this lump exactly? Have you, can you tell me?
yes, sir. It's more in the left lumbar region, but it's connected to the umbilical region. So that's why I've described it as left paraumbilical region.
So you have
It's
a
a
lump in
continuous
the
movement.
left lumbar region, you have a lump in the umbilicus, right?
Yes, sir.
So what do you think, what kind of GI malignancy are you for?
So it could be
With
a
no other symptoms except for weight loss, loss of appetite, one episode
Yes,
of
sir.
constipation relieved.
So multiple episodes of constipation, but yes, over 15 days. Sir, it could be a large colon malignancy, transverse colon or descending colon malignancy, or it could be a stomach carcinoma.
It could be anything in biology, right? What we are talking about is that there is a mass lesion in the central abdomen as well as extending to right and left sides, and there is colicky pain, right? And so this colicky pain is due to, do you think it is because of bowel complaints or urinary complaints? Because you kept a renal as well as a GI mass.
Ma'am, I believe
Bowel complaints and urinary complaints. What kind of colicky pain was it?
ma'am, it was more. I believe it was more because of the
Can you describe
colon, the bowel complaints.
Describe a renal colic. What is colicky pain?
Spasmod. It's a spasmodic type of pain. It occurs and then disappears on its own. It's a self-limiting episode, but multiple times it occurs.
So it has
In the
a
form of
crescendo and
spasms.
it comes down. It is severe in nature, and then it is associated with other symptoms also, like nausea, vomiting, and all 2 or 3 components are there too. Yes, other than constipation, this patient doesn't have any other urinary complaints, no? What is an intestinal colic?
No.
So you have to describe a colic. When you describe, then only you would know.
Let's move to examination now.
Okay. The patient was examined under well-lit conditions with appropriate informed consent with adequate exposure from nipple to mid-thigh. Patient is conscious, oriented to time, place, and person, cooperative. His decubitus was supine position, built is average build, height 152 centimeters, weight 60 kilograms, and BMI was 26. Pulse was 82 per minute in right radial artery with normal rhythm, regular flow, adequate force. Blood pressure was 128 by 76 millimeters of mercury in right arm in supine position. No pallor, icterus, lymphadenopathy, cyanosis, or clubbing was seen. In systemic examination, the CNS, CVS, and RS, the central nervous system, cardiovascular system, and respiratory system are within normal limits. Going to per abdomen on inspection, the shape is normal, skin of the abdomen is normal, umbilicus is central, 2 by 2 centimeter swelling at umbilicus is seen, and cuff impulse is seen. No scars, sinuses, dilated veins, or peristalsis is visible. All other hernial orifices are intact. Swelling moves with respiration. Left supraclavicular fossa is empty. On PAL, all the inspection findings are confirmed. Abdomen is soft and non-distended. A diffuse mass with smooth surface is visible in the paraumbilical region, extending to the left and the right paraumbilical region, about 10 by 12 centimeters, irregular shape, extending in the left lumbar region from 4 centimeter below costal margin, above left ASIS vertically, and 5 centimeters from the line horizontally on both the sides. And on the right side, it is 5 centimeter below the costal margin and 4 centimeter medial to the right ASIS. It is firm in consistency with well-defined margins. The swelling is not palatable. It is renal and free. On direction of recti C, just below the sternum. Swelling itself is not swelling is trapped up. The swelling is not pulsatile, not transilluminant, not fluctuant. Cuff impulse is palpable at infraumbilical border for 2 by 2 centimeter swelling at umbilicus. It is not reducible. Inguinal and clavicular lymph nodes are not palpable. On percussion and auscultation, underneath the parabolomies are not palpable. The palpating hand can be inserted below both the costal margins. On percussion, the note is dull with the swelling.
Shreya, are you there? They have a challenge with the internet. You're there now. Yeah, you can switch off your video and speak. Maybe she's trying to rejoin. Surya, is she trying to rejoin? Her internet, no? Or our internet? Okay. You can give her a tinkle. Or we'll move to the presentation. At least they'll know how to do it the correct way, no? See, what we're not a great fan of virtual presentation personally. Presentation should be physical. Why? Because there is a set format and they keep reading without knowing, without thinking. Now, the abdomen, you could look at the picture and it is glaringly deformed. You can't say abdomen looks normal. Hello? Yes? Agreed? Now, what are the other features you observed? You've been attending regularly. Yes? Which you would need to correct in the presentation. Yeah, stand up, no problem. Don't worry. This is a free for all. Okay, umbilicus. Other points that you noted? Oh, she's there. So you're like, oh, no, she's there. I'm happy that you didn't want to speak when she's there. Shreya, are you there?
Hello? Yes, sir. Sorry,
No,
internet
no problem. You
got
can finish with
interrupted.
your presentation. I know the challenge.
Yes, sir. So the second image is bimanual palpation of both the lumbar regions. The third image, left lower image is me insinuating my hand below the right costal margin, and the last image is for the left costal margin. And this is on leg raising test. The divarication of recti is visible. This is a zoomed in image. So may I go to the final diagnosis?
You please finish, otherwise we're scared of your internet
Okay.
going cranky again.
Sorry, sir. No. A 69-year-old male, a resident of Sangoda, Thane, farmer by occupation, Hindu by religion, came with complaints of lump in the abdomen since 2 years, swelling on the umbilicus since 2 years, pain in left side of abdomen since 15 days, constipation since 15 days, loss of appetite and weakness since 15 days. On examination, the patient has a diffuse 10 by 12 centimeter palpable mass in the right and left paraumbilical regions, soft, smooth, non-tender, with all the borders are palpable, moving with respiration. Another 2 by 2 centimeter swelling is present on the umbilicus, non-tender, non-reducible, with cuff impulse present, suggestive of an umbilical hernia. After a complete examination, my diagnosis is a malignant tumor of the gastrointestinal tract. I would like to further investigate the patient, first to confirm my diagnosis, then to stage the disease, and then do all routine investigations required for fitness for surgery should the tumor be operable. Investigations that I would like to do are ultrasonography
All
of
right,
abdomen.
we'll not ask you that. Okay, first your diagnosis we need to discuss. There are a few observations, Shreya, if you don't mind. First of all, give her a round of applause for making an attempt. Shreya, you presented virtually, so that itself is a challenge because you're just reading through the slides, which is not a good thing. You can improve upon it.
Yes, sir.
Secondly,
Okay,
when you're describing your abdomen, try to watch the patient yourself. Is it a normal looking abdomen? Not a normal looking abdomen. You can't be doing leg raising test in an elderly person just to prove a point. We already know it's inside the abdomen. So these are some unnecessary, and there are many unnecessary tests that were done. If you don't have hepatomegaly, where's the point in trying to put the finger on the costal margin? Because that is just to support it is a liver or a spleen on the left side. So many of these are unnecessary, tests that you probably did. Why did you want to do a leg raising test in this patient?
Sir, to see if the swelling becomes more prominent with leg raising. It could differentiate between parietal and intra-abdominal
So
swelling.
what did you think initially when you started? Is it a parietal swelling this large?
It could be a parietal swelling.
It could be a parietal swelling.
On clinical examination on palpation, it could be a parietal swelling.
Okay. And you had,
Because sorry.
you said the right iliac fossa is empty. Is that what you said?
No, sir.
Or
Renal
something?
angles are full.
Okay. Can you go through the abdominal examination again? The slides, please. Something was empty. Left iliac fossa was empty. Actually, left supraclavicular. Can you? We can't.
It's left supraclavicular fold. Yes,
And
sir.
anything else which was empty in your case? Renal angles are free from any trouble.
Yes, sir.
Because there's so much written there, no? We are not understanding what was the actual issue. But I'm glad you made an effort to present. Is this the first time you're presenting?
Sir, yes, sir. I'm a first year resident, sir.
Don't worry about it then. You will do better. But make an effort to persist with it. And you don't need to write everything which you don't do. Okay.
Okay, sir.
And
Yes, sir.
in this sized lump, nobody's saying you should not miss the umbilicus or the hernia there, but pay attention to the lump. It is occupying almost the entire abdomen. So all
Yes, sir.
quadrants should be
It is, sir.
occupied. So no point trying to say one or the other is more occupied than the other one. And I have noted many things, but I don't know where to start actually. So maybe we can move on. Any questions? All right. So when you write the diagnosis, I think you can go to that slide. You've written the summary probably. This is not the final diagnosis. Final diagnosis would be 2-liner or 3-liner, right? So what is your final diagnosis? No, and you'll never have a final diagnosis. If you've read the book by Arthur Haley, Final Diagnosis by the pathologist. We have clinical diagnosis or provisional diagnosis. Okay.
Provisional diagnosis.
So
Yes, sir.
provisional diagnosis, what is it? 69 years, gentlemen. We don't need to know now that he's a resident of so-and-so place. You already mentioned that. All that detail doesn't need to get repeated. Right?
Okay, sir.
On examination, he had this, etc., etc. So how would you put your diagnosis now? Forget this detail. So 69-year gentleman with an abdominal lump occupying almost all the quadrants, likely to be malignant, probably arising from the gastrointestinal tract, likely to be which part of it? Which part of
it could be transverse colon, descending colon.
So you're saying it can't be all of them, no?
Either transverse colon or descending colon.
So colonic mass, that's what you're saying. So you
Oh,
can be
colonic mass.
less
Yes, sir.
confusing there. And we don't
Yes,
mention investigations here, they may ask you differently. After a
sir.
complete exam, my diagnosis malignant tumor of gastrointestinal. I would like to, and this I would do this, I will do that, my patient, etc., is not used in the examination. So you can be direct with it. Okay. Now, why do you think it's a colonic mass?
So, mostly based on the location of the tumor, because
There's
the
no
patient
history and
is not having history of either vomiting or any
you have vomiting
complaints
in a
of
colonic mass.
no, I'm saying to point towards other except for constipation. He only has one non-specific symptom of constipation. So
Constipation is a non-specific symptom in a bowel disease. It's an important symptom. And don't feel
yes, sir.
comfort comfortable saying that I'm a first year postgraduate, but you're definitely post MBBS, no? So there are many things
Yes,
which
sir.
are at undergraduate level that you learn. It's not always in PG that you'll go and learn. And don't live with that
Yes, sir.
excuse if there are others here also. This is what we
Yes,
are
sir.
asking you are mostly MBBS questions. So
Yes, sir.
you should have worked harder at putting it together. All right. Uh, I think we'll quickly ask you what do you want to do now? How do you proceed? Why do you say it is malignant?
So a lump, a diffuse lump in abdomen occupying almost all of it and associated with weight loss is
So next time, Shreya, you will
mm,
answer by saying points in history and points on examination. What are the points in history?
yes, sir.
What is the age?
Age is 69
69 years
towards the
old.
yes, sir.
And with a history
69
of
year old.
constipation, loss of weight and appetite, and a lump in the
Yes, sir.
abdomen. On examination, a large lump occupying the entire abdomen. Am I right? That's what you said?
Yes, sir.
And
Yes, sir.
hard in consistency, irregular surface, more likely
Yes,
to
sir.
be malignant. And
Malignant.
how do you proceed with investigations? Now you can tell us in 1 minute, we'll wind up. You've written it all, so you can read it now.
So first and foremost, we'll do all routine blood investigations and an ultrasonography of the abdomen to see the location, the if possible, the organ of origin, the consistency, if is it solid or cystic, the vascularity. After that, I would like to do a PCT or an MRI of abdomen, whichever is feasible, to know the extent of the tumor and
Now, give me a promise. You're going to sit through all the talks now. There's going to be a very, very
yes, sir.
important talk on how to examine the abdomen. So those points will get corrected because some mistakes, some
Yes,
people
sir.
are repeating, indicating that they did not watch yesterday. If you don't pay attention, nothing happens without hard work. You need to be paying attention. Secondly, you wouldn't do a biopsy externally. If it is a colonic mass, you'll do colonoscopy. You should have heard the first case. And then other things we have
Yes, sir.
already discussed. Is that okay, Shreya?
Mhm. Yes, sir.
Anything else you want to tell us? There's more slides.
So the alternate, no,
Alternate, yes.
there's no further slide. The alternate organ of origin could be stomach as well, uh, uh,
So stomach
because
is one end of the problem, colon is the other end of the problem. Will they be
yes, sir.
similar in their presentation?
No, they will have different types of
So,
presentation.
beta, you should not compare apples to oranges and certainly not apples to donkeys because they'll be too far away then. So, try to keep it. Why do you say it's arising from the gastrointestinal system?
So
Such a
because the
large
patient has
lump
the
in the
symptom of
colon,
constipation.
would it have remained quiet? It would have produced obstruction. It would have
Yes,
produced
sir.
many changes, no?
Yes, sir.
Yeah, so you can think better about it. Now, watch through the next presentation. Good that you made an effort to present. Keep presenting. We are here to teach you, not to discourage you. But if you tell you done very
Yes, sir.
well, it won't be not be right. It won't be fair. You
Yes, sir.
should work harder
Yes,
at your
sir.
presentation rather than following it from Google, picking up some presentation patterns. Be realistic. You watch the other people present, and we will be speaking about all presentations. So you will make use of it and you'll utilize you'll make this presentation better and do present again and present
Yes, sir.
repeatedly. How many
Yes, sir.
postgraduates are there in your college with you?
So my batch is of 5 people.
So the 5 of you should present to each other if nobody is there to listen and make an effort to
Yes, sir.
present. If there is nobody listening, stand in front of mirror and make your presentations. That's how you should do it.
Yes, sir.
It's very, very important.
Yes, sir.
Anyway, you made a good effort. Finally, would this patient be treatable by any method?
Yes, sir. If we have confirmed on
It is a
histopath
transverse
exactly
colon
what
mass, which it is not, but then suppose it is, then what do you do?
yes, sir.
All right, so read about
We
it.
would be doing a right. Yes, sir.
You can do more than what you probably are thinking. So you can read about it or watch other presentations. All right, give her a round of applause. She's finished her presentation. Thank you, Shreya. Stay tuned
Yes, sir.
and be there for the next presentation, which is very, very, very important. So we will have Professor Vindal presenting the examination of abdomen talk, which should make you understand what is it that you are missing, what is it that you can do better, how is it that you can improve, and what is necessary to present, what is not necessary to speak or present.
Yes, sir.
Over to you, Professor
Thank you,
Vindal.
sir.
Thank you so much, sir, for this kind invitation. And it's a pleasure, like always, to be here and to see the students logged in virtually as well as present physically. And the task that has been assigned to me by Professor Chintamani is to speak on the nitty-gritties of abdominal examination. It's a vast topic. I'll try to make justice with it. And what I plan to discuss here is the basic components under which you should deal with abdominal examination in any patient who has presented to you with an abdominal pathology. The core components being the inspection, palpation, percussion, and auscultation. You are all aware of this. And remember that, like Dr. Chintamani has been telling over and over, that abdominal examination does not end with examination of the abdomen. There are some more components to it, specifically examination of the renal angles, examination of the back and the spine, examination of the genitalia, and a parietal examination. And do not forget to mark out the pointers in general physical examination which are relevant to the abdominal case that you may be examining. So we all know that abdomen can be divided in two ways, into either four quadrants by a midline vertical line and a horizontal line as to right upper, right lower, left upper and left lower quadrant, or into 9 regions by 2 vertical and 2 horizontal lines. The important thing to remember is that abdominal cavity extends much more beyond what we see from the surface. The normal diagram that we make is the 2 costal margins superiorly, then the flanks by the side, and the inguinal ligament and the iliac region inferiorly. But the cavity of the abdomen is extending much more superiorly under the dome of the diaphragm, where it houses the liver on the right side, the spleen, and the stomach on the left side. And similarly, also is extending deep down into the pelvic cavity, where it contains the cecum, the appendix, the urinary bladder, with the female internal genitalia, the uterus, the ovaries, the broad ligament, and on the left side, the sigmoid and the intraperitoneal part of the rectum. So if we do not take this into account, we may miss out on examining the abdominal viscera properly. So the things that you must remember is that always, whenever you are examining the patient with an abdominal disease and you are exposing the abdomen, it should be in a private area so that the patient can be relaxed and the privacy of the patient, you take care of the privacy of the patient. It should be quiet. So when you go on to the auscultation part, there are no noises which are interfering with your hearing. Patient should be comfortable. Otherwise, if the abdominal muscles are not relaxed, you will not be able to discern or gauge what is happening beyond the abdominal muscles, because the cavity lies underneath the abdominal muscles. If the patient is tensing the muscles, your hand will not be able to gauge what is inside the abdominal cavity. The position in which you should examine the patient is a supine position with the knees extended and the head supported on the pillow, so that again the abdominal muscles are relaxed. Sometimes some examiners would want you to flex the lower limbs at the hip and the knee joint in order to relax the fascia and the lower abdominal, central abdominal muscles. which may make the abdominal palpation easier. The exposure should ideally be from the clavicle to the mid-thigh, but again, taking care of the dignity of the patient. The ambient temperature should be comfortable so that the patient does not become hypothermic, patient does not shiver while you are examining. There should be proper lighting. And in case of a female patient, you should be having a chaperone or a nurse with you. So what are the pointers in inspection that you must be careful about? So whenever you are doing the inspection, the first and the foremost thing is treat the patient as a whole. Look at the posture of the patient. Sometimes due to pathology in one of the regions of the abdomen, the patient may acquire an abdominal posture, which may give you a pointer towards where exactly the pathology may be lying. Look at the facial expression. Patients who are having an acute abdomen may not be able to lie comfortably and they may be wincing. And look at the overall comfort level of the patient. You have to examine the shape and the contour of the abdomen, which is best seen when you bend down and bring your eyes at the same level as that of the patient's abdomen. The shape can be either scaphoid, which is a normal concave shape, where the bony edges of the abdominal wall are at slightly higher level compared to the midline part, which is slightly sunken. So scaphoid means boat shape. It may be flat or mildly distended, where everything is at the same level, or it may be protuberant or distended, where the central part protrudes over the costal margin. Now, you all would have learned about the causes of abdominal distension, the 5 Fs and the 1 T. So I'm not going to repeat that. Then always remember that in inspection, you must also comment on the symmetry of the abdomen, because there is a midline and there is a right region, there is a left region. So always compare the right with the left, like we do for all paired organs in the body. And the symmetry is best appreciated when you are standing at the foot end of the patient, not by the side. So when you are examining, you are standing on the side of the patient. When you are commenting, when you are trying to look at the symmetry of the abdominal wall, you should stand at the foot end of the patient. So that is how a scaphoid abdomen would look like. Then also on inspection, you must comment on any scars, which may give you a pointer towards the surgical history of the patient, and be careful about examining the small scars of laparoscopic surgery, which may be hidden if you are not carefully looking for them. Big scars of open surgery are clearly visible, but small scars of laparoscopic surgery, because more and more procedures are being done laparoscopically now, may be hidden unless you carefully look for them. Look for dilated superficial veins, which may be a pointer towards portal hypertension. Look for skin, the condition of the skin, any obvious skin lesions, any erythema, discoloration, any bruises, any striae, which may indicate a sudden abdominal distension. Look for any abnormal or visible pulsations. Some thin patients may have normal pulsations in the epigastrium, which are transmitted pulsations from the abdominal aorta. But if the patient is not thin, these pulsations should not be there. Look for any visible peristalsis, which may be a sign of abnormal or increased strength or increased force of propulsion of the intestine, signifying an element of obstruction. Look for movement of the abdomen with respiration, and look what happens to the abdominal wall while the patient coughs. So this photograph will show you that there is a small bulge in the supraumbilical region, dilated veins, and these are the various scars which may be present on the abdomen: midline, paramedian, subcostal, thoracoabdominal, and so on and so forth. This shows you presence of dilated bowel, which are casting an imprint on the anterior abdominal wall, signifying possible obstruction, and a midline scar will make you think that possibly this is some sort of an adhesive intestinal obstruction arising because of the previous laparotomy the patient has had. Again, a lump in the supraumbilical region, which could be arising because of a hernia, and slight discoloration of the skin around the umbilicus. I don't know whether it is seen there. So be wary of these subtle signs, which may be harbinger of disease lying inside the peritoneal cavity. Look for any visible lumps, look for any swellings, look for fullnesses. Compare that with if it is present in the midline, fine. If it is present on one side, then it is better to compare it with the opposite side so that you are able to make notice of it in a better manner. Look for the position of the umbilicus, shape of the umbilicus. Now, if there is an upper abdominal fullness, umbilicus tends to shift down, and vice versa in lower abdominal fullness. So normally the umbilicus should be central. It should be equidistant from the xiphi and the superior surface of the superior border of the pubic symphysis. Normal position is inverted. It may become flat. It may become frankly everted. Look for any sinus of fistula opening at the level of the umbilicus. Look for any discharge present at the umbilicus. Look for any discoloration like we just saw, or any obvious nodule which may signify metastatic deposit. Look for all hernial orifices, specifically looking for any hernia or any cuff impulse arising from a previous scar which may indicate presence of an incisional hernia. And like I said, abdominal examination is not complete without inspecting the genitalia and the back. If there are any stomas, then always inspect the stoma for any obvious complication like a prolapse or bleeding or retraction. So this figure shows obvious bulges in the inguinal region signifying hernia, another inguinal hernia patient, and the different sites where the stomas can be in a patient who has had a previous surgery. Now, after inspection, next is the palpation, and palpation is to confirm and build on the findings that you saw on inspection. Before touching the patient, ensure that your hands are not cold. If you are examining the patient in winters, rub your hands, bring them to the same temperature as the body temperature or the skin temperature of the patient before touching the patient. Poking movements and sudden deep palpation should be avoided because it makes the patient uncooperative, and you will lose out on gathering information by this component of the examination. Always ask the patient which is the area where the patient is having pain, and examine that area in the last, because if you examine that area as the first thing, it is very tempting to go directly to the area which is supposedly at fault, or that is the area of pathology. But if you examine a tender area right in the beginning, you will lose the cooperation of the patient for the rest of the examination. Try to distract the patient by talking. Look at the face of the patient when you are trying to perceive whether the area that you are palpating is tender or not, rather than asking the patient whether it is painful. Examine always with the flat of the hand. Do not poke your fingers. Do not examine with the tip of your fingers. So lay the hand flat and be gentle while you are examining the patient. Begin always with light palpation. Be systematic. Start from one of the areas and then move either clockwise or counterclockwise to arise at the area of pathology in the end. So we have talked at length about temperature. Dr. Chintamani was also telling you temperature is only of significance when we are dealing with parietal pathologies. Otherwise, for most of intra-abdominal conditions, temperature is of no value. Look for any guarding or rigidity, which may signify intra-abdominal pathology and reflex contraction of abdominal muscles. Look for any tenderness and any rebound tenderness. So tenderness is an active process where when you're palpating, the patient will wince and experience pain. Rebound tenderness is tenderness arising when you are removing the pressure of your hand, and because of the springing action of the parietal peritoneum, which is inflamed and is pain sensitive, the patient will experience pain. Then palpation of specific abdominal organs would come once you have examined the abdomen as a whole, specifically liver, gallbladder on the right side, spleen on the left side, kidneys on both the sides, abdominal aorta, whether it is palpable or not, stomach or colon, whether there are any lumps arising out of that. And whenever you are palpating any organ, keep this picture in your mind as to what is the organ which is directly underlying the area which I am palpating. So if it is in the right upper abdomen, there would be liver, there will be gallbladder and the upper pole of the kidney. If it is left upper abdomen, there will be spleen there and the upper pole of the left kidney, and so on and so forth. So if you close your eyes, take 5 seconds to kind of think in your mind, what are the areas anatomically which are directly underlying my hand? It will be easy for you to arrive at the anatomical diagnosis as to what is the structure, what is the most likely structure that I am palpating. Look for any abnormal mass. If there is any abnormal mass, look for the plane in which the mass is lying. So there are several tests which have been described. There are 3 planes. It could be the parietal, that is superficial to the muscles. It could be within the plane of the muscles, or it could be deeper to the plane of the muscles. For the upper abdominal lump, you can do a head raise test if it is in the midline, or for lower abdominal lump, you can do a leg raise test. But for lumps which are placed laterally, contraction of the rectus abdominis muscle does not help. Because what you're trying to do is to try to find out whether the lump is lying deep to the muscle which is getting contracted or not. So if it is lying deep to the muscle which is getting contracted, it will become less obvious. If it is lying superficial to the muscle which is getting contracted, it will become more obvious. So rectus is present in the midline. If there is a lump on the lateral aspect, you need to contract the lateral abdominal wall muscles, and you need to ask the patient to do a Valsalva. Okay, so Valsalva becomes more informative compared to a leg raise or a head raise test for laterally situated lumps. Look at the size, surface, shape, consistency of the lump, fixity, whether it is mobile by itself, whether it is moving with the respiration or not, and whether it falls forward in knee elbow position, signifying whether it has a mesentery or whether it is attached to the posterior wall. Look for all the hernial sites, look for inguinal lymph nodes, and if there were any intestinal stomas which you had inspected, always ensure that you palpate all the intestinal stomas to look for any complications and whether they are proper or not. So just a pictorial representation of all that we have discussed that we need to look for. Sometimes, like I said, in thin patients, abdominal aortic pulsations may be palpable in epigastrium, which is a normal finding. But if in a not so thin patient you are able to palpate the abdominal aortic pulsation, it may signify presence of abdominal aortic aneurysm. So liver is palpated starting from the right iliac fossa, because liver is situated in the right hypochondrium and it grows down vertically in the same axis. So you start from the the right iliac fossa, and with each inspiration, you wait for the liver margin to come and override your finger to override the margin of the liver. And with each subsequent breath, you move some centimeters cranially till you are able to feel the liver. What you have to see is whether liver is enlarged or not. If it is enlarged, how many centimeters is it enlarged beyond the costal margin in the mid-clavicular line? So there has to be a reference point. Just saying that the liver is enlarged 2 centimeters does not mean anything. You have to be specific. It is 2 centimeters below the right costal margin in the mid-clavicular line, so the examiner gets a clear picture as to what you're talking about. You have to be specific whether it is the right lobe only or whether it is right as well as a left lobe, which is palpable in the epigastrium. Look at the surface. So that was discussed in a few cases back. Look at whether it is tender or not, and look for any additional signs which may be arising due to liver pathology. Similarly, gallbladder is also palpated in the right hypochondrium. There are 2 ways which have been described. One is palpating from below upwards with the radial aspect of your dominant hand, waiting for the gallbladder to move down with the liver with inspiration and then hitting your hand. And the other way is to stand behind the right shoulder of the patient and insinuating your fingers along the costal margin and asking the patient to take a deep breath and then waiting for the gallbladder to come and hit your insinuated fingers. On the left hypochondrium, the organ which is most commonly enlarged is the spleen. Now, both in enlargement of the liver and the spleen, you will not be able to get above the swelling. That means that you will not be able to insinuate your hand between the costal margin and the lump that you're feeling. Spleen enlarges from the left hypochondrium obliquely towards the umbilicus and then into the right iliac fossa. So again, you start your palpation from the right iliac fossa and move diagonally across to the left hypochondrium. There are 2 methods which have been described. One is in the supine position for an obviously enlarged spleen, and for smaller amounts of enlargement, which may not be palpable on supine examination, you ask the patient to take a turn towards the right side, support the posterior aspect of the left rib cage with your non-dominant hand to push the spleen anteriorly, and at the same time insinuating your fingers underneath the left costal margin, trying to feel for the tip of the enlarged spleen, which may come down and hit the tips of your finger while the patient inspires. Kidney, both left and the right kidney are examined by doing a bimanual examination, where one hand is placed posteriorly on the flank and the other hand is placed anteriorly on the anterior abdominal wall. And with the left hand, you push the kidney anteriorly, and with your right hand, you press the anterior abdominal wall downwards and try to palpate the kidney. The lower pole of the kidney may be palpable in a thin person, and if the kidney is obviously enlarged, you may be able to feel it with this maneuver. The kidney is an organ which is mobile on respiration. So when you ask the patient to take a deep breath, the kidney comes down and you will be able to feel the kidney coming in and slipping out between your two hands. Another test which has been described is ballotability, which is a test which simply means that when you are placing your two hands, one of the hand is doing a flicking movement, and there is an organ or a mass which is mobile, which is normally resting posteriorly. But when you make this flicking movement, there are two things. This mass is mobile, so that when you flick it, it is able to move up. And second, there is enough space between this mass and the watching hand, which is the anterior hand, where this mass would move in, touch, and then fall back. So that is what is the test for ballotability. Now, obviously, if the lump is so big that it is lifting the anterior abdominal wall up, or it is reaching the anterior abdominal wall, the second criteria for it to be ballotable is lost. That is the space for it to move up, because it would be, as it is, bimanually palpable. So if it is as it is bimanually palpable, the test of ballotability becomes redundant. Now, very rarely you will get a case of acute abdomen in your exam, but just for completion's sake, in an acute abdomen, you will like to do what is known as a cuff test or a bed shaking test or a heel tapping sign, which is basically just to elicit the irritation of the parietal peritoneum, which is pain sensitive, whenever the patient coughs, or you shake the bed suddenly. Because of the sudden jarring movement, the patient experiences pain and winces. This may also be elicited by doing a percussion, where the tapping movement stretches the peritoneum. It is just like a rebound tenderness. With each percussion, the patient will wince. You may do an obvious rebound tenderness, and there is a maneuver which has been described in one of the books, which is a Butov maneuver, which is basically to find out whether the patient is malingering or not, in which you will palpate identical areas on both the sides simultaneously and then ask the patient, basically to confuse the patient if the patient is malingering. After palpation, the next step in examination is percussion. For abdominal pathology, specifically, you are looking for whether the note on percussion is tympanitic, signifying air, or whether it is dull, signifying fluid or solid. Look also for percussion tenderness, like we just discussed, for areas of tenderness. Percussion is also helpful in finding out the liver span. Okay. And also to find out whether the patient has any free fluid present in the abdomen, in which case fluid thrill or shifting dullness can be elicited. Now, specifically in a patient who has ascites, there are 3 tests which can be done to find out whether the fluid is present, free fluid is present, and if it is present, what is the approximate amount. So for very small amounts, the test which has been described is what is known as a puddle sign, in which you ask the patient to make a knee elbow position in order for the fluid to gravitate on the anterior abdominal wall, and then agitate that fluid and look for and auscultate for that agitation sound while you are auscultating with a stethoscope. Shifting dullness is a test which is done for again for free fluid in the abdomen, where the principle behind it is that if the free fluid is present in the abdomen, it will shift with the shifting position of the patient. So when the patient is supine, the intestines will float up and the fluid will gravitate onto the flanks. So when you percuss from the epigastrium, you should get a tympanitic note. Now, from this tympanitic note in the midline, when you move to the flank on either side, you will reach a point where the note turns from tympanitic to dull, signifying that the fluid is present beyond this note. Now, keeping your finger there, when you ask the patient to turn onto the opposite side, what would happen? The fluid, which is free fluid, which is present inside the peritoneal cavity, by the effect of gravity and with the patient shifting to the opposite side, the fluid will move on to the other side, and the intestinal loops will float to the site where you are putting your finger. And now when you percuss, the area which was initially dull because of the presence of the fluid now becomes tympanitic because of two reasons. The fluid has shifted because the patient has turned the position, and the gas-filled bowel loops have moved to this new position. The other test that you can do is fluid thrill, which is usually positive in tense ascites. So basically you ask one of your assistants or the patient herself or himself to place one of the hands vertically on the midline just to dampen the thrill which may be transmitted through the fat, abdominal wall fat. And then you place one of the hands as a watching hands on one of the flanks of the patient, and the other hand, which is a dominant hand, will make a flick movement on the other flank, waiting for the flicking movement with your dominant hand to be transmitted through the fluid inside the peritoneal cavity to your watching hand. Taking care that this is not falsely positive because you have already taken care to dampen the transmission of this thrill through the abdominal wall fat by placing that hand in the midline. After percussion, the next is auscultation, which is very important for abdominal wall pathologies. And it is usually done with the bell of the stethoscope, and it should be placed gently on all the four quadrants. You are looking for the presence or absence of the bowel sounds. If they are present, what is their nature? What is their pitch? What is their frequency? And also, as a complete systemic examination, you should always examine the chest as a part of abdominal examination, because lower pulmonary pathologies arising from the lower part of the chest wall can also mimic intra or upper abdominal pathologies. Additional maneuvers that can be done are ausculto-percussion test or the scratch test, which we just heard in one of the cases that were presented, basically to find out what is the extent of any distended viscus, where the bell of the stethoscope is placed and you make scratching movement on the anterior abdominal wall. And till the time that the finger or the scratcher is present within the realms of the viscera where you have placed your bell, you will feel a very clear sound, and the moment it crosses the boundary, the sound becomes dull. So you can actually chart out the boundaries of the distended organ. This is classically done for a distended stomach. Succussion splash, it was discussed and described in detail by Dr. Rai and Professor Chintamani, is again a test which is done for gastric outlet obstruction. Dipping method of palpation has been described specifically for patients who are obese, where normal method of palpation may not be sufficient because of the presence of the thickness of anterior abdominal wall fat, and also in patients who have gross ascites. So it just means that you have to make flicking movement just to displace the fat or the fluid away from the viscera that you are trying to palpate, and with each movement, move cranially while the patient is asked to take a deep breath. Knee elbow position. Some of the examiners are very, very categorical that it puts the patient at a lot of discomfort, so it is not to be followed. And then, but there are still some tests which have been described, which are done in knee elbow position. Puddle sign is one of them, and test for retroperitoneal tumors or masses is another one. Now, always remember to look at the renal angles. Always remember to look at the back, to examine the spine, to check for any change in the curvature, any obvious deformity or any spinal tenderness, inspection and palpation. Always remember to inspect the genitalia, both inspection as well as palpation. And the last but not the least part of the abdominal examination is the rectal examination, which is again both inspection as well as palpation. So inspection, you have to check for itch and the scratch marks, any signs of excoriation, any presence of external openings signifying fistula in ano, any scars or warts, thrombosed external hemorrhoids, which may be present at the verge of the anus, sentinel tag of a fissure, which may denote an underlying chronic anal fissure or a simple anal tag, and Ask the patient to strain to find out if there is any perineal descent on straining, which may signify weakening of the pelvic floor and obstructed defecation syndrome. After inspection is the digital rectal examination, in which the patient is placed in the left lateral position. So always remember, you have to be very, very gentle. Don't poke the finger directly inside. Explain the procedure in full. Place the flat of your finger or the pulp of your finger on the external anal opening. Wait for the patient to relax before you introduce your finger inside. Properly done digital rectal examination will give you a lot of information, but improperly done digital rectal examination will be painful for the patient and will yield no information for you. So you have to look for luminal, mural, and extramural pathologies. Luminal means what is projecting inside, like a polyp. Mural means what is there within the wall, like a stricture or a growth. And extramural means what is present outside the lumen. So because rectum is in direct contact with the peritoneal pouch cranially, and in the males, prostate anteriorly, and in the females, cervix anteriorly, there is so much information that you can gauge by doing a digital rectal examination, not just of the rectal pathologies, but also of extrarectal pathologies. Always, whenever you are withdrawing your finger, look at the stain on your finger, whether it is normal fecal matter, or is there any blood, or is there any altered blood on the finger. So that's left lateral position. That is what I was mentioning. Place the pulp, wait for the anal sphincter to relax before introducing your finger. Be gentle, introduce your finger, turn it to face anteriorly in order for you to be able to palpate the cervix in females and the prostate in males, which are present anterior. And cranially over there will be the pouch of Douglas, where drop metastasis from an intra-abdominal malignancy may present as presence of a hard nodule of Bloomer shell. Now, general examination, the last two slides, sir. General examination relevant to abdominal examination would include pulse, presence of icterus, pallor, clubbing, lymphadenopathy, pedal edema, or obvious signs of liver failure and portal hypertension in the form of palmar erythema, spider nevi, or caput medusae on the abdominal wall skin. Always look for Trousier's sign, which is Burkow's lymph node, or left supraclavicular lymph node, which becomes involved because of the metastasis or the spread of malignancy through the thoracic duct onto the area where it joins the bifurcation or the amalgamation of the superior or the superior vena cava and the internal jugular vein and the brachiocephalic vein. It is a sign of metastatic disease, and it is positive in intra-abdominal malignancies, specifically gastric, hepatobiliary, pancreatic, and also breast and ovarian malignancies. Pedal edema may be also seen in patients suffering from intra-abdominal pathologies, specifically because of as a manifestation of hypoalbuminemia, which is basically which gives rise to decrease oncotic pressure and shift of fluid from the intravascular to the extravascular compartment, because the fluid retention power of the intravascular compartment is decreased. So albumin denotes the synthetic function of the liver, and in so many intra-abdominal pathologies, this may be deranged. It may be deranged in advanced chronic liver disease, in obvious liver failure, and also in severe malnutrition, which may manifest in the form of pedal edema. Although bilateral pedal edema may also be a sign of IVC obstruction, which may also arise secondary to an intra-abdominal mass pressing on the IVC and giving rise to a decrease in venous return from the IVC. So that is all.
Excellent talk. I give a huge round of applause. Wonderful, Dr. Anubhav. So all parts were covered, and I like this last 4 slides more, because very commonly this is ignored, and we are trying since first day to highlight the importance of Trousier's sign, looking for spine, looking for all these features in abdomen. So it's not just about, local examination of abdomen, which is what you do. I think very comprehensive presentation. Any questions from anyone? Any doubt or any confusion? Because it's so clear and crisp that I don't think there would be any doubt. Any questions from anyone? Omar, anything you didn't understand? And I'm glad you highlighted, and we should take home this message, that any test which is making a patient uncomfortable should not be done. And I am witness to a patient collapsing. It was a DNB exam in Calcutta. Obstructive jaundice patient, periampullary. The lady was put in knee, elbow, and she collapsed. I was examining here. The student was doing it. She collapsed, and then she was to be taken and resuscitated. So it can be very uncomfortable for the patient, and the information it is giving is not so sensitive, or I mean, you're not going to rely on it terribly. But as he rightly mentioned, and he covered it up, that these are some tests that examiners may ask you, and you can run into a fossil anytime. You never know. Yes, please. I'm glad. Identify yourself. Pass on the mic. Right, Sati?
Hello. So the ideal time that we need to auscultate for bowel sound.
So what you mean to ask is, how long do you have to auscultate in order before you can say whether they are normal or abnormal?
Yes.
So ideally, it should be between 3 to 5 minutes. Okay, but for want of time, minimum of 1 minute, you should auscultate.
So for saying that if the bowel sounds are absent, what is the ideal time that we need to?
So it is between 3 to 5 minutes. That is what is the standard which is given in the books. Anything, sir, from?
I agree. And actually, you can't be doing it always. If you heard before that, you won't hold on. So what he's trying to say is, before you actually say there's a silent abdomen, spend time. So three minutes plus. But 1 minute, you'll be able to get that answer in your exam. You usually won't get that case in the exam, but the question is valid and he's answered it. You have a doubt? You're happy? Good. She's happy. Any other? If there are none, thank you very much, Professor Bindal, for taking time out and coming in the afternoon, and staying through all the sessions. Thank you so much. And the last, Khalikur Rahman has rejoined for his abdominal presentation, but he'll have to wait because he could not connect. So we'll have presentation which we missed out yesterday due to a goof up. That is by Professor Gyan on the reflux surgeries, which will be comprehensive video presentation of the surgeries that are done for the reflux. So please join us.
Good afternoon, students. Thank you, Professor Chintamani, sir, for this opportunity. So I would be covering up surgery for the gastroesophageal reflux. And so beginning on with that. So as far as the surgery for reflux is concerned, you all are aware of the fact that the incidence of reflux is quite high, ranging from 10 to 30% in Indian population. And you would have many such patients referred to you in your surgery OPD from medicine. And I'm pretty sure about it, you would be dealing with a lot of reflux patients. So when would they require surgery? When would they be just done with medical management? So I would just cover up a bit. So by the end of this session, you all would be able to enumerate the indications of fundoplication and what is a preoperative workup. As a student, you are expected to know that. It could be asked in theory examination as well as in practical. And I would also describe the operative steps. I'll show you two videos. The most commonly performed procedure, the niacin and the DOR. I'll show you the video. These are the videos of our own patient. And then I'll talk a bit about complications. So as far as the indications goes, so any patient is not getting benefited with the PPI therapy would definitely be a candidate. But even if a patient is getting benefited, you read the line properly, esophageal or extraesophageal GERD symptoms. Extraesophageal GERD symptom mean anybody having a persistent cough because of reflux that are responsive but not completely eliminated by PPI, or heartburn eliminated by PPI but continued volume reflux. Patients keep complaining that he's having some acidic reflux in the oral cavity all the time. In Hindi, they would verbalize, muh mein tejab aata rehta hai. So even they are on PPI, they would get relief, but they keep having this volume again and again. And patients with a well-documented reflux events like chest pain, cough, or wheezing, and after we have ruled out the pulmonary causes for same. And patients with GERD complications like a stricture, Barrett's esophagus, or vocal cord injury while taking PPI twice a day, patient with well-documented GERD who desire to stop chronic PPI. They have been taking it for ages. Few patients would come to us who have been taking PPI for 3, 4, 5 years, although they get benefited, but PPI in itself comes with its own subset of complications. Pre-op evaluation, now you all must understand that one thing is a subjective evaluation, another thing is a objective evaluation. So we have nth number of scores being prescribed for GERD evaluation. One of the commonly performed or used score is GERD questionnaire. In the objective, as we have discussed yesterday also when I was taking your classes on X-rays, the gold standard for GER, of course, would be 24-hour pH monitoring. We have talked a bit about it yesterday. And the higher version of it, that is multi-channel intraluminal impedance pH monitoring, gives us a better picture as far as both acid and non-acid reflux are concerned. We, of course, have to subject the patient to upper GI endoscopy, CECT abdomen or barium esophagogram. We talked about barium esophagogram yesterday, but trust me, most of the time we are done with upper GI endoscopy and 24-hour pH monitoring. We would hardly be requiring any other investigation. If hiatal hernia is associated, then of course radiography would be required. So this is GERD questionnaire, which have few questions we ask the patients. It's available everywhere on the internet. You can have a look at it. So I won't go into detail, but you must know it's just a subjective assessment of the patient. And whenever you plan a management, you must have objective assessment as well. So we give few points to the symptom, and greater than 8 score is considered to be the presence of gastroesophageal reflux disease. Regarding the 24-hour pH monitoring with impedance manometry, usually we would stop PPI. Recently, they say they have newer software where they don't need to stop the PPI. But as a protocol in our unit, we always make it a policy that patients should stop PPI, else you would have false readings. Then latest software regarding the presence of acid reflux in the presence of esophagitis. So they are saying that in COD esophagitis, when there is an objective evidence that erosion of esophagus has already taken place, in that situation, even if you stop PPI or do not stop PPI, findings are not going to matter a lot. But in a lower grade of esophagitis, Los Angeles grading, this is a grading, which I'll show you in the subsequent slide. So in the lower stage, it becomes essential for PPI to be stopped. There is another newer modality which is known as Bravo pH probe wireless external. So what we tend to do is we put in a capsule around 5 centimeter above the GE junction through endoscopic guided, and we monitor as to how many times the acid had gone on to. The same mechanism applies for 24-hour pH monitoring also, but in that you have a tube. The patient has a tube in situ. Here is just a simple small device kept. So this is something new which had come up. And then, of course, we have multi-channel intraluminal impedance pH monitoring, which is very good because it would be able to tell us both acid and non-acid reflux. You could be asked about demister scoring. So it has few components. All these components are illustrated here. Total pH time less than 4, upright time less than 4 based on the person, pH less than 4 in the recumbent period. So after calculation of all these parameters, we devise one score. And if it is more than 14.72, we call it as a significant. And especially if a patient had come with a study with the symptom of reflux, and after impedance manometry, you find a score to be 14.72 above. In that situation, it's probable that the patient would require some kind of surgical management. This is a recording of one of our own patient. I particularly put it here for the knowledge of all postgraduate. In order to highlight that it's not always the acid reflux, what's the importance of impedance monitoring? Sometimes the patient might not be having much of acid reflux, but maybe having a lot of non-acidic reflux. This is actually a patient, an 18-year-old young girl who is having severe GERD. GERD score is the highest value that the patient could have. And when we are examining on impedance, we are not getting acid reflux. If you would just see the value, only 3 acid reflux, and the non-acid reflux is 38. So sometimes even a non-acid reflux could be a problem. So as we said, am I audible to the people in the back? Yeah. So as we said, 14.72 acid reflux Z-Mistel score, we have an objective value. How many non-acid reflux are normal? Yes, you. You have no idea? Okay, yes, you. So we have a parameter objective evidence for acid reflux and we plan our management. What about this young girl? She's having no acid reflux, but non-acid. So how many non-acid are normal beyond which I'll subject the patient to some kind of treatment? Okay, anyone here? Even single non-acid reflux is abnormal. What is non-acid reflux because of? It's because of bile. Why should bile pass through the stomach into the esophagus? Acid is still acceptable. All of us would have some kind of GER. It is only when it is pathological, representing a disease, we manage it. But even single non-acid reflux is abnormal. In that situation, we always put these patients on prokinetics. But we cannot keep giving prokinetics all the time. So even she would be a candidate for surgery. What could be the reason for such less acid reflux? The patient is having acid in his stomach, bile in the duodenum, the bile is going to the esophagus. Even when we look at the probe placed 15 centimeter above GE junction, still bile is going and no acid is going. What do you think could possibly be the cause? Okay, and would you like to give it a try? The patient was on a chronic pantoprazole therapy for a very, very long time. So acid separation might present with this kind of picture, and this confuses us. GRDQ score 18, acid reflux 0, and non-acid reflux 38. This is abnormal. Even a single non-acid reflux is abnormal. So you should know there's something known as biliary reflux as well. And we can get to know it only through intraluminal impedance pH monitoring. So, but esophageal manometry, why is very important? Because we need to rule out achalasia cardia as well. Imaging studies would have an importance, especially if the patient's having associated hiatal hernia. Then it becomes extremely important. This is Los Angeles classification that I talked about, where we grade the esophagitis on upper GI endoscopy, wherein we divide it into two categories, whether there is a mucosal breach or not. If it's less than 5 millimeter, it's grade A, greater than 5 millimeter, grade B, less than 75% of circumference involved, grade C, greater than 75%, grade D. So these are 4 categories of esophagitis. Now there are few kind of procedure that we do. One procedure is when we give a wrap anteriorly or we give a wrap posteriorly. So if we are giving a wrap anteriorly, just half, 180 degree, it is lap DOR, DOR. Or we can do it by open or lap. See, we are not here to discuss the approach lap or open. We are here to discuss what is being done. Okay. So especially there are few principles which I'll elaborate, and where we are going to either have an anterior wrap or a posterior wrap. The anterior wrap 180 degree is DOR, and 270 degree anterior wrap is known as THAL, THAL. Posterior wrap could be TOUPET, TOUPET, that is 270 degree, or it could be 360 degree complete wrap. Nice. Okay. So these are few important wraps. Principle is you have to carefully position the patient, because the surgeon is going to stand usually in between the leg if he is doing laparoscopic application. Okay. Proper positioning of the patient, safe entry into the abdomen, careful hiatal dissection so that we may not injure vagus nerve. Careful dissection of the esophagus throughout. Right vagus is posterior, left vagus is anterior. We have to save them. And we have to do proper mobilization. And we must have at least 3 to 5 centimeters of esophagus into the intra-abdomen. Elsewise, the reflux would break up. So these few principles should be followed. Complete mobilization of gastric fundus, hiatal hernia, if at all it is there, it needs to be repaired. And we have to create a wrap of around 3 to 4 centimeters. This is the patient positioning. The camera is on the head side. Patient is having head end raised. Legs are split. The surgeon is in between the leg. And the port position would be in a situation where we do fundoplication or any surgery related to hiatus. I always teach students and tell them to have a chest tube ready. We might end up injuring pleura. The anesthetist might tell us, yeah, the pneumothorax is happening. It can happen in few cases. So we must be prepared with the ICD. Port positioning, this is the way we would do it. We would put the camera port 15 centimeter below the Xiphias sternum and around inch around the left. And then we would have 2 ports in the mid-clavicular line, in between the Xiphias sternum and umbilicus, 2 ports here. And we make it a point that we have this 2 ports on the left above the umbilicus for the camera, obviously 10 or 11 mm, and then we would insert 1 port of 5 mm for the liver retraction, and then another port of 5 mm on the left subcostal for traction. So I will show you the video now. Here I had covered up the important 2 procedures. Yeah. So here first we have positioned the patient. We are inserting the Nathanson. So on the left side of the falciform ligament, we first made a aperture, and now this is a Nathanson retractor. This is our own patient whom we had operated last Wednesday only, and she was discharged within next 2 days. That's an advantage of lab. So we have, can you see this hiatus? This is the hiatus. Now the second gastrohepatic ligament division. Here we have to be particular in order to save the hepatic branch of the vagus and just save it. In few situations during RAP, it might have to be sacrificed as well. Now we are trying to make a space in between the right crus and the esophagus. Sometimes in chronic hernias or chronic GERD, there might be a lot of adhesions. So what we tend to do is we put in a bougie in the esophagus, 38 French bougie, that help us in the identification of esophagus so that we don't injure it. Here we have inserted a 38 French bougie. So we have mobilized the space in between the right and left crus. Now we'll have to mobilize the fundus. So we are doing is mobilizing the greater curvature toward the fundus part. As you could see, and we would proceed till we are able to completely bear the left crus of diaphragm. A point to be noted here, we would encounter short gastric vessels. We have to be very careful. An injury to them can cause a lot of bleeding and a lot of problem during the surgery. Till the time the total left crus of the diaphragm is bared. At the same time, we have to be careful. We do not denude the crus from the peritoneal folds. Elsewhere, the suture will not retain there. The muscle fibers will give way. So it's a complete mobilization of the stomach to be wrapped. Now circumferential dissection of esophagus. I've got the gastrohepatic ligament cut, the short gastric cut. Now the fundus part is with me. Now I'll mobilize the esophagus posteriorly. Here we have to be very careful about the right vagus and the left vagus. As I said, right vagus would be posterior, left vagus would be anterior. I would show you where the vagus is being there. So we are trying to mobilize without causing an injury. And since we have stented the esophagus with bougie, it's making things easier for me. Now you can see the posterior vagus and you could see the aorta posteriorly and right and left crus. And now when I'm taking suture, I make it sure that I'm not taking suture through the nerves or cut any other structure. So now we tend to do cruroplasty posteriorly. Why? Because the crura is arranged like this V. So they would be nearest posteriorly. It is easier for me to, do suturing posteriorly than to do it anteriorly. But in a very large hiatus, you might need to put few posterior and few anterior sutures. Now we are doing the wrap. The first suture is we take the uppermost part of the fundus with the left crus. And we are using non-absorbable suture. I'm using Prolene here. So for cruroplasty or for any such procedure which we need to get it done for a longer time, we will be using a non-absorbable suture. Few people would use Ethibond. So it should be primarily a non-absorbable. So as you could see, one of the suture I'm taking anteriorly, I'm trying to avoid taking it through the vagus nerve. This is an anterior vagus. Hope there would be a marker. It is wrapped now. So I was trying to avoid taking suture. This is an important critical step here. So we are doing a 180-degree wrap. This is laparoscopic door. And the reason we are doing it over the bougie is so that we don't end up in dysphagia. or we don't end up in a problem later. The bougie is letting the space sufficient enough. And when we are doing posterior chloroplasty, we leave at least 5 millimeter distance away from the esophagus. Another catch point. Else it will end up in dysphagia. So as you could see, the wrap has been done. We have to be very careful by taking the bites because IVC is nearby. Aorta is posteriorly. Now this is another video, a nice and fine duplication. This is also our own patient where the posterior chloroplasty has already been done. I won't repeat it again. So we are just starting on how we are doing a wrap. So our sign is being demonstrated. What do we call this sign as? He'll be demonstrating. I'm demonstrating shoe shine before doing a nice and fun duplication. So then we again have put in a bougie because the most important complication of niacin is dysphagia. So you cure the GERD and landed up in dysphagia. So in order to prevent that, we do it over the bougie, 38 French. So bougie is inside, then we are covering it up. So we need to take 2-3 sutures. We take the sutures from the part of the fundus that we are wrapping and also taking it through the esophagus. That will let the intra-abdominal esophagus remain in situ. Important principle is at least 4 to 5 centimeter of length of intra-abdominal esophagus should be there. Elsewise, before doing chloroplasty, if you don't ensure that, the reflux would come back again. Sometimes if you are unable to get this much length of esophagus, we do something known as Foley's gastroplasty. At the angle of His, we fire a stapler. Blue color cartilage, 6 centimeter, so that the angle of His becomes more angulated and we get sufficient length to be wrapped up again. Okay, but you must have a good length of esophagus so that we don't end up in a recurrence. Complications, acute could be infection, bleeding, esophageal perforation, dysphagia, long-term structural laxity, post-fundoplication stenosis, chest pain, dyspnea. Many patients would come with gas bloat, and majority of these symptoms would subside. So it's not that it's going to be permanent. And this surgery gives a very good relief to the patient immediately after the wrap, except for 2-3 days when they would be having a bit of edema at GE junction because you have mobilized the esophagus, you have put in a suture there. After that, the patients improve remarkably. These are few symptoms like abdominal bloating, inability to burp, postprandial, but majority of them would get settled. So now what does the evidence say? I came through this meta-analysis published in Surgical Endoscopy, where they are saying when they had a primary outcome to be dysphagia, secondary outcome, there was no statistically significant difference in these 3 procedures. As a practice, we would do more of lab dot because we feel that if symptom is getting relieved without fear of dysphagia, it's not a bad idea. But yes, for examination purposes, the best response for GERD would be with 360-degree wrap. Okay. Conclusion, proper evaluation of patient. Not every patient would require surgery, but there would be few subset of patients who would require surgery. Have your eyes and ear open for both acid and non-acid reflux. Okay. And if a patient is a candidate, this procedure can safely be performed with very good results, extremely excellent results. Thank you so much from the LHMC team. And thank you again, sir, for giving me this opportunity because I personally feel it's an important topic. Thank you, sir.
Absolutely, same here. And the way it was taught is also making it very, very important. And I'm sure they all benefited. You do get you get questions on bariatric surgery, reflux, then on X-rays that were covered. Everything is basically not only, there is a very famous Latin saying, non schola sed vita decimus. That is, you do not learn for school, but for life. So what he has taught you is not just because you got to crack an exam. Take your mind beyond it so you will find it more useful. Any comments?
Yeah, very nice talk, very spirited, very comprehensive. A few things I want to say. Use of PPIs for a long-term results in osteoporosis. So that must be avoided. I would say most GRDs are surgical disease because they land up with Barrett's and then malignancy. So the surgery should be the first. Medical treatment is just suppressive. They suppress the acid, but they don't address the problem, which surgery does.
So very well said. I'll completely agree with you because, these patients are going to medicine. And majority of these patients, you would notice, have ended up into depression and all, because just living a life with acid in throat all the time is too difficult. And the girl I talked about, she would be writing her exams next month and she would cry all the time because she has been living this life with acid in her mouth all the time. And we really don't understand that we keep prescribing them PPI. As you said, ultimately, the surgery benefit them on the second day. As soon as they undergo posterior choroidoplasty with flap, they are fine. And they're laughing. They're back to normalcy, except for a few days of edema, which would settle. We all know when we take suture through anything, there would be some edema. It would settle.
Right. Lifestyle diseases, lifestyle changes can be temporary, they are very difficult. Also, another point is if you find a person having extremely white teeth, think of reflux.
Yeah.
And what about the sharper ones? They got the problem on the other end. So think of Fisher, right? That's what they say.
So can I ask you,
Yeah,
I
please.
saw the suture material that you were using was PDS, was it Proline?
No, I
or
was
is
using
it
Proline, ma'am.
Proline? Is
Yeah.
that your suture material of choice, or is it that you don't have Ethibond, so you're using?
I will cover it. At that moment, we would
Yeah.
rather prefer Ethibond, but usually in the hospital supplies, we have Proline. So the science behind is it should be non-absorbable.
Yeah.
But I would agree with you, Ethibond would be much more easier, especially for the fundoplication part. But we would make it a point that it should be non-absorbable. PDS ideally should, being an absorbable suture, should not be used. And Proline, we have become quite comfortable with using it again and again. But you are correct. When I have to close the common enterotomy after doing Roux and Y gastric bypass or one anastomosis gastric bypass, I would use PDS 201 round body. In that situation, we're not desiring a permanent non-absorbable. So in any location where it has to be, this Proline or Ethibond.
Any question from the students?
Yeah,
Yes.
please.
Pass the mic to him. Identify yourself and ask the question.
Dr. Rakesh from Gangaram Hospital. Sir, it is said that if we divide the short gastric vessels, there is a long-term incidence of gas bloat syndrome. I've never understood why.
If you divide the, you said it usually,
Short
see,
gastric.
yeah, okay. See, there has been few evidences where they say that there could be gastroparesis after that. And it has been documented not only in this procedure, but also after splenectomy, whenever we are, cutting the short gastrics. But usually, long-term effect, it has been seen that there's nothing of this kind. No evidence is proving it objectively that there would be a long-term. As I also said, the patient could be symptomatic post-operatively. I enumerated that in acute as well as long-term complication. But majority of these patients would settle down with time. A good amount of collaterals develop. Because had this been the situation in a bariatric surgery like sleeve, it denuded the entire greater curvature, right? But ultimately with time, the body adjusts. It is momentarily, not a prolonged effect, at least not scientifically. But you are correct. It has been documented.
Any other question? If there is none, then thank you very much. Yes.
You want to, yeah, please.
No, he's carrying.
He was just passing the
He's
mic.
passing the mic. Surya, you have a question? No question? I have a question for you. How many short gastrics he showed that they were ligated and clamped? So ask that question.
How many short gastric?
You can answer that.
Okay, see, usually we would just mobilize the vessel which are coming in a way for the wrap of upper 5 centimeter. We do not denude the entire greater curvature. But when we are dealing with sleeve, a procedure like sleeve, there we are completely mobilizing
So
entire greater
here,
curvature.
I wanted to drag that point in
Yes.
to cover up Rakesh's viewpoint also, because in any case, he did not tie off all of them. So it is that, especially in sleeve, there is a likelihood.
Yes.
Otherwise, you're good. Okay. Right. Thank you very much, Dr.
Thank you so
Gyan, and
much.
please join us here.
Thank
There's
you,
one
sir.
more presentation. Big round of applause. That's now we have one presentation which is extra because he missed out, by Dr. Khaliqur Rahman. Dr. Gyan, you can join us if you wish. Dr. Khaliq, are you there? Khaliqur Rahman from JNMC.
Yes, sir.
He is there. Yes, Khaliq, you can start sharing your screen. We could not have you, and we had instead somebody present SOS that time,
Yes,
and
sir.
really was SOS.
Hello and very good afternoon to all my teachers.
Please start. Harsh, allow him to share the screen, please. After this, we'll break off for lunch, so don't worry. Yesterday I forgot, but today I'll remember.
Sir, can I ask whether my screen is visible or not?
It is. It is. It's gone now.
Okay, sir.
Only you are visible. Share the screen now, right? And you're looking good. Is something stopping you from sharing? Please keep talking. We have problems with the virtual presentation. We've had enough, actually.
No, sir.
Can you
I'm
share your
having some
screen?
difficulty.
There'll be a link coming, which will ask you to start. Click it quick. It stays there for 30 seconds only. Keep talking. We have problems with the virtual presentation. We've had enough. Had you opened up your PowerPoint and minimized it and then opened up your connection, it will work better.
Screen share हो रही नहीं हो रही है.
See, we're very
Sir,
tight on
can
time.
I ask, sir, whether my screen is visible right now or not?
Not at all. Only you are visible, sir. Start sharing your screen. Enough is enough. Is there a problem? You first open up your PPT, minimize
Sir,
it, then
I
share
can't
this.
get the option of screen sharing, sir.
Harsh, you've given him the option? He has given you the option. Everybody has been sharing so far. Yes. Now you're there and don't fiddle with it. Start.
Okay,
please.
Sir. My topic is obstructive jaundice, sir.
See, first of all, don't tell us your topic. You just present your case. All right. Otherwise, we know that you know the diagnosis. That's not what you would be doing. Just start presenting, please.
Now I have difficulty in moving.
Allow him the freedom to move, Harsh. Click on the screen first and then it will move. Yes.
Sir, my patient is a 58-year-old male. He's a resident of Aligarh only, and he's a farmer by occupation. So the chief complaint of the patient was yellowish discoloration of eyes and urine for the last 6 months. The patient was apparently well 6 months back when he developed yellowish discoloration of eyes and urine, which was insidious in onset, progressively increasing. No waxing or waning was present, and no prodromal symptoms before the onset of jaundice. Sir, there is a history of loss of appetite and loss of weight for the last 6 months. He has lost around 10 kgs for the last 6 months. There is a history of passing a clay-colored stool for the last 3 months. And there is itching all over the body for the last 2 months. There is dull aching pain over the right upper abdomen. And there is no aggravating and relieving factors for the pain. There is no history of fevers with chills and rigors. There is no history of black tarry stool. And there is no history of vomiting or hematemesis. There is also no history of any swelling. There is no history of alteration in bowel habit. Semi-solid stool the patient is passing semi-solid stool once a day. There is no any urinary complaint and no systemic signs of metastasis. The past history, there is no similar illness in the past, and there is no history of any previous surgery or medical illness as given by the patient. The patient is married with 2 children. The health of both spouse and children are healthy. There is a mixed diet, no addiction, and sleep pattern is normal. Socioeconomic status of the patient is very poor. The parents, both of them died out of natural cause of the patient. The siblings, their two younger sisters, both are healthy. There's no history of similar illness among the family members. The patient visited private clinic near his hometown, and the patient was referred from there to JNMC OPD for further management. There is no history of any known allergy. Summarizing my history, the 50-year-old gentleman presented with history of yellowish discoloration of eyes and urine for the last 6 months, which is insidious in onset progressively. Initially painless and later with dull aching continuous pain, no waxing or waning, no prodromal symptoms and loss of appetite, weight for 6 months, passing of clay colored stool for the past month, itching all over the body for the past 2 months. No history of fever, vomiting, black colored stool, no history of alteration of bowel habit, no urinary complaint, patient has no other systemic symptoms.
Good history. If you reading it, that's a different story. Now, what do you understand by the sleep pattern?
Sleep pattern, the patient is having no complaint during
What
the
is
sleeping.
why this history in this patient is important?
Sir, there might be, sir, itching which can cause the patient to awake. There might be difficulty in sleeping.
Patient has itching.
Yes, sir.
If you don't know,
But
I'll tell
currently
you.
the patient is not having difficulty in sleeping.
Anybody? Yes, stand up and speak. You're right. Stand up and speak, whosoever. The hepatic jaundice or the hepatitis or one of the features is the reversal of the sleep pattern. So they sleep more in the day. That is what is the relevance. Scratching is a different thing. It can happen due to scabies also. And which were the organs that were affected by, which were the parts of the body, sorry, where the scratching was happening or the itching was happening more?
Sir, the patients of obstructive jaundice usually...
No, this patient. Forget about patients obstructive jaundice. Your patient.
Yeah, sir. They're more in the trunk area. Sir.
Okay. Anything else that you would like to know in that scratch mark that the patient can complain?
Sir, the patient, the scratch mark can also be present with some bleeding. Sir, I would also like to ask if there is any discoloration in the skin.
Based on history, I mean, it's no rocket science. Obstructive jaundice is what you're presenting. But
Yes,
based on history, what are you thinking?
Sir, based on history only, sir, there is the differentials of obstructive jaundice will be on my mind.
Great. So where do you think is the obstruction?
Sir, the obstruction might be, sir, in the common bile duct or
anywhere.
Sir,
is it a benign obstruction, benign etiology, or a malignant etiology?
So the history is suggestive of malignant etiology, as the patient is complaining of a history of weight loss and for the past 6 months.
Anything about the progression of the disease which can hint towards it being malignant rather than being benign? One is, of course, 50 years is not a very old person these days. 50 is a new 30 or 40, maybe. So,
Sir,
what is the characteristic?
Sir, I've also taken the history of waxing and waning of the jaundice, which the patient is not.
That has nothing to do with this. Anything else? Clay-colored stool would be present in obstructive jaundice.
Yes, sir.
What is the characteristic of a malignant obstructive jaundice?
Sir,
painless, progressive,
painless progression of jaundice. Yes, sir.
3 Ps: painless, persistent, progressive, and pale stools. So they can add one of the 4. So it will be easier for you to understand. Intermittent, etc., are usually with benign condition, rarely with malignancy, except one where again it is not so intermittent, that people tend to sway too much towards calling it intermittent. It's not. It's a mild drop only that happens. And it's not in the level of jaundice that drops. The patient starts feeling better, appetite improves, but the icterus may persist. So be careful about that.
Yes,
can we move to examination?
I just want to ask him.
Please, please.
Yeah. Okay. So by a history, can you make out where, or can you rule out what kind of pathology, and if it is malignant in a periampullary region, what kind of pathology can be ruled out by a history?
Sir, as the patient is not giving history of vaccine or being of the disease, we might rule out periampullary carcinoma because it is associated with
Maybe.
very
I
ampullary
think
scar.
that's a wrong statement. So don't be loose with it. Periampullary is a broad term, and ampullary variety of periampullary will have fluctuation. I spoke just now. Okay, I'll ask you a question. Sorry, if I may. Intermittent, classically intermittent jaundice is seen in which kind of obstructive scenario?
Classically, intermittent is seen mostly in the periphery and choledocholithiasis.
Yes, there you are. So the Charcot's triad, intermittent pain, fever, and jaundice. So you don't get classical intermittent jaundice in malignancy. I think it gets people tend to believe it's intermittent in ampullary variety of periampullary carcinoma. That's not true. It doesn't happen so frequently. With stone, it happens frequently. Can you tell us how does it happen in stone? Why does it fluctuate?
So the stone, the stone is passing through the ductules.
Anybody here? We want it to be interactive. Anybody here? You keep talking about Charcot's triad, intermittent pain, intermittent fever, intermittent jaundice. With a stone getting stuck at a point, proximal part of the duct keeps on pushing it and dilating. Then it slips back, some bile passes, it gets relieved to be stuck again. So it's always tumbling. So that is why you get it in stone. The malignancy associated intermittent or not intermittent, reduction in jaundice off and on is for a different reason. If you have anything else, we
Yeah,
can discuss.
you said there's no melena, or what are the causes of melena in a case of obstructive jaundice? What could be the causes of melena?
The history of melena is important because there is a sloughing off of the tissue along with the bleeding that may
Which tissue?
be pancreatic tissue in case of pancreatic cancer.
Pancreatic tissue sloughing. There could be duodenal involvement of the duodenum.
Ampullary variety can produce that, and it sloughs out. You could have been more clear with that. It can slough out, and melena is not always due to only one cause, which is what you people remember. Like fluctuation, you would not thinking of benign cause. You would think of the same ampullary because your mind is there. The hemobilia can happen along with the usual stone also. It can happen with malignancy also. So there are many reasons for melena. There could be associated malignancy. So it could be a malignancy with the GI, which has got, either due to lymph node, there's a block to the flow, like you saw the case in the morning of a cancer stomach. So there are so many reasons for melena. Yes, doctor.
Kalikur, you said that the jaundice is progressive and there was no history of waxing and waning. What exactly did you ask the patient to elicit this history, based on which lot of our differentials are based upon?
No, it's not waxing and waning, he said.
I'm just asking what history did he ask to ascertain whether it's a progressive or a waxing or waning jaundice? What did you ask the patient in order to elicit this history? What kind of jaundice it is? Is it progressive, intermittent, whatever? So what question did you ask patient?
So I've asked the patient about the pattern of the progression of the disease, so as to the patient.
See, patient would not be able to
The patient
differentiate
yes,
if
sir.
eyes get stained, if sclera get stained. It won't get de-stained so easily to be noticed by the patient. So would you ask some specific question in order to elicit this history?
Sir, the family members noticing the discoloration of the
No, that was the reason I had asked this question, because I could sense that the very basis. Anyone here? Yeah, color of the stool. So it has been answered by the students in the audience. Usually once sclera get stained or skin get stained, the changes will not be appreciable. Though there may be biochemical changes, patient will not, we are yet on the history. So the color of the stool would be quite a specific, where clay colored would go toward bit normalcy and would get back to clay, which would be more subjective evidence, which could be elicited from the patient. Yes, sir, please.
Sure. Examination, please.
The patient was examined in a well-lit room, conscious, alert, cooperative. ECOG score of 1. Build was average. BMI is 22 kg per meter square. Hydration status of the patient was well hydrated. Peshi is normal, gait was normal. Pallor was absent. Icterus was present. The cyanosis, edema, clubbing is absent. Neck veins not engorged. Cervical lymph nodes were not palpable. Pulse rate was 76 beats per minute regularly, and the blood pressure of the patient was 126 by 84 millimeters of mercury. Respiration 16 beats per minute, abdominothoracic respiration. Temperature was normal. No scratch marks, pigmentation, or no obvious deformity. Abdominal examination, inspection. The shape and contour of the abdomen is scaphoid, umbilicus centrally placed, inverted. Skin over the abdomen, there was no scratch mark. No scar marks, pigmentation, or engorged vein. Movements, all the quadrants are moving normally with respiration. No visible peristalsis or pulsatile movement. No visible swelling over the abdomen. Hernial site, there is no swelling or expansile impulse on the cuff. External genitalia is no abnormality seen. Coming to the palpation, temperature was normal, non-tender, soft and elastic, palpable lump over right hypochondrium extending to right lumbar region was present. And on deep palpation, no tenderness over deep palpation. Gallbladder was palpable. Over right hypochondrium extending to right lumbar region from right costal margin to the midclavicular line. 5 centimeter into 1 centimeter. Globular shaped smooth surface. Well-defined lower medial and lateral margin. Upper margin was not palpable. The lump was hard in consistency, moves up and down with respiration, slightly moving side to side. Intra-abdominal on leg raising test. Skin over the swelling was normal, not fixed to skin. The lump was not fixed to skin. No other palpable swelling and hernial site and genital were normal. On percussion, it was dull over the lump, resident over the rest of the abdomen. Upper border of liver dullness, fifth intercostal space, over right midclavicular line. There was no fluid. Auscultation, peristaltic sound audible, and DRE was also normal. Non-systemic examination, cardiovascular, respiratory, and CNS were within normal limits. And spine and cranium was also normal.
Wait, somebody आ जाओ, फिर obstructive jaundice की diagnose पे शुरू हो जाओ discussion को. Just stop.
Yeah, go on.
Discussion.
So a 50-year-old gentleman presented with a history of yellowish discoloration of eyes and urine for the last 6 months, which is insidious and onset progressively. Initially painless and later with dull aching continuous pain. No waxing and waning, no prodromal symptoms, loss of appetite, weight for 6 months, passing of follicular stool for the past 3 months, itching all over the body for past 2 months, no history of fever, vomiting, black colored stool, no history of alternation bowel habit, no urinary complaint, and patient has no other systemic symptoms. On general survey, nutrition is poor, patient is jaundice, no cervical lymphadenopathy. On examination, gallbladder is palpable 5 cm below the costal margin, non-tender, hard in consistency, moves up and down with respiration. Medial lower lateral margin palpable, upper body not palpable. Liver and spleen were not palpable. No other mass is palpable. No free fluid in abdomen. Normal
Dr. Rahman, just give us a brief. Don't read the whole thing out again. Okay. Yeah, go on. Okay, go on.
Please finish it.
Yes, sir. I have done.
You're done
with the examination.
Let's start with your first slide of examination. Everything fine, and BMI is 22, not kilogram per meter square, right? It's a number. Next slide. Go back to first slide only, please. Sorry. Go back. What do you mean by facies normal?
On general examination,
I saw your patient's face. It doesn't look like yours. And which of the two is normal? What were you looking for specially? You got to be specific. You're going to become a surgeon.
Sir,
what did you look for? What are you trying to tell us? Which faces you're looking for?
Sir, overall, sir, nutrition of the patient. And
so what faces you're looking for, sir? This column, if it was not normal, what would be filling this space? Your Hippocratic faces. What faces are you looking for? So you're unnecessarily mentioning it. That's what I wanted to highlight. You looked for gait. I'm so glad. Why did you look for gait? Just completing a checklist doesn't make a surgeon. You must have a thought. It is relevant. I'm telling you it's a good point. But what is it that you're looking for? Next slide. Pallor absent. Manjeet present. Sunjit absent. Makes no sense. There is no pallor. Icterus is present. Cyanose is absent. Edema absent. Clubbing absent. Neck में absent ही होते, तो A P लगा दो इन पे. Present like a postgraduate. There is no pallor, although there is icterus. And they will ask you questions as to how did you comment on it with the icterus being there. There is no cyanosis. Mostly, luckily, fortunately, in the exam, you don't get cyanosed patients. Which edema is absent? Hello?
Pedal edema, sir.
So say pedal edema. No pedal edema. Then the neck veins are not engorged. Clubbing absent. Now we will put, there was a class that happened just now. I'm getting a little worked up because you should have attended a class which was happening while you were still online. And he talked about it, right? That you need to describe the stigmas of liver disease. That would have made more sense. That would have taken care of it. Next slide. Cervical nodes not palpable. That means groin nodes are palpable. Axillary nodes are palpable. The term to be used is no generalized lymphadenopathy. 3 days of scrubs classes have been happening. You could have attended. Respiration, no scratch mark, no scratch marks. Patient is having itching.
Yes, sir. The patient is having itching.
What do you do when you have itching? So where are the scratch marks absent? Which pigmentation you're talking about? And which deformity you're talking about? Sir, this is a different course. I'm sorry. Here we don't do run-of-the-mill stuff. This is, you are here, we take it seriously. You must go back learning. There's no point creating a copybook, checklist and ticking it. Next, one you don't know about it and you mentioned it. Now here, inspection, shape and contour. Is it scaphoid shaped abdomen? I'm only asking you. You have to say yes or no.
Yes, sir.
What is the bulge in the epigastrium? I don't know. It is visible. Is it visible? I don't know. Umbilicus is centrally placed, inverted, skin over abdomen, no scratch mark, no scar mark, pigmentation. See, I have to tell you something. Presentation at a postgraduate level is slightly more professional and better in the sense that you are able to put down points more clearly. You're just reading the bulleted points, most of which are actually not right. All the quadrants are moving normally with respiration, no visible peristalsis or pulsatile movement. Pulsatile movement would mean what? What are you trying to imply here? Please answer.
No, sir. There is no any relevance to this point
And
here.
don't switch off your camera. Stay there. Virtual,
Yes, sir.
there are no visible pulsations. Okay. Hernial sites are normal. Okay. External genitalia normal. Next slide. I'm correcting the basics because the students here who should not take back home anything wrong. Superficial palpation. Temperature normal. What do you mean by temperature? Where? Abdominal wall temperature.
Abdominal wall, yes, sir.
Okay. There's a palpable lump over right hypochondrium extending to right lumbar region and no tenderness over deep tender point. What is that?
There is no tenderness or deep palpation.
No, what does this sentence mean? No tenderness over deep tender point. I'm not understanding. That's why I asked you. I deliberately went back. We are not discussing obstructive jaundice with you, something that you're very happy about. Next slide. We've had enough of that. Gallbladder is palpable. Wonderful.
Now, if the gallbladder is palpable, where would you palpate? Right hypochondrium.
Right hypochondrium.
So this lump is gallbladder according to you. Is that right? Then
Yes,
you
sir.
don't need to describe palpable over right hypochondrium. There is a lump which is probably palpable gallbladder. And it's extending onto the right lumbar region. Most of the time, gallbladder extends to the lumbar region. And it is about 5 centimeters. You can measure its size and tell us, which you have mentioned. Globular, because they already described it as gallbladder. So we don't need that. Well-defined lower medial, that is why it's a gallbladder. Next slide. It is hard in consistency, moves up and down with respiration, slightly moving side to side. Anything that has to move with respiration can only move up and down, right? So it moves on respiration. And if it is moving on respiration, what does it indicate?
It is a the gallbladder lump.
No, which all lumps move with respiration?
So it's connected with diaphragm.
Good. Or connected with anything which is connected with diaphragm. So that is okay. Now, if it is moving on respiration, is it intraperitoneal, intra-abdominal, or it is parietal?
This one is intra-abdominal.
No, I'm asking you a direct question. If it is moving on respiration, can it be parietal ever?
No, sir.
This is an MBBS question. We are discussing MBBS stuff right now. And then you mention intra-abdominal leg raising test. So you reanalyze your own presentation. I'm just telling you the points. Next slide. Liver is not palpable, right?
Yes, sir.
And there's no free fluid. Peristaltic sound audible. I mean, bowel sounds audible. Okay. And perical examination. No palpable mass, fecal staining present. Was it clay-colored stool that you got on the finger?
Yes, sir.
But that you did not mention here. Next slide. I'm sorry I'm taking that time because so many errors in their mind and they just go through the run-of-the-mill, points. Others should also learn. It's not about him alone. Next slide. Now you can easily tell us finally your impression. I wouldn't waste time here because it's going to take a lot of time. Because
The
in
impression
summary,
of
alteration, no history of alteration of bowel habits, no urinary complaint doesn't come. Summary is about the problem and what is missing. So there's a lot missing here. I would not spend time here. Please tell us your diagnosis.
sir, carcinoma gallbladder.
So give us a diagnosis like you should. How old is your patient?
50 years, sir.
If somebody is prompting you, better don't listen to him and tell him to keep quiet. He is disturbing you. Maybe you could answer better if you think. 50-year gentleman with obstructive jaundice, probably due to a malignant etiology, likely to be, you're saying carcinoma of gallbladder, cholangiocarcinoma, periampullary carcinoma. Can you tell us 1, 2, 3? Why are you thinking 1? And why are you thinking 2? Why are you thinking about 3?
Sir, one carcinoma gallbladder because of the obstructive jaundice of the patient, the heart lump inconsistency. Heart gallbladder is palpable on the examination.
In
It's
your
a
description of gallbladder, it looked like a very normal mobile gallbladder, which did not have the features of surface being irregular. At least I didn't read them. And consistency being hard. It looked like just a ballooned up gallbladder.
Or just a hard gallbladder doesn't make it malignant, which is nice and smooth and hard.
Now, please tell us, is the patient started with jaundice or started with something in the abdomen?
Sir, the patient started with dull aching pain is also there, sir.
So is jaundice early in cancer gallbladder or late?
Yes, sir. In cancer gallbladder, the jaundice is late, sir.
In your patient, was it early or late?
Sir, late, sir.
So your patient got jaundice after how many days of the first symptom?
that the patient is giving history of, sir, 6 months of jaundice.
You did not mention that, so we didn't hear it. So what was the first symptom that patient came with?
Sir, the patient was complaining, sir, of pain.
No,
in
you
the
gave
right
us a
abdomen.
history of jaundice of 6 months. Right?
Yes, sir.
तो बेटा 6 months jaundice से start हुआ ना, तो lump तो था ही नहीं ना, pain था. So it started with jaundice, and there is a palpable gallbladder. What is the problem? The problem is the gallbladder that you are describing. Can you tell us more about the gallbladder? What was the consistency, mobility, surface, etc.?
Smooth, and the gallbladder is the
What is the consistency?
consistency is hard.
Okay. And the lump was noticed by the patient or you found it?
No, sir. The lump was not noticed by the patient.
So patient only had jaundice.
Yes, sir. As per the history, the patient only has jaundice and itching.
So it is unusual, right? It is possible, but not probable. That's why and then you kept a diagnosis of cholangiocarcinoma. Which cholangiocarcinoma?
Yes, sir. Sir, distal cholangiocarcinoma.
So is it written there? So
No,
I
sir.
can think of a hilar cholangiocarcinoma where the gallbladder would have no business to be enlarged. So you need to be more, prepared for your presentation. Which year you are? First year, second year, third year?
Third year, sir.
There you are. See. Now, would you like to revisit your diagnosis? I'll come back. Anything you want?
Okay. Let's come back to carcinoma of the gallbladder, your first diagnosis, right? Now, how will you manage this patient? This patient's come to you in your OPD. You think it's a carcinoma of gallbladder? What will you go about doing? How will you manage?
Sir, I will go for investigations like ultrasonography and LFT. First,
Okay. Anything
USG
else?
of the abdomen to confirm the organ, sir, to look for the consistency and the wall of the gallbladder and other lymph node status and the ascites and liver echo texture to look for any secondaries.
Okay, you've done the ultrasound, and what
Yes,
else? LFT you've done. So it says mass in the gallbladder, and there is obstructive jaundice. Now, what will you do?
Sir, I will go for the other investigation so as to look for the stage
Okay, no,
and
you admitted
resectability.
the patient from your OPD. Now, what will you do? How will you manage?
Sir, after admitting the patient, I will, sir, get the blood work of the patient. So
That you've done. You've done.
So, sir,
For a jaundice patient, what are the basics for management?
Sir, for the obstructive jaundice patient, sir, first of all, sir, I will hydrate the patient because these patients are dehydrated
But your
because of
patient
the
is
third
hydrated.
space.
Okay. What else?
Sir, deranged due to deranged liver function test, there is a bleeding tendency. So, sir, I will also add injection with vitamin K in the treatment card.
Okay.
And, sir, there is a there is a chance of gram-negative septicemia in these type of patients.
So antibiotics.
So,
What else?
antibiotics.
What else?
And there is also I will also measure the glucose level of the patient.
Okay, nutrition. Okay, now you've
nutrition.
done all this. Now, what's the next step?
The next step, sir, will be to
How
get
would
a
you manage the
CEG.
itching? How would you manage the itching?
Sir, by cholestyramine, sir, giving cholestyramine.
Anything else?
Ursodeoxycholic acid, sir.
Okay. And the antihistamines, ursodeoxycholic acid,
Antihistamines, yes, sir.
cholestyramine, even rifampicin, they all used.
Right, Khalik? You must be understanding. We are not here to pull you down, but you're already there. But the myth should go, and the purpose of a classroom is to take away that veil. And that veil is you continue to believe and you live in self-denial that I am all right, and then you'll never correct yourself. It is our duty to tell you that there are problems. The presentation was much left to be done properly, and therefore your differential is also all over the place. They don't connect, right? So if this was a carcinoma gallbladder and the patient presented like your patient has, do you think it's a resectable disease? Would you go for surgery, or you think it is late?
Sir, I think it's late presentation of the patient as because of the there is
So
visible.
what would you offer to this patient who has got a carcinoma of the gallbladder? How would you confirm that it is carcinoma of the gallbladder? You may be treating the patient and may turn out to be something else. You've done your ultrasound, all right. There's a lesion in the gallbladder.
Sir, first of all, sir, there is actually not much role of CT in this type of patient because there.
Agreed. Next.
And sir, to confirm the diagnosis, sir, I can go for FNAC so as to confirm the
This
diagnosis.
is one scenario where you can do FNAC and reach some kind of a diagnosis so that you can treat the patient. Okay.
Yes, sir.
Now, Dr. Sahai was asking you about palliation. So you mentioned about itching being managed by cholestyramine, antihistaminics we added. What else can you do?
Sir, we can go, sir, if the patient is presenting with the, it's not in this patient, but if the patient is presenting with the obstructive symptoms like sir, vomiting or not passage of.
So how do you palliate his jaundice, which will indirectly take care of the pruritus?
Yes, sir. So, sir, percutaneous transhepatic biliary drainage can be done.
Yes. Why not an endoscopic stenting?
Sir, endoscopic stenting mainly helps in the patients of sir, distension abdomen or sir,
Hello?
if there is.
No, stenting is mostly done endoscopically. People go from below up. Why in this case PTBD?
Sir, carcinoma of the patients are metallic stents are mainly.
No, didn't ask that question. My question is, why not from below? Why from above? What is the level of obstruction? How do carcinoma gallbladder patients get jaundice?
Sir, portal lymph nodes compressing.
Lymph nodes at porta or direct infiltration? Okay.
Yes, sir.
And direct infiltration is rare because most of the cancers of gallbladder occur in the fundus. So this could be porta block. So the stenting from below may not be very useful, may not be effective. And yes, you're right, PTBD will be the answer. And you can even put a stent from that route, which can be metallic, expendable, etc. Those kind of stents. Anything to palliate his taking care of his nutrition, fluids, feeding. Would you like to do something about that also?
Sir, if the patient is fine, we can go for exploration.
Is your patient fine? You will go for exploration.
Yes, sir. Duodenal jejunostomy, duodenal gastrostomy can be done, sir.
Have you ever seen a duodenal jejunostomy being done for carcinoma gallbladder?
No, sir.
So what are you saying? I'm not following you. It's a carcinoma gallbladder, no?
Sir, what was the question, sir? Pardon me.
I had asked already and you heard it also. So I won't repeat the question. I've done enough of this. So virtual also I've done enough of it. So I think I'll go to the next question. My question is, you are palliating the jaundice, that is done. What do you do for the nutrition?
Sir, I will, sir, ask the patient to protein-rich diet and, sir, glucose-rich diet.
He has good appetite. He'll take it on his own. He'll go home and eat it.
Sir, if Sir, this patient he's having good appetite and he's taking orally. If not, if any other patient not taking orally, we can go for parenteral nutrition. Sir.
Okay, this patient has got good appetite?
Yes, sir. Currently he's taking orally.
In spite of it being carcinoma, gallbladder, obstructive jaundice, that is remarkable, but that's okay. You'll know better. So would he, if he is not able to take it adequately, what would you do? What are the
Sir, we can
options
go
to
for
provide enteral nutrition?
Yes, sir.
Enteral nutrition, what are the options you will provide?
Sir, protein-rich diet and other.
But how would you give it to the patient? Your patient may not be able to take it on his own. That is what we are trying to constantly tell.
The rice feeding can be done.
Yes, you can do nasogastric feeding. We call it
Nasogastric
Child's
feeding can
tube
be
is
done.
not nasogastric tube, so don't confuse it. Or a nasojejunal can also be done, or a feeding J can be done. There are so many options, right? So how did duodenojejunostring come to your mind? Somebody's prompting, dear. Because usually it involves the duodenum, you're right, and it blocks the duodenum. But then that's not what we are talking about. We are talking about now.
Yes, sir.
Any chemotherapy for these patients?
Sir, there is not much more role of chemotherapy, sir, in this, but
Anybody here? Just speak loudly. Where is the mic? Why are you sitting quietly? So it has to go on Zoom. No?
Capecitabine and oxaliplatin in
Rishi, you come in
deletion.
front and sit in the front. Huh? Yeah.
Most of the-
Capecitabine and oxaliplatin, yes. And what any data to say that it is beneficial? Limited role. So it's mostly a surgical disease, but then you should manage it only surgically if the patient is resectable. Is there by any chance a possibility of it being periampullary carcinoma and you reading the gallbladder wrong? With a classical obstructive jaundice and a palpable gallbladder. Is it possible?
sir, yes, it is possible. Sure.
Now, if the patient presents first presentation is jaundice, and if it is presenting the manner your patient has, that seems like a higher probability. And you can cover cholangio and periampullary only. What is periampullary carcinoma?
Sir, carcinoma in, around 2 centimeter of the ampulla of the pancreas.
What are the various types?
Sir, carcinoma head of the pancreas, sir, ampullary carcinoma, and sir, carcinoma involving the duodenum near to the ampulla.
Now I'm searching for places to mark you. So which of these has the best prognosis?
Sir,
Which one tends to slough out frequently and relieve the patient?
sir, ampullary carcinoma.
Ampullary variety of periampullary carcinoma.
Yes, sir, ampullary
Which will
variety of.
slough out and produce melena low down simultaneously, and improvement in appetite. Patient starts feeling better because that's what subjective assessment of patient's jaundice getting better. And eventually, last question before I pass it on to them if they have any. If you have a periampullary carcinoma presenting like this, would your approach change? Because you've done ultrasound. What will be the characteristic of this gallbladder when it just due to congestion, it is enlarged?
So on ultrasonography, I would, sir, look for the wall thickness of the patient of the gallbladder.
Any
The
irregular
wall,
thickening inside or
irregular thickening inside, yes, sir.
lesion,
The
polypoidal
peripolycystic
growth?
fluid.
Okay. And the lymph nodes, right?
Yes, sir, lymph node status.
Any question? Any question?
So just a comment for everyone here. See, whenever you are getting a case of obstructive jaundice, majority of you would feel as if now you got something, of your own interest and you would be able to fare very well. But sometimes things could turn other way around. So whenever you have a patient with obstructive jaundice, in history itself, make it clear whether it's a medical jaundice or a surgical. In surgical, whether it's benign or malignant. Sir has enumerated almost all the points, but I'm yet to see few points in history, like history of blood transfusion, history of previous surgeries. There's so many histories that you need to elaborate down line from there itself. In examination, there's something which is known as palpable gallbladder, and another thing is gallbladder lump. Palpable gallbladder means when the gallbladder retained its shape. What he has described was more akin to the palpable gallbladder and not gallbladder lump, but he used the word hard. You know, that's how the entire thing had got turned down. So if gallbladder is hard and is not retaining the shape and irregular margin, you make a diagnosis of gallbladder, gallbladder carcinoma, and never make a diagnosis of carcinoma gallbladder in exam till the time you have this kind of description. A hard, palpable mass in the region of gallbladder, which is not maintaining its shape. And it has an irregular margin. Here we are getting mix of both the world. And that's why the entire, and what sir said, I completely agree with him. It's a finding of the gallbladder which seems incorrect, and the patient would suffice mostly in some other category of malignancy, right? Another point for all student, whenever you make diagnosis, the way he has made, always diagnosis as three element: anatomy, physiology, and pathology. Anatomy is gallbladder, physiology is jaundice, and pathology is carcinoma. All three components should come. None of the three components are there in any of the diagnosis. We know majority of the time you get to learn the diagnosis from PGs or whosoever at allotted case, and things takes a completely different term. No one is interested in you knowing the diagnosis. I think for the past 3-4 days, what sir has been emphasizing, it's an approach, just an approach. And it could have been a bit different. So whatever sir has said to you, Khalikur, is just to improve you. Okay, take it in a positive way, and I'm sure you're going to do great in your exam.
Thank you, sir.
Any questions from anyone? Any question you have, colleague?
No, sir, most of the points are covered.
Where are the problems in your presentation? Should I tell you?
The slides, sir.
No, I'll tell
more
you.
than-
I'll tell you, don't worry. Even if you present a hernia also, it's not a small case. But never ever try to stick to somebody else's instructions. Make your own mistakes so that you can correct them for yourself. And learn from others' mistakes also. That is why there are CMEs of these courses. You should have attended from day one all the presentations. Today, your presentation would have been totally different. Based on your presentation, Dr. Ratna and others both were saying, and your previous presenter also, that they're not watching others' presentation. Your life is too short to learn only from your own mistakes. You should learn from others' mistakes also. But you're neither bothered about that. Most of you are into finishing your residency somehow. And somebody mentioned it as a hurdle to reach into MCH, the most, abnormal way to approach your career. This is the most important thing in your career. If you don't become a good surgeon, you can become no neurosurgeon, no cardiac surgeon, be under no confusion. We are facing this problem because fortunately we have seen both sides of the story. We are receiving residents, senior residents who have no understanding of surgery. It happens mainly because teaching is got limited to virtual slides, which you just create a situation and present it. Your findings don't collaborate with what you mentioned. So therefore, for your own good, make presentations, present regularly, and don't feel happy about it. I'm not trying to give you any marks, but I'm trying to tell you very, very frankly, a good teacher is not a grandparent. He's a parent. Grandparents pamper their children, right? Grandchildren, because they have nothing to lose. Parents are worried. You would see that, grandchildren and grandparents make perfect friends because they don't tell anybody your problem, They're happy. Oh, you're the best. You are not the best. So you improve. A good mentor is a parent, not a grandparent. And that's what I'm doing. I'm trying to tell you the problems. This is not even an average presentation. Make it better. You should present better. But to take negative out of it would be your problem. You should learn from this and make it better next time. All right? Yes or no?
Sure, sir. Sure, sir.
Yeah, and don't worry about people. What are they thinking about? Nobody thinks about you. If they were thinking about you, you're a film star. So forget it. Think about what you are doing. Your presentations are important. Next time, probably we won't have virtual presentations. This is what we decided. But there were massive requests for this. Physical presentation makes it at least possible to convey certain things, and we're going to have live presentations so that you don't create this. And as Dr. Gyan was saying, somebody has told you these points, you put them down, they don't make sense at all. If you were thinking yourself, I can make out you're an intelligent student, you would have made a better presentation. So don't be guided by anybody. Make your own presentation based on your own observation. It'll always be good. All right? Hello?
Yes, sir.
Colleague?
Yes, sir.
And did you attend yesterday and day for yesterday? Keep your camera on.
Sir, my camera is on.
Yeah. Did you attend yesterday? Okay, when you speak, it disappears. Did you attend yesterday? Yes or no?
No, sir. Yesterday I was busy, but the
You had a better thing to do.
day
Okay.
before
So
yesterday,
you know
sir.
the result of that. So this is a take home. These people sitting here throughout. I can watch a lot of them. They are not here for nothing. So this is all that it answers all the questions. Otherwise, it was takeaway. Obstructive jaundice is a takeaway case if you are basic, as they were all mentioning. Anyway, all the best, and don't rely on the the whole recording being provided, which is what you people do. Please attend next time when the scrubs happen. Try to attend, or otherwise, virtually also you should have attended all. There were talks which were so useful. So many surgeries. Did you watch the reflux surgeries?
Yes, sir. Yes.
Did you?
Yes,
What is the
sir.
repair
Just
he had
before.
discussed? What is door? What was door?
Sir,
What was shoe signing?
shoe signing was, sir, as told by the sir, there was
And
in
there
the
was
surgery only, sir.
one case where there was an alkaline reflux. What was that?
Sir, the patient was taking, sir, PPIs for a long duration.
I'm glad you were
There
listening,
was,
but you didn't have a choice because you logged in before him. So if you were listening to others also, you would have at least, even if you had absorbed 30%, I have spoken about obstructive jaundice yesterday, day for yesterday. So from this, the take home for you should be do more presentations and attend hard work. There's no shortcut to learning, and nobody dies of hard work. Most die due to lack of it. And harder you work, luckier you get. There's no other option. Anyway, I'm so glad you made an effort to present, and I accommodated you towards the end, and I don't regret it at all. Frankly, I wanted to teach you. That's why you got all those inputs from me. Right? Thank
very
you.
thank you, sir.
Thank
Very
you. We'll
thank
break
you.
off for lunch now. We can start with the next session. And this is the last session. And I'll request Dr. Ratna to kindly join me on the dais. This one is extremities, soft tissue, and miscellaneous. And towards the end, we'll have the ward rounds today. I'll request you all to kindly come in front. It'll be nice. In the rounds, right now you can sit wherever you like. Madam, if you could join me, we'll start. So, Surya, the first presenter, has he loaded? Okay, great. Ayush, okay. Start sharing your slides.
Good evening, everybody. My name is Dr. Ayush Agarwal. I'll be presenting a case of a soft tissue swelling of the lower limb. A 50-year-old lady, resident of Uttar Pradesh, housewife, presented to the surgical OPD with chief complaints of swelling in the right leg for the past 1 year. The patient was apparently well 1 year back when she developed noticed a swelling in the right leg, initially which was 2 to 2 centimeter in size, but has since then rapidly progressed in the past 6 months to its current size of approximately 15 into 7 centimeters. The patient has also complained of difficulty and pain in walking and squatting for the past 1 month. The swelling was not associated with any pain initially, but now mild pain is present while squatting or walking. So it's dull aching in nature, non-radiating, and usually gets relieved by medication. There is no history of redness or any discharge or ulceration over the skin over the swelling. No history of tingling or any numbness in the right lower limb. No history suggestive of any lower limb weakness or any dysfunction. No history of loss of appetite or any significant weight loss. There is no history of any radiation exposure. No history suggestive of distant metastasis like chest pain, cough, or hemoptysis, or any headache or any neurological deficits in the patient. Past history, the patient is not a known case of diabetes, mellitus, hypertension, CAD, asthma, or any other chronic illnesses. There is no history of tuberculosis or any contact with the disease. There is no history of any trauma or any radiation exposure. And there is no history of any drug allergy in the patient. Personal history, the patient takes a mixed diet. She has normal bowel and bladder habits. The sleep pattern is normal. And she is a non-smoker and non-alcoholic. No significant family history in the patient. On physical examination, should I stop now?
I think in the history.
So, in which part of the leg was the swelling present?
The swelling was present in the calf region in the posterior aspect.
So that we should be able to mention. And is it closer to the knee joint or closer to the ankle joint, upper or lower part, and which part of leg can be mentioned? So, what significance do you attach to rapid increase in size of a swelling that was 2 by 2 centimeters?
The swelling can be malignant in nature if it has shown a phase of rapid growth over the past few months only.
Could you have taken any other history to rule out a benign swelling in such a case? Can a benign swelling also suddenly increase in size?
There was no history of trauma between in between that 1 year period also. So if there was any trauma, there might be an increase in the swelling. If there was hematoma in the lower
Yes, so
aspect of the
history
leg.
of trauma you've taken, anything else?
Apart from that,
So again, history of things like joint pains and bone pains and all, because just to rule out other conditions. Well presented otherwise, sir.
Examination.
on examination, the patient is conscious, alert, and cooperative, and well oriented to time, place, and person. The performance status is 90 by Karnofsky performance scale. The patient is nutritionally well preserved and BMI is 25.8. There are no signs of any macronutrient deficiency, and the patient is also well hydrated. Pulse is 88 beats per minute in the right radial artery, regular in volume, regular and normal in volume and character with no delay. The blood pressure is 126 by 72 mm mercury in right arm supine position. Respiratory rate is 14 breaths per minute normal. There is no pallor, cyanosis, clubbing, icterus, or pedal edema, and no generalized lymphadenopathy in the patient. Systemic examination, cardiovascular, respiratory, and abdominal examination were within normal limits. Higher functions were also normal in the patient. Examination of the lower limb. On examination, the left lower limb was normal. On examination of the right lower limb, the patient had an antalgic gait. The patient had difficulty in walking for the past month and she was in pain. So patient had an antalgic gait. The patient's attitude was extension at the hip and the knee joint, while the ankle joint was at 90 degrees. There was no apparent lengthening or shortening of the limb, and there were no visible changes in the skin, no scars, sinuses, fistula, or any signs of inflammation or any trophic changes also in the limb. On examination, there was a visible swelling, 15 into 9 centimeter in the posterior compartment of the limb, posterior compartment of the right leg, which was ovoid in shape. On an extent, it was approximately 7 centimeters from the middle of the popliteal fossa and almost 15 centimeters of the medial and lateral malleoli. On palpation, the swelling was 15 cross 8 centimeter, non-tender with well-defined margins, smooth surface, and a hard consistency. It was mobile in the horizontal and longitudinal axis, and the overlying skin was pinchable. The swelling became more prominent or plantar flexion at the ankle, and it was fixed to the posterior compartment muscles. There was no edema of the leg distal to the swelling. On neurological examination, higher functions were normal. There was no neurological deficit in the left lower limb. In the right lower limb, there were no fasciculations or twitching or any tremors, no visible wasting of muscles. The power was 5/5 in both lower limbs. There was no loss of sensation. The deep tendon flexes were normal. There was no restriction of movement at the ankle joint, although the patient experienced pain while plantar flexion at the joint. And all other joints in the lower limb were also normally. On vascular examination, the anterior tibial artery, the posterior tibial artery, and the dorsalis pedis artery had normal pulsations in both legs. In summary, the patient is a 50-year-old lady with swelling in the right leg calf region for the past 1 year, which is rapidly progressing in size for the past 6 months, associated with dull-aching pain and difficulty in walking and squatting for the past 1 month. On examination, it is a 15 into 8 centimeter swelling in the extensor compartment of the right leg, which is non-tender with well-defined margins, smooth surface, hard consistency, fixed to underlying muscles, no associated sensory, motor, or vascular deficit. This is probably a case of 50-year-old lady with swelling in the right leg posterior compartment, most probably of malignant etiology, probably a soft tissue sarcoma.
A good presentation. Give a round of applause. All of you. But when you're talking about performance status in these patients, and especially with the limb problem, they aren't able to do their normal activities in any case, and it may not be applicable. Suppose the limb is fractured, you can't say performance status is less than 60 because patient has to be bedridden on account of fracture. So common sense should play a role. Secondly, it is safer in all symptomatic patients to keep it between 80 and 90. 90 is by and large very good. Now, in the limb, when you were examining, you covered all aspects with the gait, with attitude, lengthening, shortening, visible changes in the skin, visible swelling, extent of the next. So, you can, when you talk about overlying skin pinchable, you can say skin is not involved. Pinching is a test. And it becomes more prominent on plantar flexion. What does it indicate?
Sir, first of all, the swelling is in the posterior compartment, so there must be some infiltration into the posterior compartment group of muscles.
Which are those?
The superficial is the gastrocnemius and the soleus, and deep to them are the flexor hallucis longus, flexor digitorum longus, and the tibialis posterior.
So infiltration of these muscles is a possibility, yes. And there is no edema of the leg distal to the swelling, which means there is no venous engorgement or involvement. And no neurological deficit?
No,
Next
sir.
slide. So I wanted it, I was not aware he's presenting, but limb should be examined as a whole. If you make it as a habit, it took exactly 5 minutes to present it. So if you can present it all that quickly, then everything gets covered, madam.
Go back to the image, please.
Any wasting, I forgot to ask you.
No, sir, there was no wasting in the muscles.
It is not possible. So measurement has to be right. Where did you measure for wasting? Which wasting you looked for?
So first of all, in the lower compartments in the posterior.
So wasting may not only happen in the leg muscles, it can happen in the thigh muscles also. So you need to measure above the, the knee to know whether there was wasting, because the patient can't be using this limb as much as the other side. So even if there is no direct reason for it to lose muscles, here it cannot be a false reading because it is swelling there. So it has to be above, no? Yes, madam.
Yeah. So what are those two marks that you see on this swelling over the skin that you've not described? Or
Ma'am,
did I miss it?
Yes, ma'am.
You
Ma'am,
described? You
Ma'am,
described them?
these two marks were actually present since birth in the patient. I inquired about any history of if there was any biopsy or any needle had been inserted, but the patient gave no such history. This was the first presentation of the patient to the OPD. These are probably from birth only.
Okay. So you could have just made a mention because sitting here, I was imagining probably two core needle biopsies done from here. Yeah.
Good point. It is to be described, and one would suspect it's a puncture mark, which is what probably somewhere else. Having said that, another thing which I was thinking of and trying to talk about, but suddenly I've not remembered. Regional lymph nodes.
Yes. Sir, no lymphadenopathy in the inguinal
So
region.
which nodes you looked for?
Sir, in this case, we can look for the superficial group of inguinal lymph nodes.
Very common mistake. So examine the popliteal group and then the inguinal group. And like in the hand, epitrochial and then axillary. It's very common mistake. That's why I wanted to check it. And how did you look for the clinically? Do you think popliteal or any other vessel is involved?
No, sir, all vessels had normal pulsation, sir. Proximity
All
to the
means
swell-
where? You could
proximity-
palpate
Yes, sir.
popliteal and dorsal speed is below, and
Yes, sir.
anterior tibial
Yes, sir, both. All
and
three.
posterior tibial both
Yes,
could
sir.
be palpated.
What have you told us about the mobility of the lump? You've said skin can be pinched. What about the mobility of the lump?
When the patient has the foot is relaxed while the patient is in supine position, the swelling was movable in the horizontal as well as the vertical axis.
Would it move in the vertical direction? Looking at the site of the lump?
Not vertically.
Was the movement equal on both the sides?
Yes, ma'am, equal on both the sides.
Is there any bone that comes in this area that you may want to look for whether the lump is mobile or immobile totally?
On the tibia and the tibia is
Oh, in
here.
this side, in this particular area?
Yes, ma'am.
Tibia lies medially, no? It seems to be sitting over the area where fibula is.
Covering
So
both,
look for.
both the zones. But important thing is, when you're talking about mobility in a relaxed position, it doesn't count. When you made it taut, you found that it has become immobile. And you suspect that muscles are either it is deep to them or they are infiltrated or they are all one. Important. What is your clinical impression?
So clinical impression is in this patient on plantar flexion, there was no
No,
mobility.
what is the diagnosis?
The diagnosis of a 50-year-old lady with a swelling in the posterior compartment of the right leg with history of rapid increase in size for the past 6 months, probably soft tissue sarcoma.
What are the points in favor?
Points in favor in history, sir. First of all, the swelling was initially small, and then for the past 6 months only, that's started developing. It has started growing to a bigger size, and the patient also had now has started experiencing dull pain, which is constantly present all throughout the day. Maybe a sign of infiltration into the nerves in the region, sir.
So maybe if I was taking history, I would put in a little more effort to find out that when this 2 by 2 centimeters swelling was present, could the patient move it comfortably initially? Because what I want to know is that was it a subcutaneous swelling that started and infiltrated into adjoining areas, or was it a deep swelling to begin with?
I did not specifically take this history of whether it was movable at the initial time, but on examination, the swelling seems to have originated from the subcutaneous plane and then infiltrated deeper into the muscle bones.
How do you say that on examination that it originated in subcutaneous and went in deeper?
The pain, I thought the pain had started now only, and patient did not have
No,
any
see, at
difficulty.
this point of time, you can only say that swelling is involving the muscle. Where it originated, you cannot speak about that, no? And if it is totally immobile to begin with, you would know that it is fixed to the bone also. But you say it was mobile, but only on contracting the muscle, it has restricted mobility. How will you, can we ask him how to?
Anybody questions? Any questions? How do you approach now?
First of all, sir, we would like to proceed with investigations to confirm our diagnosis, then to stage the disease, and then to treat the patient. For confirmation of our diagnosis, first of all, it is recommended to obtain as an extension of clinical examination, I would like to do an ultrasound of the limb, as the limb as a whole, to identify if it's not a vascular swelling, so that we may not inadvertently go ahead with corneal biopsy. And the modality to confirm the diagnosis will be our image-guided corneal biopsy from the swelling, so that we may take by tissue from the representative areas of the swelling.
This is the picture,
Yes, sir.
right?
Yes, sir.
This is the swelling.
Yes, sir.
What would you do?
Sir, corneal biopsy from the
Take the
middle of
cursor,
the
show
swelling.
me where.
Sir, if the disease comes out, if we have to operate in the future,
Your question is
Yes.
direct,
Yes.
simple.
we would like to take a
Okay.
corneal biopsy from the middle of the swelling.
Submit. But would you image first or you do core?
First image, sir, and then image-guided corneal biopsy.
No, any other imaging that is almost, I mean, it's permitted to do that beforehand.
Sir, ultrasound was.
You do ultrasound guided core biopsy, that is
Yes.
okay. Any other imaging which is a standard of care?
Sir, MRI is a standard of care
Okay.
in these patients.
So you need to do MRI. That teaches you, that gives you all. Do you know MRI gives you histological diagnosis also?
Yes.
They have MRI patterns. So what are those patterns?
Uh,
More fat, less fat. And they have some scoring and grading system for soft tissue sarcomas. So imaging is, why should we do MRI before we put in a needle?
But first of all, we should try not to to identify if the swelling is.
No, you were saying it earlier.
If the swelling is of vascular origin, if it's a angioma.
Anybody? It will distort the architecture. You may have a hematoma, you may have an artifact. So that I think was a very simple takeaway question. So you do imaging first, then putting a needle, right? You can do an open, that is institutional biopsy or core biopsy. If the core biopsy is inadequate, you may have to. All right. Any other basic investigation? Ultrasound, you said basically for core biopsy. Any other? Would there be a role of doing an X-ray or you do?
Sir, X-ray of the limb, as well as one joint above and one joint below, in two views, probably AP, anterior, posterior, and lateral views has to be.
Two views, two sides, two joints.
Yes, sir.
That's the formula we follow in our unit. That's for X-ray. We do X-ray for all of them. Why?
Sir, first of all, to identify if you have missed any infiltration into the bone.
Yes,
or
bony.
if the swelling is itself bony in originating
Okay.
from
So
the.
you will be able to know the bone. It doesn't harm you. Although some people do CT for the same reason. You can do good X-ray and MRI followed by core biopsy. Now, what is the most likely soft tissue sarcoma in this region?
Sir, in this region, sir, liposarcomas are common, most common form of soft tissue sarcoma.
Extremities, I'm
Extremity
asking. And
sarcomas. Liposarcoma, it could be, sir, a myxoid liposarcoma. Commonly in this region, they are found. And apart from that, sir,
do the liposarcoma.
Leiomyoma
Okay, carry on.
it could be a leiomyosarcoma, although they are rare as compared to.
How about rhabdo?
The rhabdo usually presents in younger age group.
Yes.
Sir, uncommon in this age group, sir. 50 years of.
And anything else in the history that would help you know it is liposarcoma or not?
Sir, if the swelling was smaller in size at first and then it has shown rapid increase in size, maybe.
So lipomas change into liposarcoma?
No, sir, it's a different.
So it doesn't help.
Yes.
If it was a lipoma and now it has become liposarcoma, not common. They're mostly de novo. Any other investigation?
Sir, since on
We have done investigation for T, now for N and for M. You have to tell us all.
Yes, sir. Since the tumor is on examination only, the tumor is seems to be more than 10 centimeters in size, or T2 or T3 grade. We would go for the most common site of metastasis is the lungs. So we should ideally do a chest CT scan.
Yes.
CT scan of the chest to look for any lung metastasis.
CT thorax becomes necessary.
Yes, sir.
Because of the size. You're right. And anything when you've done a core biopsy, the grade will tell you something.
Yes, sir. According to the grade also, we can classify tumors as high grade or low grade. So if the grading includes tumor differentiation, tumor necrosis, and the number of mitosis per high power field. So according to that, it can be graded into G1, G2, and G3, which is a part of the TNM staging also.
So how do you, now that you mentioned it, how do you make it into GTNM? How do you grade it? How do you stage it? What are GTNM stages?
Yes, sir. GTNM includes, sir, TNM is a T staging is for the tumor size, which is less than 5 centimeters, T1. greater than 5 and less than equal to 10 centimeters T2, greater than 10 and less than equal to 15 centimeters T3. Answer T4 is more than 15 centimeters, sir. Answer in grading, sir, it is grade 1 is the score is 2 to 3, grade 2 is 4 to 5, and grade 3 is 7, 6, 7, and 8, which is on the basis of in the mitosis it is less than 9, less than equal to 9, 10 to 19, and more than 19. Less than 50% necrosis, more than absence of necrosis, less than 50% or more than 50% of necrosis. Answer differentiation, well differentiated, poorly differentiated, and very poorly differentiated.
Very good. And how about the N?
So N stage, N0 is no metastasis, N1 is any lymph nodal metastasis is N1 in this case. So.
What about the M state?
The M state, metastasis to a single organ is M1, sir.
What is AJCC 8th edition change in N? Earlier, we used to call N1 as M1, you know, to be metastatic. So when is it metastatic?
Sir, in AJCC 8, first of all, they have differentiated whether the tumor is present in the head and neck. The staging is different for head and neck.
Staging is different for region-wise.
Region-wise
Extremity is
staging
different.
yes.
Okay. Okay. And?
Sir, I don't know about the nodal status. I don't know.
It's the same. It is no longer M1 that they used to talk about, but then they're back to M1 now. So it is changing frequently. So node presence can make it a metastatic disease, a stage 4. So that is why it is important to, if there is a node anywhere, you need to do guided FNAC. It's not palpable node alone. That is enough. Yes, madam. Any
How
question?
do an imaging differentiate lipoma from liposarcoma? Can lipoma be immobile in this area?
Usually, if
Can
it is
lipoma have similar clinical findings in this area?
well, lipoma can be the plane of the lipoma could be
Yes,
different.
so an intramuscular lipoma can have similar findings. You know, so other than core needle biopsy, can imaging give you, say, MRI, give you some idea about whether we are dealing with a lipoma or a liposarcoma?
Ma'am, on imaging, lipoma usually has a very defined capsule around it. And on imaging, we can identify if there is any extension into the deeper plane of the muscle. If there is infiltration of the...
So it is basically all that can happen in both, no? Intramuscular lipoma can also infiltrate into the muscle, but the margins will be well defined. You're right there. Even sarcomas have got well-defined margins. No, they don't infiltrate like carcinomas. The differentiating feature is thick septa. Thick septae are present in liposarcomas, which are missing in lipoma. And like you will call it a liposarcoma only if the size is, I stand corrected, whether it's 10 or 15. I think it's 15. If it's more than 15, then only you would start calling it a liposarcoma.
Okay. So, imaging has a major role to play. MRI can make out histology in great degree. How do you manage this case?
Sir, according to the size of the swelling, it seems like a T2 or T3 disease. So first of all, the treatment has to be, limb preservation has to be the priority in this case. So we would first like to do a wide local excision of the tumor. Then according to the final histopathology, we can differentiate on the basis of grading and we can go for adjuvant radiotherapy to the affected site of the...
Okay, good. What do you mean by this excision?
Sir, excision has to be the pseudocapsule of the tumor has to be taken. Along with that, the normal tissue has to be taken almost 1 to 2 centimeters around. And for example, one plane below and one plane up that we practice. And the swelling has to be excised like that.
When does it become difficult or when is it contraindicated to do limb preservation?
For example, if there is infiltration into the blood vessels or the nerves of that area, it will be difficult to perform a wide local excision.
That's not a complete answer. Yes, somebody? 2 out of 3. So that's a rule of 2 out of 3. So what are these 3? So neurovascular bundle, joint, and bone. Any 2 involved, you can't spare it. There are exceptions to it, but not every time it is possible. So one is careful in preserving. If it is not possible to preserve the limb, what are the options? You can go for neoadjuvant chemotherapy. And neoadjuvant, upfront radiation is also an option in limb sarcomas like retroperitoneal sarcoma that we are discussing. Now, wide local excision or, as you said, clearance is not the answer, 3-dimensional clearance. What about skin?
Sir, in this case, the skin does not seem to be involved. And on making an incision, if we find the tumor is infiltrating above, then we have to remove the skin along with it and then
Reconstruct it.
reconstruct
But
the
mostly skin is not involved, so then you don't need to do anything more. And how do you achieve those planes of resection?
Sir, while resecting, usually we do not look for the tumor. We have to go above the tumor. So we have to resect through the normal tissue above and below the
So you
selenium
take the
tissue.
muscle out,
Yes, sir.
not the tumor.
Yes.
So we will go deeper and we'll be able to take the muscle out without looking at the tumor. And what are the barriers that you can make use of for benefit? And you take those barriers, then your margin is not a problem.
Sir, we can take out the deep fascia of the muscle. That will act as one barrier, sir.
There's some minor barriers and some major barriers. So tendon sheaths, fascia, neurovascular sheath, they are barriers which don't let the tumor pseudopods cross. So if you clear that, then you don't need to count 2 centimeters, because if 2 centimeters includes popliteal artery, you will not remove it, you will shave it off with the sheath. And the major barrier like in pleura or peritoneum, those are different ones. So it's important to understand periosteum,
Perineurium, sir.
perineurium, and also the
Tunicate
synovial membrane and all these basically. So clearance would be 3-dimensional clearance. And once you do the clearance, what do you do next?
Sir, clips have to be placed along the margin of the excised
In the
part. So
tumor
that,
bed. Why?
for identification post-operatively, so that radiation can be given to the specific area.
Radiation and boost also can be given subsequently. You can also do brachytherapy in the limbs. What is that?
Sir, in brachytherapy, it is a course of radiation that is given over 4 to 5 days only with a lower radiation exposure, and catheters are placed intraoperatively
During
along the
surgery.
tumor site.
Very good.
So can you define what is this intralesional, marginal, wide local, and radical excision? Can you define these 4 terms?
Intralesional.
Intralesional, marginal, wide local, and radical. Wide local is the one that we've talked about and has to be practiced. What are these others? Which are inadequate, and radical is overdue.
Okay.
So intralesional is you go through the tumor thing only.
You shouldn't do that.
Marginal is when you go through the desmoplastic area around it. Wide is when you go beyond that. And radical is when you go across the compartments.
Right. And compartmental excisions are not done these days. They were practiced in the past for soft tissue. Very important. Now, last question. Why do they recur so frequently?
Sir, the tumor has a tendency to have pseudopods which are present beyond the tumor also. We do not normally
Beyond the
resect-
pseudocapsule. When
Beyond
the
the
tumor compresses, produces a pseudocapsule. They go beyond it. So that's the reason for recurrence. And mnemonic is the same, no? 3 R's. What are those?
recurrence, and recurrence.
Recurrence, recurrence, and recurrence. What are the indications for radiation in these patients?
So radiation is usually preserved for more than 10 centimeter or more than T2 stage of tumors with poor differentiation grade. And sir, in which post-operatively there are microscopically positive margins.
Yeah.
The
Closed margins are also positive. It's not tumor on the ink. And
so less than 1 centimeter margins are usually like
and also recurrence.
Recurrence.
So these are the indications. I think we can close.
Last.
Yeah, please.
Any technical concerns other than removing the tumor that you may have in mind? That you may want to discuss with the patient? After all, it's the limb.
Movement, if we have to take consent for removal of all the posterior group of compartment muscles.
So one is that you would also want to talk to her about reconstruction. 2, second, about functionality of the limb should be maintained. That's the main purpose of retaining. No?
Very good presentation. Give a round of applause. Very nice. Excellent job. Now, we have 2 presentations left before we go to ward rounds. One is Siddharth, the other is Sanjeev Reddy. Who is present? Sanjeev Reddy is here. Give a big round of applause. He's a undergraduate who wanted to present, and there are only 2 that came. One is Omar, who was insisting on presentation. The other is Sanjeev. So we'll have his presentation on another lesion of the limb. Sanjeev, start.
very good afternoon to the respected panel members and seniors. I am Sanjeev Reddy, an intern from Subjung Hospital, and I'm here to present a case of a facial ulcer. My patient, a 21-year-old housewife hailing from Sitamar, Bihar, belonging to the lower middle socioeconomic status, presented with complaints of recurrent sunburns, dark and light spots all over her body since childhood, and lesions on her left hemiface for the past 3 months. The patient presented with history of recurrent sunburns, dark and light spots all over her body since childhood. 3 months ago, she had approximately a 1 into 1 centimeter swelling on her cheek, her left cheek. 2.5 months ago, it ulcerated and it started producing a foul smell with mucopurulent discharge. Currently, it's approximately 6 into 6 centimeters in size, an ulcer. This is encroaching on a lower eyelid with dull aching pain and it bleeds on touch. There's no history of any similar lesion in the past, any itching sensation, persistent fever during the course of the disease, significant weight loss, evening rise of temperature or night sweats, scars or burns at the site of the lesion or irradiation to head and neck, any signs or any symptoms of metastasis such as breathlessness, hemoptysis, jaundice, loss of appetite, severe headaches, seizures, epistaxis, or recurrent sinusitis or loosening of teeth. The patient had a history of an excision of an ocular surface squamous cell neoplasm from the right eye 1 year ago. There was no significant family history, there was no history of any recurrent sunburns, cutaneous malignancies in the family. And the lady also had a year-old child who had no symptoms, no similar complaints. A patient follows a vegetarian diet and she has no changes in appetite, bowel or bladder habits or sleep habits. There's no history of any alcohol consumption, smoking, or tobacco in any form, or any illicit drug abuse. Currently, she's lactating for the past 5 months and there's no menstrual abnormalities. She's been married for 1.5 years. She's P1L1.
History is fine. You can proceed to examination. In history, what are the salient things you observed, Sanjeev?
Sir, one was considering the age of the patient. She's 21 years old. It's a very early age for something so malignant to appear. It is suggestive of something syndromic. Other than that, because of the rapid progression of the disease from a nodule to an ulcer, it is a malignant condition.
Very nice. And in the family history, what did you observe?
Sir, there was no history in the family as such, but
What did you have in mind?
sir, I mean, the typical features of xeroderma pigmentosum that the patient has, and almost 50% of the cases are due to de novo mutations.
So you were not expecting anything, but you wanted to know.
Yes.
Okay. Go to the examination.
Informed verbal consent was taken for examination and photography. The examination was performed in a well-lit room with the patient comfortably seated in the presence of a female chaperone. The patient was alert, conscious, well-oriented to time, place, and person. She was afebrile to touch. Her blood pressure was 122/76 mmHg in the right arm in supine position. The pulse rate was 76 per minute in the right radial artery. Respiratory rate was 16 per minute, regular in rhythm and thoraco-abdominal type. There was no pallor, icterus, cyanosis, clubbing, general lymphadenopathy, or pedal edema were noted. Premature graying of hair was observed. A dark cutaneous horn is seen 4 centimeter lateral and inferior to the lateral canthus of the left eye. Multiple hyperpigmented macules and plaques with interspersed hypopigmented macules are seen over face, forearm, and trunk. When it comes to the eye, of course, I could not get a detailed eye examination answer, but the patient had a mass in the inferolateral aspect of the limbus of the left eye, which was white and pearly. It had some feeder vessels and the conjunctiva showed obvious dryness. When it comes to the ulcer, sir, it was 6 into 5 centimeters, a circular ulcer on the left hemiface over the cheek area. It extended from the medial canthus to 3 centimeters lateral to the lower margin of the ala vertically, and from the lateral margin of the nose to 4 centimeters inferior to the lateral canthus. It had everted or rolled out edges. It had a yellowish white foul smelling purulent discharge on the floor. It's crusting over the edges. There's obvious bleeding noted on the inferior margin of the ulcer. A dark color conical mass of 2 centimeter diameter and 1.5 centimeter length was seen 5 centimeter later to the lateral canthus, left lateral canthus. And 1 into 1 centimeter circular raised lesion with beaded edges was seen just below the right medial canthus. A round crusted nodule of size 1.5 into 1.5 into 1 centimeter seen at the tip of the nose. As we come to the main ulcer, there was no local rise in temperature. It was 6 into 5 into 1 centimeter tender irregular ulcer felt in the left hemiface over the cheek area that rolled out hard edges. The base was firm and fixed. It bled on touch, especially on the inferior and superior margin of the ulcer. Surrounding skin is darkly pigmented and indurated. Systemic examination was within normal limits, sir. In summary, a 21-year-old woman with multiple hyperpigmented macules and plaques with interspersed hyperpigmented macules all over her body, more densely distributed over sun-exposed areas, with a 6 into 5 into 1 centimeter ulcer, with a fixed base with purulent discharge associated with pain and tenderness, which bled on touch.
This case you took when you were a student, right? And it came in my OPD. It's my case, so I know about it. But nicely presented. Give him a round of applause. Now, even in undergraduate period, you should learn to make right presentations. Few things you must have noticed which were missing in many presentations. Taking consent for photography and sharing it, which he mentioned, and also video recording and sharing it. You just can't bring a picture of a patient and start discussing. So there are few things which are highlighted. And considering that is an undergraduate, we would all agree that it's an effort made. So there are many things that you can ask. Many things could be missing, but I think by and large, a very good presentation, even from a postgraduate standard. Well done. You should keep it up. Become a surgeon only. Don't try to become a shady radiologist after this. Yes, question.
What is your diagnosis?
Ma'am, overall it was a 21-year-old female with a suspected photosensitivity syndrome, probably xeroderma pigmentosum, with multiple keratoxanthomas and poikiloderma, with an ulcer on her left cheek, suspicious of malignancy, probably squamous cell carcinoma or a basal cell carcinoma.
Sanjeev, are these pre-malignant conditions which she already has?
Sir, she had many pre-malignant conditions, like she had actinic keratosis, had multiple spots, and keratoxanthoma is high-grade SCC.
Since these are hyperpigmented lesions, so many of them, why did you not keep melanoma as a possibility?
Ma'am, actually, this altered pigmentation is seen in xeroderma pigmentosum from the age of about 2 years.
So it was already there.
Also had an eye surgery, no?
Yes, ma'am.
So melanomas are also known to happen in the eye.
Yes, ma'am.
So that is another thing that can be considered. What do you understand by this ugly duckling sign?
Not heard of it.
So whenever you have multiple swellings anywhere, you need to keep a watch on, is any one of those swellings very different from the other swellings? So if it is different, that's an ugly duckling in that area.
Melanoma, usually that's how we pick up that amongst many moles, it'll look different. Huh? So it's a possibility and keep that in mind. But it's one of the skin cancers. Now look at the characteristic. Can you take us through the picture? And next time, don't use this periodic presentation. Take one shot at a time. You know, that is a physician kind of presentation. No, take one there. Now, if you really look at the lesion, edges are everted, there's some pigmentation happening there also, but originally there was a pigment. So these are all possibilities. So you should consider them. One would also ask you why you're indirectly, unnecessarily linking it to anything else. What is the most common cancer that happens in this region?
Sir, in this region, it is basal cell carcinoma.
Very good. And there can be melanotic type of basal cell carcinoma. There can be basosquamous carcinoma. And there can be, something which can confuse you with squamous cell carcinoma. So we will leave it to histopathology and to the diagnosis to be made. Clinically, therefore, it's good to keep those possibilities, including melanoma. Nothing wrong in it. But what do you see elsewhere in the face? If we were to operate on one spot, you put an arrow at another spot. What is that?
Sir,
Yeah.
not this.
No, I can see your arrow. You can take the cursor there. You can see the other arrow. Take it up. Yes. What is it?
That's a cutaneous horn, sir. That
So would it have any relevance with this?
Sir, cutaneous horns can have both benign and malignant etiologies.
Yes. So
It could be anything from a seborrhokeratosis to an actual SCC.
no, this to you is, I mean, a horn. But if we were to have this ulcer draining towards preauricular lymph node, it could also be an in-transit
Transit metastasis.
nodule, which can also go in favor of melanoma there. So you must keep everything in mind. Just don't make it benign simply because of that reason. Okay? Good. Excellent presentation and a very good case. How do you, what did you see in you showed the left eye. What was the finding?
So it was a pearly white lesion on the inferior lateral aspect of the limbus of the left eye.
Was it after this lesion that it has appeared, or it was there before?
It was there beforehand. She actually had a history of an excision on the
Excision was done at the record, actually. So
on the contralateral
contralateral side. Okay. Now, is there cataract?
Cataract is also a possibility in such patients.
How do you proceed in this case? What do we do? What did we do? Well, I'll tell you later, but what do we do?
Sir, we will proceed with performing investigations to confirm the diagnosis, to further stage the disease and for the treatment of the patient. First of all, to check if there's any lymph node involvement, which we have missed on clinical examination, we would do an ultrasound of the parotid region and head and neck. And sir, to confirm the diagnosis, we would do edge biopsy of the lesion. Apart from that, for the syndrome, we would like to do a biopsy of the subcutaneous tissue. And usually the culture of the fibroblast is done and a UV photosensitivity test is done.
Very good. What more? For the eyes, what will you do?
So for the eyes, a CECT for overall the head and neck.
So that is for the orbit. Okay. And?
And apart from the routine investigations, histopath from edge biopsy, we do a histopath grading.
No, is she able to see? What is the vision like?
Sir, the patient did not consent for a visit to the opthal department.
She refused for a reason. What was that reason? Why didn't she go?
So she was actually very reluctant. She was not even, she didn't know about the disease that she had. And actually, she was not socially, her family was not supporting her.
Yes. Abandoned. They didn't want to take her. That is the reason. Anyway, how do you establish a diagnosis? It won't take you further.
Sir, the edge biopsy will give us the type of cancer that is there. And the syndrome will be established by the photosensitivity test.
What is this photosensitivity test?
Sir, XP is basically a defect in the DNA repair, which happens because of basically whenever UV rays fall on a DNA strand, dimers of thymidine is formed, which is repaired by a certain mechanism. And when this is defective, certain syndromes like trichothiodystrophy or cocaine syndrome or XP occur. So to check for this, this photosensitivity test is done, sir.
Good. Treatment. It is common cell carcinoma, well differentiated, eroding into the orbit.
Yes.
That was the case. So what happened? What was to be done?
Sir, the patient was sent to radio.
No, don't tell me what happened. What will you do? What happened? I'll tell you.
So after the CECT, the patient came back and she was sent to the radiotherapy department. And she recovered after
She was not willing for surgery, but it involved going for exenteration and plus resection, which was a radical resection. Any questions? Any questions from anyone? Very rare. Yes, please.
Why did you thought about heme metabolism valid disorders? Because they tend to produce photosensitivity.
AIP also produces photosensitivity, but it does not lead to formation of nodules. It forms blisters.
You got the answer.
Visceral pain is also.
This was from a UG to UG. I understand this challenge. These guys have already forgotten about it.
Types of UV rays that you know of?
ABC.
Which out of these is the most dangerous?
Ma'am, A is the shortest, highest frequency, shortest
So
wavelength.
C is cool, right? gets
C is
destroyed in
good.
the. C
Ma'am,
gets
usually A
destroyed in
doesn't
the
penetrate
atmosphere.
the stratosphere.
A and B?
B and C are the ones that commonly reach the
No,
shortest.
A and B. C gets destroyed in the atmosphere only, no? A is the one that reaches the deepest layer till the dermis. And I think B reaches till basal B and
So,
B.
ma'am, I was talking about what reaches the surface of the earth.
No. The surface of the skin is what we're talking about.
Like from the sun is what I mean.
No.
No one, no problem. Give him a big round of applause. Huge. Very well done. Proud of you. Keep it up. I trained you as an undergraduate, become a surgeon. If you don't, I'll kill you. And I'll know where you are, so don't worry about it. Wherever you go, you'll find me. A lot of our good students have become something somewhere. It's Sanjeev Reddy. We have the last presentation is Siddharth Kita. Yes, please come. He's making a presentation on another ulcer. And Siddharth is a postgraduate. He's our postgraduate at Sir Gangaram Hospital. Very bright resident who's presented thyroid earlier. So I'm sure he was very keen on presenting, and that is what is more important. Don't bother about anything else. Enjoy your presentation.
Good morning, everyone. Sorry, good evening. So I'm going to present a case. A patient was a 70-year male resident of Bhagwanpur, Dhaka, a farmer by occupation. He had chief complaints of pigmented lesion over left side of nose since 15 years. The patient was apparently well till 15 years ago, after which the patient developed a pigmented lesion over the left side of nose. It was the size of 5 mm till about 3 months back. In last 3 months, it has increased in size to about 2.5 into 1.5 centimeter. History of darkening in color of the lesion in last 3 months. History of itching over the swelling. No history of pain, no history of bleeding or discharge, no history of any other swellings or pigmented lesions anywhere in the body, no history of significant weight loss or appetite, no history suggestive of distant metastasis. No history of similar lesions in the past. He is a known case of hypertension, diabetes, and coronary artery disease. He underwent PTCA for CAD in 2018. He is married, follows a mixed diet. His bladder, bowels, sleep, and appetite, everything is normal. Socioeconomic status, lower middle class. No history of addictions. No history of allergy to any medications. His parents died of natural causes. One sibling, healthy, no similar history of skin-related illness. 70-year gentleman presented with painless pigmented lesion over left side of nose for last 15 years. The swelling was about 5 mm in size initially, but it started growing rapidly in size in last 3 months and has attained a size of approximately 2.5 centimeter into 1.5 centimeter with recent darkening of color. It is also associated with itching for last 3 months. No history of any such lesions or distant metastasis.
Anything you'd like to ask in the history? You can proceed to examination because usually the history is complete. Nothing much.
Thank you. General examination, the patient was examined in a well-lit room with proper informed consent, and photographs were taken after getting a proper informed consent. Patient is conscious, alert, and cooperative. BMI 28. No pallor, icterus, cyanosis, edema, jaundice, or generalized lymphadenopathy. BP, pulse rate, respiratory rate, and temperature are normal. Locoregional examination. On inspection, a pigmented lesion on the left ala of nose, size of 2.5 into 1.5 centimeter, shape asymmetric, surface uneven or nodular, skin a central depression over the pigmented lesion, no discharge or bleeding, no any other swellings or pigmented lesions visible, cervical lymph nodes, no enlargement. Palpation, no local rise in temperature or tenderness palpable, Inspectory findings were all confirmed. The site left allow of nose 2.5 into 1.5 centimeter, shape asymmetric, surface uneven, firm inconsistency, not fixed to underlying structures, no discharge or bleeding on palpation, no enlargement of cervical lymph nodes. This is the BCC. Basically, this is the lesion, pigmented skin lesion. The summary: 70-year gentleman presented with painless pigmented lesion over left side of nose for last 15 years. The swelling was about 5 mm in size initially, but it started growing rapidly in size in last 3 months and has attained a size of approximately 2.5 into 1.5 centimeter with recent darkening of color. It is also associated with itching for last 3 months. No history of any such lesions or distant metastasis. On examination, there is a dark asymmetric nodular swelling 2.5 into 1.5 centimeter in size. No underlying structures are involved. No other swellings or pigmented lesions in the body. Provisional diagnosis: a 70-year gentleman with dark pigmented skin lesion over left ala of nose, probably of malignant etiology, most likely a case of BCC without any lymph node or distant metastasis.
Right. In the examination, can you show that picture?
Yes, sir.
Now, what else would you describe for a lesion? Since you have the diagnosis in mind and you have to go for something more. So anything more you would like to tell us about? What about the nostrils, the examination inside the nose?
Yes, sir. The examination inside was done. I forgot to put a picture. It was done, sir, and there was no invasion. I could not see any invasion, sir. I could not
Oh, it's
see.
important. Is the cartilage involved?
No, sir.
How would you know that? Even here there is a cartilage, no?
Yes, sir.
Bone may not be involved, but the cartilage would be, I think, quite likely, unless you tell me it is not involved.
It was not involved, sir.
So we need to do, especially in the lesions involving the nasal part, we can do bidigital examination to see the depth of it. And of course, we'll investigate to find out, but you should try to rule out how much, because resection, what do you do in a basal cell carcinoma? More of resection, that you were careful about the margin and importantly the depth. So that is why I was asking you. How about the, there is a spot just going up, take your cursor. Up to the point where the, yes, stops, no, go up. What is this?
So this was present initially. I had asked about this one to the patient because there are always more lesions over there.
So similar lesions are there
Similar
elsewhere.
lesions, sir.
Would that
I've asked-
again be the question? Which was the ugly duckling sign?
Yeah, sir, but
So try to work on the concept of melanoma also with the same logic, although this is a classical site. What is the classical site for basal cell carcinoma?
basal cell carcinoma, almost 30% of basal cell carcinomas arise on the external part of the nose.
Exposed part.
Exposed part of the nose, yes.
And how is he exposed to ultraviolet?
He was exposed as he was a farmer by occupation, and he had told us clearly that he used to work outside in the farm a lot. So
Without a hat on, right?
yes, sir. Yes.
And no protective gear, no protective cream. They tend to get it. Is it common in darker individuals or lighter individuals?
Lighter individuals, sir.
Questions.
Because of palpation.
Can you give the clinical description of this lesion? I mean, is it an ulcer? Is it an exophatic growth? Or what is it? Can you magnify the image? Or is it a PDF?
Ma'am, it's PPT.
Yeah, magnify it further. Now you will also be able to describe it better. Magnify it more so that only knows the scene.
I'm not able to.
Yeah. Can you describe it?
Uh,
What kind of lesion is it?
It is
Is it an ulcer, ulcerated nodule, exophatic, fungating nodule? What is it?
It's more of an ulcerative skin lesion.
So if it's an ulcer, please describe the ulcer.
Ulcer with ulcers with rolled out margins.
Rolled out margins, then why will you call it basal cell, no?
Rolled out everted margins with rolled out
No,
edges.
they are not everted.
central.
Go on, keep describing.
Sorry.
Keep describing.
Yes, sir. A 2 centimeter lesion with a.
What are the components that you describe when you describe an ulcer?
We describe the base of the ulcer. We describe the edges, the margins, and anything surrounding.
Anything else is that? No. There's some important thing left. What is floor and what is base?
Yes, floor and base. Yes.
So tell.
Base is the overlying structure on which the ulcer is there, and the floor is the central part of the ulcer.
Imagine a swimming pool in first year, second year or first year now? First year. Imagine a swimming pool, take the water off. And as you walk around, that's a margin. What you see down is the floor. Between the two is the edge. And the mother earth in which you have dug this hole is the base. So now don't confuse this ever. Remember it for future. How do you proceed now?
As
You mentioned basal cell carcinoma with no regional lymphadenopathy. So it is basal cell carcinoma because of that reason. You were asking.
Classical beaded edges. No, you should not call them everted.
They are beaded, and beaded are classical of basal cell carcinoma also. The beaded would not be everted. Okay, no problem. Proceed. How do you proceed now?
With investigations, so we have to do investigations to confirm our diagnosis.
To support our diagnosis, to
support
stage our disease, and to treat the patient.
treat the patient. Yes. So to support diagnosis.
First confirm it.
Yes. To confirm it, we'll have to go with a biopsy.
Where will you take the biopsy from?
Biopsy will be taken, incision biopsy from the edge of the.
Okay. Which edge? Take the cursor.
It's a small lesion. Why do you want an incision biopsy here?
Because
ma'am. What is the size?
2.5 into 1.5 centimeter, ma'am, and
Okay, then it's relatively big.
No. Even if it was smaller. Oh, no. I'll make it easy. 1.5 into 2. Will you do excision or you need a biopsy?
I'll take a biopsy, sir, first.
Why is it so important?
Because BCC in this area is prone to have a lot of recurrence. And second thing, 2 centimeter is the cutoff, sir. And below 2 centimeter, we can go for an excision. But more than 2
Excision
centimeter.
here is not just excision; it will be deeper, so it will have a wider outcome, and it comes out to be a furuncle. Then you had it. Then you'll have furuncles all over your body. Okay.
Yes.
So you need the histology, but yes, in very small lesions. In fact, the cutoff is 3 centimeters. Less than 2 centimeters, right? When you can take a clear margin. This is a very crucial area. Nose, eyelid. So you can't, even 1 millimeter is important here. So you're not going to take that margin here if it's a malignancy. Clear? Okay. Any other investigation? You do need some imaging?
Yes, sir. We will need an imaging in this situation because the size is more than 2 centimeter plus. We need to clinically the cervical lymph nodes were not palpable, but the
Are they palpable?
No.
Why don't they get involved in basal cell carcinoma?
Basal cell is very rare to involve the lymph nodes.
Why?
Why? Because basal cell carcinoma gets its nutrition from the stroma itself. And when it was transplanted in one of the studies outside and was placed, it doesn't grow because it takes all the nutrition from the stroma itself. That's why there is no metastasis in basal cell carcinoma. So not very common, sir, but.
No. This is the reason is that if you read your basic books, they'll give you the answer that it involves the lymphatics from the very beginning. It kind of involves them by encircling them. So they can't carry anything further. Okay. Besides arising, the stroma, so all soft tissues sarcomas arise from stroma only, but they can go. It is rare on account of lymphatics getting destroyed early. So no way to carry it was locally aggressive. What surgery would you offer?
2 surgeries are like classically known. One is excision itself, and the second one is Mohs micrographic surgery, sir, MMS.
Excision means wide local excision.
Wide local
You're
excision, margin.
new to the job, so to understand it better. And there are not two surgeries, there are 200 surgeries. So they'll never say one or two. The answer is wide local excision, which can be frozen guided, which is Mohs micrographic surgery, or it can be a wide local excision with a margin of 0.5 centimeter or 5 millimeter. You're okay with no tumor on the ink, okay? But you need to take some margin. Therefore, the defect would happen. And also I was asking you for a different reason. That is where the nasolacrimal duct would be, the upper part. So many times that gets involved and we need to excise more. So it is so important to understand in basal cell carcinoma, the extent of resection and the morbidity you're causing. How will you reconstruct it?
Reconstruction can be, as the bed is cartilaginous and avascular, a graft would not be preferable, sir. It would be the
I didn't say graft. Oh.
flap would be preferable.
Which flap?
In this case, nasolabial
Yeah,
flap.
that's the answer. Nasolabial, or you can even have the old Shushruta flap, no? Based on the, what is this called? It has a name. Glabular flap. Just rotate and cover. Glabular or nasolabial, based on superior or inferior part of it. So no problem with that. But local flap, no need of any major surgery. And most micrographic surgery is definitely what is recommended for this area. Any adjuvant therapy? Not needed. Done. One more presentation. They are missed out. Any question?
If cartilage is involved, you're excising it and cartilage is involved.
Rakesh, are you here? You make your
Cartilage is
presentation.
involved. So obviously you'll have to excise it. So how will you reconstruct?
Sure.
So you won't distort the face. You can take it from the ear.
As a free
Another
graft.
area
You can
which-
put a free graft. Thank you. Well done. At least you made an effort to present, which is also very, very important. Give him a round of applause. You have a question? Oh.
Saying that he was having this ulcer for 15 years, but he came to the clinic.
Can you give him the mic?
So chief complaints should be for 15 years or
15 years. That's what is what.
Repeat again.
I was asking if the chief complaints, can it be that long, like 15 years? He was having an ulceration for 15 years. Or should it be that the ulcer grew in size and
Did it heal in between?
No.
So what is it that made you think it is shorter duration?
Because since 3 months, it started progressing from initial size of 5 mm, sir, and 15 years becomes a like the chief complaint because that predicts the diagnosis or makes us move towards the provisional diagnosis. That's it.
They can stay long for a long period. That is why.
So, sir, I was just asking, like, can we write that in chief complaints? Because, sir,
You are finding it too long a period for a chief complaint, right?
sir, the patient presents to us acutely with a small complaints, and if he's having a problem for
You see,
15
these
years,
are
then-
semantics like you heard yesterday. Patient had a problem. It's not that patient was problem free for all these years.
No, sir, we could have mentioned.
Okay, how would you
his,
like to put it?
Past history, like that he was having.
No, how would you like to put it?
No, sir, actually, I was just asking.
Those
if
doesn't
I had-
matter.
it had-
I just want to know how would you put it, and I'll make it.
That there's a ulceration, painful ulceration for 3 months, which is increasing, progressively increasing in size. And in past
But
history, I would have.
that's not true, no? Because what is your history?
Small pigmented lesions since last 15 years.
So there is a pigmented lesion for the last 15 years, which has started showing this change in the last 3 months. So you have to keep it in continuity. Past is when there is no continuity. Okay. But good question. You're relevant. Thank you. So we have one last presentation that got missed out from day one. So we don't let anybody down because he could not come due to whatever reason. This is Dr. Rakesh from Sir Gangaram Hospital. He has an abdomen. Siddharth Gilda. Yes, please.
A very good evening, one and all. So, My patient is a 52-year-old gentleman hailing from Noida, who is an engineer by occupation, who presented with the complaints of left-sided chest pain 20 days back, with an episode of left-sided chest pain 20 days back. So coming to the history of presenting illness, the patient developed one episode of left-sided chest pain on 5th February 2024 at around 10 a.m. while he was in Mumbai. The pain was in the left lower chest and left upper abdomen, acute in onset, moderate to severe in nature, non-progressive or non-radiating, not associated with breathlessness, cough, diaphoresis or dizziness, and there was no aggravating factors. So the patient was taken to a local hospital in Mumbai. Cardiac workup was done, ECG and cardiac markers were done, and it was found to be within normal limits. An ultrasound examination was done, which was suggestive of an intra-abdominal mass lesion. The pain was relieved on IV analgesics. There is a history of early satiety with patient consuming small frequent meals since 2 months. So there is no history of any previous episodes of abdominal pain. There is no history of any other gastrointestinal complaints like vomiting, hematemesis, melena. There is no history of altered bowel habits. There is no history of loss of weight, appetite. There is no history of diabetes, hypertension, ischemic heart disease, or asthma or tuberculosis. So there is history of patient undergoing right PCNL in 2014 and history of left inguinal hernia repair in 1990. There is no history of radiotherapy in the past. Coming to the personal history, patient takes predominantly vegetarian diet, who has a regular sleep with normal bowel and bladder habits. There is no history of smoking, alcohol intake, or substance abuse. There is no any history of any other abdominal lump or abdominal conditions in the family. Summarizing my case, a 52-year-old gentleman with complaints of one episode of left-sided chest pain and upper abdominal pain with early satiety, and incidentally found to have an intra-abdominal mass on ultrasound examination with no other GI symptoms.
Dr. Rakesh, go back to the first slide and tell me, are you telling me a story casually talking to all of us, or are you presenting a case?
Presenting the case, ma'am.
No, what is so important about 5th February 2024, 10 a.m.?
Ma'am, since it was acute
What
onset,
is so important about your giving call? Is this, how many times we'll go back to the chief complaints also? Only chest pain.
Yes.
Right? But then thereafter you said patient had early satiety also. You attach no importance to that complaint? And especially when you are telling in the history only, I understand your patient must have been educated,
Yes.
you know, but you have given no importance to early satiety.
Ma'am, the presenting complaint was just the left-sided chest pain. Only on probing that the patient revealed that he was consuming small frequent meals.
When we take the history, we can analyze it also and put it in order thereafter so that the other person who's examining you is able to see it. Go to the next slide. You need not mention 5th February 2024, 10 a.m. and all that.
Sure.
Go to the next slide. What is all this about ECG, cardiac markers, this, that, done? All that is treatment history, no? So that's how you need to learn to analyze, right, about the chief complaints. Chief complaints means complaints that matter. You're right when you say that presenting complaint to the hospital was this, but the chief complaints that you've analyzed were 1, 2, 3, 4, like that, right? History of early satiety with patient consuming small frequent meals, right? So what was early satiety? Other than early satiety, did the patient have some other complaints related to upper GI? Let's see what you've written about other upper GI complaints. Right. So no pain, no vomiting, hematemesis, melena. How old is the patient?
52-year-old.
Right. So what significance do you attach to early satiety in a 52-year-old gentleman?
Ma'am, it could be an early sign of malignancy of stomach.
Very good. Go to the next slide.
Now, same thing, I'm sorry. Many terms are actually just put wrongly. You don't mean it that way. You're writing as you normally do, right? As a postgraduate, the presentation is slightly different. So now you can mention there is a history of intervention in 2014 for whatever ureteric obstruction or PCNL was done. And there is a history of having undergone surgery for hernia 1990. And there's no history of radiations in the past. Not radiotherapy, receiving radiations in the past, in whatever form. Okay.
Sure.
Next slide. This is okay. What do you mean by family history of abdominal lump? You talk to a patient and all you want to know is abdominal lump, or what is the purpose of a family history?
So any abdominal malignancy is what something we are.
One
looking
thing
at.
you've just said it. So we'll take any history of abdominal malignancy, not lump. Next. So which malignancy and why are you taking the family history for it? To find out if there is a hereditary basis to the disease. Am I right?
Yes.
So family history is not a casual thing. And I didn't have that presentation this year. I do it every time. I gave it to others to present. When you're taking a family history, keep the patient condition in mind, the diagnosis in mind, take some specific family history. What would you like to know in this patient specifically? In the family. According to you, this is a malignancy involving which part? GIT?
GIT.
Right?
Yes, sir.
So any history of GI malignancies, you know of the conditions now and the syndromic presentation or the hereditary basis. Can you name a few?
Sir, colonic malignancies, colorectal cancers, they have.
Carry on, I'm listening.
And GI malignancies, sorry, stomach carcinomas.
All GI.
Yeah.
No history of any GI malignancies, no history of malignancy. I mean, like basically both BRCA1, BRCA2 related, mainly BRCA2 related can come into this. Then all those HNPCC related can come into this. The examiner should be conveyed that in family history, you're not being lazy. No history of abdominal lump is not a family history. You know, you don't need a lump all the time. You may not have a lump, yet patient may have malignancy. And nobody died of any cancer in the family. It is necessary to find out. Even if it is breast cancer, you would like to find out. So, okay, they can be connected. Next slide. Now, it's very technical history because that's the kind of work which we may be doing. 52-year gentleman with what? What is the major observation in history? What does the patient say?
Sir, early satiety is the only.
So ultrasound examination and other things are not required to be part of this.
Yes.
Let's move to examination.
Coming to the general physical examination, well-informed consent was taken, and the patient was examined in a well-lit room with adequate light, sunlight. So patient is a moderately built and moderately nourished gentleman with a BMI of 23.1. He is conscious, cooperative, well-oriented to time, place, and person, and echo performance status is 0. There is no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, or no pedal edema. The pulse was 84 beats per minute, right radial, normal in volume and character, and blood pressure is around 130/80, measured in right arm, sitting position. Respiratory rate is 14 cycles per minute, and patient is afebrile at the time of examination. So here is just a clip of the patient's abdomen. So this is just a small clip of the lump that is moving with the respiration. On inspection.
Show that clip again. You can see it literally jumping down.
Yes.
Up and down. You can see that. No, moving. Yes.
On inspection, all quadrants move correspondingly with respiration. The umbilicus is midline and inverted. There is a vague lump in the observed in the left hypochondrium and left lumbar region of approx size 12 into 10 centimeter. The lump is appears to move with respiration, and the skin over the lump appears normal. There is no dilated veins, scars, or sinuses. There is no visible pulsations or peristalsis. There is no visible fullness at renal angle. Hernial orifices and external genitalia appear normal on inspection. On palpation, the inspectory findings were confirmed. There is no local rise of temperature. A lump of size 12 into 10 centimeter is palpable in the lower aspect of left hypochondrium and left lumbar region, with upper border being not palpable. There is ill-defined margins with smooth surface. The lump is firm to hard in consistency and it moves with respiration. There is, I was not able to insinuate my fingers between the swelling and the left costal margin. There is no tenderness, guarding or rigidity. On the examination on right lateral position, the swelling does not shift to the opposite side and there is no renal angle tenderness. The hernial orifices were normal and the external genitalia was found to be normal. On percussion, there was dull note on percussion over the mass and normal bowel sounds were heard on auscultation. There was no bruit heard. On rectal examination, there was no palpable growth or lesion. On systemic examination, cardiovascular, respiratory system and neurological system were found to be within normal limits. Summarizing my both history and examination findings, 52-year-old gentleman with complaints of one episode of left-sided chest pain and upper abdominal pain with early satiety, incidentally found to have an intra-abdominal mass on ultrasound with no other GI symptoms. On examination, a lump of size 12 into 10 centimeter palpable in the left hypochondrium and left lumbar region with upper border not palpable, ill-defined borders, smooth surface, moving with respiration, firm to hard in consistency, palpable below the left costal margin. I'll like to consider two provisional diagnoses. One is gastrointestinal stromal tumor and a retroperitoneal mass.
Well, I know this case we operated last week only. So your findings are correct, but nobody would believe them. You know, that is a tragedy of the world, because we thought all along differently. It came out different, but important points were covered. But it was not to the left hypochondrium. It was slightly mostly to the lumbar side, just about going to the left hypochondrium, and we could get above. So the problem was in the posterior part that we could not go beyond because it was occupying that space. And, a retroperitoneal mass is not known to move on respiration unless it is attached to something which moves on respiration. That is what we discussed. So it was in this case, which is the only retroperitoneal structure, that organ that moves on respiration? Kidney, right? So it was attached to kidney on one side. I'll break the story.
Kidney and spleen.
And it got attached to, yes, in between the kidney and spleen, occupying the pancreatic tail, engulfing it and going to get attached to the crus. And it was behind. So very huge tumor. And it was, your findings are all correct because I know these are the findings. But many a time you need to be a little clever in the exam. And he actually presented with chest pain in Bombay, for which ECG was done. And ECG did not find anything, so they found no cardiac problems, so they did an ultrasound. So on ultrasound, they found a lump. This was the first time that it got detected. Now, answering your question, how should we put up the history? Because you asked me yesterday. Now I understand why you are asking. So should we start you should start as it started. Don't worry about it. Tell as it is. Don't mix it up, and you did not. But importantly, you were preoccupied with mentioning those things. You could have started by saying the patient had a history of chest pain, for left-sided chest pain, suspected to be due to ischemic heart disease, taken up for investigations, and on the ultrasound of the abdomen, while the investigation of the cardiac thing was normal, he was found to have a lump. And ultrasound also reported a retroperitoneal mass, query gist also, because of its movement and its closeness with the stomach. It was almost attached to the wall of stomach, so it was thought that it's arising from there and is going down, while it was arising from below and going up. That is the case. This is the case, if you want to discuss. Renal angle was not full because kidney was not enlarged. But kidney was via the space, the kidney, there was no plane between the two, so we had to take that out. That is the reason why we had to remove the. Incidentally, the kidney, along with the tail of pancreas and therefore spleen, and the entire thing had to be, initially we could not do the clearance. So we went for what is called a compartmental resection in retroperitoneal sarcoma. So we went from below taking up everything and block, and we found stomach was free. It was just that it appeared on imaging that way, and the whole thing was removed and block. That was the case, right?
So we'll ask you just.
Forget the story, but you can stick to the cases.
Yeah, no, everything has been told by sir. Just tell us one basic fact that to be able to remove this said compartmental excision, you would have mobilized the retroperitoneum and the colon.
Yes.
So when you do the Mattox maneuver and you do cattle brush, what is the difference between the two with respect to kidney?
Please clarify the question. You don't understand.
So you will do cattle brush maneuver on the right side and Mattox on the left.
side.
So in both, you lift the colon off the retroperitoneum,
Yes.
right, to get into the retroperitoneum.
Yes.
This is exactly what you wanted. So with respect to the plane of the kidney, what is the difference between cattle brush and Mattox? So on the right side, when you do it, kidney is left in place and you're in a plane above that. When you do a Mattox maneuver, kidney is always lifted up. So here it made your job easier, but otherwise you have to be careful about the kidney.
What did you understand? Cattle brush versus Mattox. What is Mattox maneuver? You won't understand unless you know the first part, right?
Sir,
What is Mattox?
left
to right. Cattle brush?
right to left.
What were they designed for?
Sir,
For aorta and IVC. They were basically vascular. And when AAAs were happening, they would mobilize. And when you're doing it on the left side, there is a difference as compared to right, as you mentioned. And importantly, we had to remove a part of the colon, transverse colon also, which I didn't mention, and we repaired it. And the incision could be, anyway, that is separate. In this description, I didn't find anything wrong, but it can get reorganized. And you can't be saying both in the same go. So you could have started by, when you're giving a diagnosis, you could have said 50-year gentleman with a retroperitoneal lump likely to be this. But rare possibility of a gist, because gist can get attached to the backside of any viscera, and that can be retroperitoneal then, because some part can be retroperitoneal. How do we proceed? Secret is open, so we had an ultrasound, we did a CT, we did a PET CT also. So must tell you, sorry.
In history, we could have taken history to rule out an acute attack of pancreatitis, something happening in the region of tail of pancreas and a mass happening there.
He was a completely asymptomatic individual. His retroperitoneal sarcomas can present absolutely without any history, and they can have a large mass before. This is exactly what happened. What is it that we could have done to approach it? Something that I've kept murmuring, but we did not do. A bed is an issue, getting a bed, getting admitted, etc. I wanted to do something to reduce its vascularity.
Sir,
Louder?
adjunct radiotherapy.
No, beforehand. No, don't do blunders. Adjunct means later. Embolization preoperative. Because it was some part was coming towards the renal vein and also towards the aorta and IVC. But we were lucky that it did not derive supply from there. So that is one thing you could have done. And the orientation, the specimen when they asked me later on which margin, sir, you particularly want. So I had to write back again. We need the margins on all sides: colon, spleen, kidney, and stomach, all four, and the deeper margin. What should he receive in? What is the likely pathology?
Retroperitoneal sarcoma.
No, which type?
Sir, liposarcoma.
Very common is lipo. Any other?
The other could be a leiomyosarcoma.
We were also, the anesthetist kept saying, sir, it is giving me his words were, it's giving me the fun of FEO during surgery. BP would keep dropping or keep rising. So adrenal was very close. So we wanted to disconnect that vein first, because they may have all those features too. So we did not know what it was when we started. Well presented, Rakesh. Thank you very much. Give a round of applause. Louder one. I know it's the last case. Shall we do the ward rounds? No, with head nodding, nothing works here. Say loudly, yes, then I'll do it. Louder, this is more. No, no, no. Louder. Good. Come to the front, last people. Did not score all because those who crossed the benchmark of 60% only. And UG got upset.
Shall we start, sir?
Yes, please.
So we have a 45-year-old gentleman who was a resident of New Delhi who presented to OPD with the complaints of left upper quadrant pain. The pain was stabbing in nature. He had difficulty, it was associated with difficulty in breathing. It was not radiating to anywhere. And he was relieved with analgesia to recur again. Actually, on further probing, he gives a alleged history of fall from the tractor seat a day before, after which he developed this pain abdomen. He's a chronic alcoholic and a BD smoker for past 15 years. There's no other injury to any other part of the body. There's no past history of any surgical interventions. On examination, his vitals were stable. Though his pulse rate, pulse rate was 100 per minute. The respiratory rate was 18 per minute with saturation of 98% on room air. There was no paralysis, cyanosis, or clubbing or lymphadenopathy. On per abdomen examination, the umbilical is central. The only positive finding was a mild tenderness present in the left upper quadrant, closely to the left hypochondric region. There was no organomegaly, there was no abrasion or laceration present, and bowel sounds were normal. We went ahead with blood investigation. Initially, he had gotten an investigation from outside. It was showed HB to be of 16.3, and to repeat complete blood count, his HB had fallen to 13.4. To be sure, again, we got a repeat CBC done, which also showed 13.2. We got a chest and abdomen X-ray. This was his findings.
You can't keep moving, no? Then what would you discuss?
Yes, this was the case.
Okay. Let's start. Ayush, can you float the mic? Give it to him first. What do you see in the X-ray?
So left side, I see chest X-ray, PA view, showing so trachea and midline with normal ribs, bones, and bilateral angles are free of any fluid. And right side, I think there's a horizontal fissure is prominent. Might be suggestive of pulmonary edema initial. And bowel loops, air shadow is visible in the loops, which is featureless. So air in probably ileum and some air in stomach as well. On right side X-ray is X-ray flat plate abdomen. I could see all the vertebrae aligned in midline and bilateral iliac blades with sacroiliac joint with similar air shadow in bowel, featureless, and yes, sir.
Okay. What do you suspect at this point?
Sir, since he gave history of fall from tractor and left upper quadrant pain with sequential falling of hemoglobin, I would suspect a splenic injury.
Okay.
So we went ahead with ultrasound. Ultrasound findings were suggestive of an ill-defined heteroechoic area in the lower pole of spleen with perisplenic fluid. There was moderate free fluid in the peritoneal cavity as well. What next? Next.
Yeah, this is the question. You can pass it to the next person. What should we do next?
Since the patient's vitals are stable and his HB is reducing, and the ultrasound came as positive, we would go for CECT whole abdomen to go for AST grading of the splenic injury and plan accordingly.
Yes. As rightly mentioned, we went ahead with
How do you grade them?
Sir, AST grade 1 to grade 1, 2, 3, 4, and 5. Where grade 5 is complete splenic rupture, but grade 4 is we have grade 5 is avulsion of the spleen. Grade 4 is there is a hilar rupture, and grade 1 laceration of the spleen is present, which is less than 1 centimeter. Grade 2 is laceration 1 to 3 centimeters, and grade 3 is more than 3 centimeters in size. And in grade 1 to 3, we also have the hematoma as a component. If only 10% of the subcapsular hematoma is present, it is grade 1. In grade 2, I think it is from 10 to 50% of the subcapsular hematoma surface area is present, it is grade 2. And grade 3, more than 50% of the surface.
How does this grading help actually?
If grade 1, 2, 3 are present, and if the patient is if the hemodynamically stable, we can go for conservative management of the patient. And in grade 4 and grade 5, we'll go for exploration and splenectomy.
What is conservative and what is expectant management? What is the difference?
Expected management, yeah.
What is the difference? Next.
If we monitor the patient and we are expecting, if we act according to the patient later on, then it will be expected management. If we are keeping the patient in non-operative only, it is only the conservative.
So you may be keeping that intent clear that you may have to operate also. So that's like expectant treatment. So conservative treatment otherwise happens in a medical ward. So treatment, observing these patients in surgical ward is the purpose. So that's expectant. What do you see in the CT?
As you can
I can see the hypoechoic area in the hypointense area in the splenic region. And liver is normal with no retroperitoneal region is also normal. Chest, bilateral chest is normal. No fluid accumulation is seen.
All right, this is the case. What would you have done next?
Serial monitoring, as the patient is stable, and I would like to know the grade of the injury of the patient, splenic injury.
Read it. Read it.
So it showed multiple splenic laceration in the upper, middle, and lower pole, with depth of largest being 4 centimeter. On arterial phase, multiple small patchy areas of active contrast extravasation was present in the middle and lower pole of spleen. Few of these areas are rounded in shape and suggesting pseudoaneurysm formation of segmental vessels. It was graded to be grade 5. The splenic artery was normal, and perisplenic fluid was minimal, 14 mm. And the two well-defined splenenculi was seen at the lower pole.
As there is active contrast extravasation is there, that means there is active bleeding seen. So I would like to go for exploratory laparotomy of the patient, and then I'll see.
Is there any role of involving the IR people here, intervention radiology people?
We can go for embolization. If the for splenic artery embolization can be done, if the spleen is salvageable, and if not, we'll go for a splenectomy.
Okay, please pass it on. Next. Do you have?
Yes. So, like she mentioned, we went ahead with ASA with embolization of splenic artery. The patient.
Would you like to comment on it? You can speak about it, no problem. What is it? What DSA with embolization of splenic artery?
The splenic artery, as you can see here, it was embolized, which the non-opacification was not seen later on. It's completely embolized. You can see the spleen here. Contrast, which is taking up the contrast. Moving on to the next presentation. Harsh, can.
So wait. It is not that if you do splenectomy, it will be a wrong decision. Okay. You getting the point? So don't misunderstand. this step, but you should be aware of this also. This is available, you should do it. I taught yesterday as to what is the difference between emergency splenectomy and a planned splenectomy. So what will be the difference? What will be the emergency splenectomy like? What do? You must have done. So
In emergency splenectomy, we will directly deal with the hilar region first. We will ligate the both artery and vein together, and then we will came to the this ligament part.
And
in the elective session, we will give the mobilization of the spleen has to be done first, then followed by first we will ligate the artery, then followed by the vein.
And also you look at the indication for which you're doing it. Say if it is ITP, you would like to look for all the accessory spleens and what they found in gastrosplenic ligament and also pelvis. And in the infracolic area, you would like to look for it. Right? Good. Very well answered. Give a round of applause for all of them. We move to the second and the last case. So please start.
Yes. Second patient was a 52-year-old gentleman who presented to the emergency with complaints of. Harsh, can you give me the controls? Okay, I'll go ahead with the case. So it was a 52-year-old gentleman who presented to the emergency with pain abdomen for the past 6 days, with non-passage stool and flatus for the past 4 days. The history of present illness: he had abdominal pain for the past 4 days, which was sudden in onset, which was severe and was constant throughout and diffuse over the abdomen. However, there was pain more in the periumbilical region, which aggravated with food intake, and there was no relieving factor. It was associated with abdominal distension. There was also with non-passive stool and flatus for the past 4 days. He also had multiple episodes of non-bilious, non-projectile vomiting. He's a known hypertensive who is on CCBs. He's not a diabetic. There's no history of any consumption of drugs. There's no surgical history. What other history would you like to ask?
Yes, Meet.
Yeah,
Summarize.
It's a 52-year-old gentleman who presented to the emergency with complaints of abdominal pain and non-passive stool and flatus for the past 4 days. Pain was diffuse, severe, and it aggravated with the intake of food, and there was no relieving factors. It was also associated with multiple episodes of non-bilious, non-projectile vomiting. He is a known hypertensive on CCBs. No, there's no history of any drug intake.
Any exposure to TB or any positive family history?
No, there's no history of TB or TB contact.
So what are the possibilities that are coming to your mind? Colicky pain, non-bilious, non-projectile, and plus history of hypertension given for some reason.
Any other previous surgery history?
No, he has a significant, there's a past history. He had episodes of colicky abdominal pain on and off for the past 1 year, which also aggravated with intake of meals and was relieved on medication.
And is there any radiation to the back?
No, there's no history of any radiation.
So what are those pains that are aggravated? Supposing you consider there is a problem in the stomach or
Gastric
duodenum.
ulcers will get
So which pathologies will get aggravated with meal or do you think pathology is lower down?
If there is any gastric ulcer, then there will be aggravation on intake of the food.
And duodenal ulcer would improve with
Yeah.
pains. That is one possibility you may keep in mind. Anything else? And can any other pathology present with pain in the upper abdomen with non-bilious vomiting?
If there is any outlet obstruction, then there will be a non-bilious
One, we've talked about that. What are the other conditions in which you get postprandial pain in a hypertensive patient in middle age group? I also don't know about the case I'm reading with you.
Let's go further. What is the missing history? What would you like to ask? You mentioned. What next would you do?
as an extension to my clinical history, I would like to get ultrasound.
So before that, on examination, he was conscious and oriented. His BP here, he was hypertensive with 84/60, and he was tachycardic.
So
Pallor was present.
you can see that now. There's few things happening. Okay.
Moving on to the per abdomen examination, it was distended. On palpation, there was guarding and generalized tenderness present with rebound tenderness appreciated. Percussion was not in view of tenderness, and bowel sounds were absent.
Any organomegaly?
There's no organomegaly, there was diffuse tenderness.
Diffuse tenderness. And
different
there is a guarding as well. But I would like to get ultrasound further and to get erect abdomen X-ray to check for the bowels.
Okay.
So prior to investigating, we went ahead and did a digital rectal examination.
Which is why I was
Yeah.
asking. So
It is
DRE is to
later
be
that-
done. What do you see? Read up.
So the anal tone was normal, there's no ballooning or there was no growth felt, but blood and mucus on finger showed blood and mucus staining.
Nothing. Okay. What is ballooning?
So if there is any air collected in the rectum, then we will see that there will be emptiness felt on digital rectal examination, which is
What did
called
you
as-
say? Air collected there? How
Sir, if there is any air in the rectum, then there will be emptiness felt on digital rectal examination, which is called as balloon.
If there is air in the rectum, he'll pass it.
Dilated empty. If then.
How do you clinically define a rectal ballooning? Rakesh, pass it on to him.
During DRE, the walls of the rectum, which is normally collapsed.
You cannot feel them at the same time. So that is ballooning. What is the physiology behind it? If you want to speak, then you speak into the mic.
Because of the obstruction, the distal bowel tend to dilate.
Dilate, the gastrocolic reflex only. The peristalsis that way. Because the distal part prepares for receiving the peristalsis. So this is the usual polarity of the gut. So the ballooning, rectal ballooning is a feature of dynamic obstruction. It's not adynamic. Ileus, you may not have it. Yes.
So as part of the protocol, we got an ABG done and calculated the Apache 2 scoring as well. It
It's
came out to
15, which is not surprising. Yes.
And later on, what are the investigation you would do in this patient?
Apache has been done, so those investigations must have been done. Any specific investigations now?
Sir, now we will have a ultrasound and
Ultrasound.
abdomen erect X-ray.
He wants an abdominal ultrasound first?
Ultrasound first, sir.
Okay.
Bedside availability, sir.
Okay.
So this is the...
With this kind of an abdominal ultrasound won't be very useful, right?
Dilated.
So, yeah, so it would be difficult. So what do you see here?
This is a abdomen plain radiograph of abdomen erect X-ray, showing that there are no vertebra, the spine are all normal, including the sacroiliac joints, ilium, and there are distended bowel loops which are seen, and Ryle's tube, nasogastric tube, as also seen in the stomach.
I can see some contrast somewhere. Can you see some contrast in the lower part? Maybe I'm seeing it wrong.
Enema.
We don't use barium at all. And in acute abdomen, barium is contraindicated.
Enema.
Why is it contraindicated?
It could be, there could be peritonitis, perforation peritonitis.
It can incipient, precipitate obstruction and
Irritate.
perforation and peritonitis. And barium peritonitis has a mortality of 100%. So you are 100% marks there. But there is something there. What do we do in adhesive obstruction or doubtful decision? I don't know if it is the same case. I don't remember. It must be old. Gastrographin can be done. It's water soluble. So do you have anything to show next?
Yes, sir. Patient was optimized. After that, he was actually...
This X-ray is suggestive of any problem?
No, hypertensive patient, postprandial pain, blood on fingers, tall, on doing a digital rectal examination, clinical features of guarding and rebound tenderness. Mesenteric vascular ischemia with
So
gangrene.
why are you suggesting to them? That is what the case was. No, I didn't hear that answer. Next.
So we got a contrast CT scan done. It showed a stenosis of a celiac trunk at its origin from aorta, and there was a thrombosis of 2.5 centimeter long in the SMA at its origin.
We wanted a classical case, as Dr. Ratna could pick it up, but you should approach it like any other patient with acute abdomen, with unexplained hypotension and a past history of chest pain. These were the three clues here. If you were, really looking for clues, these were the ones. She caught them. Please come out with everything.
One more point before he goes to the next one. In all those patients in whom you do not find free air under diaphragm, you must get serum amylase levels done.
And it also showed dilated stomach and duodenum, suggestion.
The only problem is all of them will have amylase raised, because amylase is non-specific. And I have been bitten many times. Patient on pancreatitis treatment, not because of me, but my subordinate. I am on leave for a day. I come back on Sunday and I will take a round on Sunday itself. And I say, open this case up. He said pancreatitis and they've got it, no gas, nothing. It's not guarded abdomen. Operate. Even if I do all this jiggery pokery, there is a dead bowel which will still need to come out. As a surgeon, please understand, a negative laparotomy is better than a positive autopsy. Don't be wise like a physician is usually. I speak every time it gets recorded also, there's no problem. It appears YouTube, they watch, some physicians respond also. They will write the patient has died already. The diagnosis would be this, possibly this, possibly this, possibly this, and this needs to be ruled out. Died already. What are you going to rule out? Surgeons act differently. Nobody can catch you for opening up this abdomen, even in the today's very, very bad era. We lived in a better age when it was easier to explain. I thought my gut feeling meant laparotomy. I have spoken this in the court. I felt that patient would benefit by my opening up the abdomen, so I opened up. And the judge said, that's fine. But today, if you say that, oh, who is interested in your guts? They will tell you, we just want to evidence, show me the lawyer would have read, and one of your colleagues would have educated this lawyer like some people are presenting their cases today. Unless you know yourself, you can easily see through. Please read it out.
Yes. So we looked for the vascularity of the bowel. There was no definite bowel ischemia was seen in CCT. So how would you proceed in this case? So this you can see the...
Now listen, CCT says no bowel ischemia. Clear? There is a block. Patient has guarded abdomen. That's where the radiologist ends. And the clinician starts. You should take charge. Thank you very much. You supported my diagnosis. I've understood. There is a problem in SMA and patient is guarding. You would be foolish not to believe that there is ischemia. Not perforation. Ischemic bowel also produces peritonism. Peritonism would happen. If there is peritonism, patient needs surgery, sir. There is no confusion. Clear? And all of them will have raised amylase with due respect, because amylase is specific. It can rise. Yes, sir.
Unfortunately, because the bowel was seen to be normal, CT angio was done. And
this all happens in the night.
And stenting was done of the SMS.
Carry on. Somebody had a stent also, so you put it in. Next.
So even after stenting, patient symptoms did not improve. Neither did the signs. So we got a repeat ultrasound, CT done, which showed gangrenous proximal jejunal loops with adjacent fluid collection, with patent SMA stent with normal distal SMA.
Carry on. And tell them what happened on Monday.
Then we took up the patient for
morning rounds. I said, to hell with all of you. And what is all this nonsense that happened? And it happened, there was a faculty involved also. I said, don't ever do it again in my unit. Take up the patient for surgery. It's a waste of time. All this is waste of time. Please understand this. And especially those who have the facilities, it happens that somewhere some people get involved. Clinical diagnosis is primary. So this needs intervention. Okay?
So this was the intro of findings. So multiple patches of gangrenous segments were seen extending from 15 centimeter distal to 1.5 centimeter proximal to ICJ. The rest of the bowel and viscera were visualized appeared normal. So
Now what do you do, sir? I think we can take some front people. Yes, you get up. The number 2, Siddharth.
There's already.
No, what do you do now? Mic is working. Don't disturb that. What would you do?
Gangrenous ball loops, sir.
Now, with the hindsight, was it possible to march in early? No, speak in.
Yes, sir. Yes, sir.
And if there is a patient with suspected peritonitis also should be actually operated. Our threshold for that surgery should be lower. And we have done it. We have shown you the problem that happens. We delayed it actually. We shouldn't have. That stent has a problem. What is the problem? What can be the problem in an ischemic part and the rest being normal and you put in a stent? What can go wrong?
Reperfusion.
Excellent. Give him a round of applause. So if you have that wisdom, you should have control. So how do you prevent that RPI? You want to take it? Next one. How do you prevent reperfusion injury anywhere when you're doing surgery for, please sit down. Decompressive laparotomy for abdominal compartment syndrome, for limb. How do you prevent reperfusion injury?
Can hydrate.
Yes, good is hydration.
100%.
Oxygen, yes. Nobody, he is answering well. Plus? You don't know? No problem. The lady there, corner. You don't want to answer? Behind?
Resuscitation and decreasing the time of shock the patient in and permissive hypotension, so that when the reperfusion happens, the body will be acclimatized by that time.
Please, see, we should not stretch it too far sometimes. Don't push the envelope too tight. Next one. How do you, when you're doing decompressive laparotomy for abdominal compartment syndrome, that is usually done. We have a cocktail for that. Yes. Now suddenly the mind would start functioning. You see what is happening in reperfusion? The acidotic contents, they get released into the perfused areas. So they go into circulation, so there will be acidosis, number 1. 2, there will be splanchnic fullness, which will lead to reduced preload. So you need to replace volume 2, right? And 3, what do you do for the acidosis? I'll ask you. And now this entire thing would have clogged the kidneys. So they may go into renal failure. So diuresis. So it's a cocktail of soda bicarb, saline, and diuretic, mannitol or Lasix, generally loop diuretics. This is called decompressive cocktail, which was traditionally used in limbs and it is used in abdominal compartment syndrome. If the pressure is okay, you don't need vasopressors. Okay, what is the problem with vasopressors? Usual problem. You can take it, you're speaking. How do they act?
Vasoconstriction.
You see, if you have only 50 rupees, you can only push from one pocket to the other. Then one pocket would be empty. So the push is towards center, core zone. So the peripheries may suffer. So the guts may suffer. And you may gradually get into that situation where it is not reversible. So if the patient is in shock, it is usually due to splanchnic, vasodilatation, as I mentioned. It may have a role, but in very, very low doses. So that what they used to call in ICU as the renal doses. So when the kidneys don't suffer and you still are able to achieve. Okay, is that clear? So we can prevent that in open surgery as well as when we put in a stent. What was done?
So we went ahead and did the resection of bowel. The entire bowel had to be removed. So we had to do a resection of pathological bowel with division.
Now the CT did not suggest it. So please understand, you don't treat the CT, you treat the patient. CT angio was done, stenting was done, it still could be missed. And we have some very fine IR team there at something. So you can imagine it can happen anywhere. Yes.
Later on, post-operate, he got extubate on the post-op day 3. So these were his parameters which improved over time. And the important points was we started feeding from the distal loops.
Enteroclysis we do. We take out because short gut syndrome. How do you define short gut syndrome? Somebody here now. Anybody? Yes, please. Mic to her. Quick, quick, quick.
Remaining of the bowel length less than 2 feet, less than 2 meter.
2 meter, 2 feet,
2 meter,
200.
less than 200.
पीछे उससे भी पूछ लो 150. Huh? Anybody here? It is some
200 centimeters.
oh, अच्छा वो है 200 centimeter or something to do with the kg weight.
Less than 1 centimeter per kg.
There is an answer to questions which is proper. It may vary. It's a child. What will you do? उतनी तो उसकी gut ही है. So it is 100 centimeters is optimum for management. Okay. And the easier answer is, as we discussed. So more than that, not trying to suggest that is what you achieve. And then it can be anatomical short gut syndrome, or it can even be physiological short gut syndrome. You may have functioning bowel, which is less. The length is okay. So that has to be taken into account. Enteral nutrition is superior to parenteral nutrition. So we try to provide enteral nutrition. And how do we do that? We connect the short gut proximal and we put it into the distal. Utilize as much as you can. And there is ilealization of colon which starts happening. Ascending colon starts doing the job of the ileum, terminal ileum. And gradually, that's the only hope the patient has. There is bowel transplant which is done later. We just pull them through and we do go for early anastomosis as far as we are concerned. Only 3 patients out of many that we must have worked on, 3 could survive, where they couldn't go anywhere actually. And maybe they had just about, they continued to have loose motions for a long time. What is the boy's name? Piyush, or what was the corner bed? Apur, yes. So for 3 weeks, we had lower threshold for closing. And they somehow survive if they can, with the support is good, families supporting them. But important to understand this logic. Okay? That's the case. Any questions? Yes, please.
What is the sensitivity of a CT scan in diagnosing the features of ischemic bowel symptoms? This patient, we were not able to catch that early on.
You want to answer?
Exactly. So you can see, but you'll have to take a relook at the CT, go on the console and see if you can see intramural gas shadows or not. I remember of a patient, like sir was saying, he was a young boy again with tense, tender abdomen being managed as dengue fever. We did get the amylase level done, but because clinical features of peritonitis were present open, there was gangrene. We sent the CT to the radiologist for a relook at the CT and they reported it as colitis. So I don't know what the sensitivity.
So it is possible
input.
that the radiologist can be smarter than we know. I'm not suggesting that they all can miss it. But in most situations, it's a clinical diagnosis which should be, the clinician should lead the radiologist into thinking. Now, what could be missing here, I'm telling you the answer, is that clinician did not push him enough to tell him, no, there's guarding, better look for it. I'm not happy with your impression. But that usually doesn't happen, especially in places like, the institute where I was earlier. There are just too many patients and too much to do. So the radiologist can easily say, I don't have time to, I'll go, he'll sit with me on console. He has no business he has no courage also not to do it. But the problem is, an average junior faculty or a registrar going and asking, they may say, this is our report. If you like it, like it. If you don't like it, go. And IR people can find out even better. They're studying each, they're going into each vessel. So sensitivity can improve with angio, which again has a challenge. So always be guided by clinical impression of a situation rather than imaging. Do not treat the CTs. Don't treat the MRIs. Don't treat the X-rays. Treat the patient. The patient has to be getting better. Many a times the CT can be, flabbergasting you, but patient is fine. You can take a decision accordingly. It has to be tailored. But sensitivity, especially for ischemia, is not that high unless they add angio and other modalities to it. Now, serial CTs with the axial, cuts, which are where you can sit on the console and see all the films, you may pick up. But like she said, gas, and there are other features. But this is too glaring to be missed. Clinically, we should decide to go in for. In these cases, the decision should be early. Any question from anybody else? Yes, sir.
Sir, you told like in any hollow viscous perforation in any peritonism, it is will go for surgery. Suppose there is a small perforation in the gallbladder, which happened in my institute once. So, but the patient was not having any kind of only tenderness was there, no rigidity, no guarding. But hemodynamically, the patient BP was dropping a little bit, like 100/60. The patient was conservatively managed. So, should we undergo conservative management, expectant to seal the perforation, or will go for laparotomy?
A very good situation. Gallbladder is slightly different because gallbladder perforations happen, spontaneous de novo perforations happen in immunocompromised, weak people, typhoid patients. Stone-induced perforation would be impacted stone and back pressure and rupture, right? So it'll again depend how old is the patient.
It was a lady of age. She was a lady of age 52 years. Like.
Okay, so a lot of them are ICU patients, older. Diabetics with emphysematous cholecystitis, they may have a very fulminant infection. That is okay. And many a times in gallbladder perforation, omentum will go and will be able to seal it. And if it is sealed and if there is localized peritonitis, you can get the patient out with expectant management. But this is expectant again. You may need to go in any time. Or limited intervention in the form of cholecystostomy, which is again guided. Image-guided cholecystostomy can take care of the perforation. So it is possible to do non-operative management in gallbladder cancers. But peritonitis gets very limited. It's a supracholic compartment, right? Here it is a massive disaster. So answering your question specifically, your answer in the exam would be, if the general condition is good and the diagnosis is clear, patient is guarding, I'll operate. Now, operation doesn't necessarily in these days means you cut open. You can even put in a scope. You can put in a laparoscope to see what is the position. You can even close it on laparoscopy. You can put in a cholecystostomy tube, which we used to do in the past open. Now it is under guidance, so you can do that. These are options.
Thank you.
Another person had raised hand. Yeah. Very good question. Very good question. They have a role only in acute scenario. Naturally, chronic scenario, the collaterals would have developed. The stent can only work if there is no distal runoff. Distal runoff in any situation means there is a block, but collaterals have developed. In an acute scenario, it can help you buy time. It stops progression of ischemia. The gangrene won't progress. Line of demarcation would appear. You can go for a. This is not line of demarcation. See, patchy, spread out. So mostly patchy would be terminal, not the like in the limb you have focal spots. So these are embolic mostly. So you don't find them very useful. In major vessels, stent has a role. They also stented the major vessel. So others could not be salvaged. Now they can claim that because of the stent, the rest of the bowel survived, but then most of it is gone. Gangrene means you open up and do surgery. With that, we close it, and we will have, as always, we have a short valedictory, and where we announce the best performances, which are not the only performances that are good. We pick up beyond a benchmark. We set a benchmark of at least 70%. So all those who got more than 70% are selected as the scholars for the Gurukul that we always, every year we do the ceremony. This time we are not doing it because it was at a short notice. And many people are virtually attending, so they should not be having a disadvantage. That's why we don't do it. So any questions, Rakesh? Anything that you want to ask, Siddharth? What's your name? Sorry, Siddharth is you. You are anything? Ayush. There's one Ayush here also. He's also Ayush. Yes.
During abdominal examination, is there any significance of doing auscultation before palpation?
Why do you want to do? You want to put on trousers first or the shirt first? It's your problem where you are. To me, it matters nowhere. You just got to describe it in a particular manner because they've designed a system and you have to respond to that system. We don't like it either way. But yes, would you like to ask? Would you like to auscultate first or palpate first? Take it to your. Will stimulate the bowel sounds. Do it to one patient of mine. I need one. He's not passing the wind. You can do it to me.
I thought you're going to say that you will palpate as well as auscultate
I
with
think you
bend
can
of
do
the
a good job.
stethoscope.
I could never do it. I've tried so hard doing it with my hand. So the fact you're laughing, you know how stupid is that statement? Not from you, from whosoever wrote wherever, whichever book. I've written a foreword to many books which you people read, but don't believe everything inside that book. Forward I had to write because of them being my friends or associated or juniors or colleagues. So writing a forward doesn't mean, "Aur sir ne keh diya kitab theek hai." It's not true. There is percussion of hernia in couple of them, which I find absolutely ridiculous and silly. You raised your hand? Don't be scared, yes. You had a question to ask.
I explained things like that. It was a YouTube channel. So it mentioned that auscultate was before percussion. It was not palpation, it was percussion. Because percussion is
Now, they did not define possibly to percuss with what they're percussing. Some hammer or something. Or you're sitting on the tummy of the patient and doing it. These things are, wow, have some sense. You're all intelligent people, right? Now, gone is the story of apples and oranges. It started a brown nut, groundnut, football, etc. Because we've become wiser every day. No? So we'll call centimeters. When you have to call centimeters, might as well call centimeters. Okay? So with that, we would want you to all stay. We conclude. And maybe I'll request Dr. Ratna to join me. We usually used to have a crowd of faculty. It's a working day, unfortunately. We used to end on Sundays earlier, but we timed it in such a way so that you all, it was coinciding with some exam or something. That's how it happened. So before we close it, big round of applause for all of you and to the faculty that we were joined by. And Adam, you can come here. I'm also quite happy to announce that we had to make it virtual and we had to do it in a hurry because we were planning the Scrubs course much earlier than this. But then I had to move and many things were happening. So usually we do it in February. It got shifted a little bit. Early February is when we do it. Now everybody did well, and there is no shame in thinking that, or I'll do with this. Huh? Okay. So we had given the best marks based on the faculty. We've given the ranking based on, please sit down. We'll conclude now. The head and neck session had some wonderful presentations. Breast had some very, very nice presentations. Abdomen, there were 3 sessions. So there are more in abdomen. Extremities, there is only 1. And only some people could get that benchmark sorted. Now, first of all, we'd like to have your feedback as to how did you feel, starting with you, Umar. Pass the mic to them. One mic to madam here and one mic to them. You can speak.
Okay, so I felt really good, means at least I got to know my foolishness where I was.
You can switch off the this one, the projector.
And got some hint how to think. So nice session.
Enjoyed it. Yes. Thank you for coming all the way. Where did you come from?
Aurangabad means my college is in Akola. I live in Aurangabad.
Aurangabad. Okay, pass on.
It was a great learning experience. I would like to join in every year for this course.
Wonderful. No, you can pass to your left there. These people also need to be speaking.
This is the first time, sir. I've been watching all your YouTube videos. I think I've learned how to wear a gloves from your videos itself. So this is the first time I'm doing this live, and I think I enjoyed it thoroughly, sir. I could attend only one day because I'm in first year and there were a lot of duty tasks.
No, but for a first year, you did very well. Give him a big round of applause. And you got a deceptive smile. One would not know whether you're happy or you're unhappy. So I didn't know. That's why I asked you. I'm glad you enjoyed it. Thank you so much for coming.
So first of all, thank you for organizing such an amazing, very informative and learning experience. Actually, I've never been to such events, and I got to learn that I have to study a lot. Really, thank you, sir. Thank you, sir.
Yes, Rakesh.
Thank you very much, sir, for taking the pain in organizing such stuff to make sure that the students learn. And this kind of programs really set a benchmark for us of to what standard our presentation needs to be, so that's something we can look up to and then emulate.
Good. You made a good presentation. Round of applause for him too.
First of all, I would like to thank both of you, sir, because I'm seeing just starting of the day to ending of the day, you both are examining all the candidates and not giving the knowledge, all this to all the without getting demotivated. Like you motivating us, it's a good thing. I'm attending these clubs from the first year.
I know. I remember you as the first year.
Yes.
And you were there in Hamdard Institute also. I told you to go out and wear shoes.
Yes.
You're the same person?
Yes.
And you were to wear the gown. Actually, we have a gowning ceremony at the end. And he was selected to be presented the fellowship, but he was in slippers. I said, in slippers you can't wear gown. So it was you.
Let me
You
recite
put
it.
on some weight. Good.
Let me recite it. He's my PG. Sir was standing next to me. Listen, who's this person? He's in his slippers. To which hospital does he belong to? Like looking at him, I said, sir, actually, he's my postgraduate. He'll come in shoes. So I told him, go to the hall and get somebody's shoes and come in shoes.
Well, I'm sorry about it, but that's how I'm stickler about the turnout, the way you are. Yes, sir. You too, I remember in first year. How did you gray so quickly in 2 years? I don't know. Really, carry on.
Sir, a big thank you to Chintamani sir as well as Ratna ma'am to conduct this course and ensuring that all the PGs over here are having a wonderful experience out here, and that everyone knows about the cases and how to approach them in the exams. Big thank you, sir.
Such a pleasure to have you. Yes.
It was a very good learning experience, even for all the exam going students also. And it is very fortunate of us for you guiding us through the exams.
Most welcome. Thank you so much for joining. You did well.
Thank you, ma'am. And I would like to say that in my first year, again, I came to that institute and you told me that we don't promote mediocre here. We try for excellence. So maybe I'm not there yet, but still I try.
Oh, no, you've done well. And don't take my words literally. They're meant to be true.
Guide us into the right path.
But do take them literally.
Sir, I think it's one of the most learning experience for me, and not only about surgery, but also about certain aspects of surgery and life. which other people also, they took a talk and they told us about the decision making in surgery as BB Agrawal sir did. So it's, I think, overall a very holistic learning experience. So thanks a lot to you, sir.
Thank you. Is there anybody else who wants to speak? We won't make all of you to bother. Anybody who wants to speak is welcome. Yes, pass the mic to him. But some are looking very reluctant to speak, so we don't want to force them.
Good evening, sir. My first meeting with you was in July last year. It was in Mexicon. Truthfully, I'm a third MBBS student. You were out of the 21 odd delegates who had won a prize in that conference, I was the only person you hugged. So that was a life-changing moment for me, sir. And that moment onwards, I don't know how, it's just been to me that let's just take up surgery itself. And attending this conference, very truthfully, maybe I've been able to imbibe 35 to 40% of what has been told. But even then, I'm quite sure if the rank allows me and God has grace, I shall become a surgeon.
Give him a round of applause. I'll hug you again. Don't worry. Anybody? Yes.
Hello, good evening, everybody. First of all, thank you so much, sir and ma'am. So I unfortunately could only attend 3 out of the 4 days of this conference because of health issues. But at the end of each day, I was exhausted, and I understand that I could barely imbibe all of what was being spoken on stage. The fact that you understood, then you tried to comprehend what was going on in the presenter's mind, and then you asked questions based off of it, and then you taught at the same time. That is very impressive to me, and honestly, something I aspire to learn as the years go. And I just wanted to say that thank you for teaching us not only surgery and knowledge, but also the fact that not everything can be presented to you in a textbook. Sometimes your own mind is the best textbook you can have. And I think that's one of the best lessons that I can ever get. So thank you so much.
Brilliantly said. Your mind is the best textbook you can have. So there's a good old Beatles number, no? A teacher, leave these kids alone. If you need to learn, you need to burn your books, but don't do that now. It's not literally that you burn the books, it's the idea. Don't be a stickler for don't be a zombie, MCQ zombie.
Thank you, sir. I have come for you only from Silchar. It's in Northeast, far away. I have been a great admirer of you and the scrub programs I have attended and actually been a success. I've learned a lot and I'll take the legacy there. I believe into my hospital also in both clinical practice and by God's grace, it will be fortunate. I'll be fortunate enough if I could work under you someday or the other. Thank you, sir.
God willing. Thank you so much. God bless you. Any other? All right. So I think we are done with that. So I'll announce the list. We have head and neck session. Supriya Raj from LHMC. She may be here or she may not be here. You're here. Come. Good. Keep clapping. These are people with, they're all scholars. So they will be given, we'll have a ceremony for that. Please come. Thank you. In the breast session, and again 80% around Leela Prasanthi, Indira Hospital. You did very well. God bless. Keep standing. God bless. God bless. Come here. Vena, come here. Later. Then abdomen, again, we have these in that order, 80% odd. Bishweshwar Pal from Silchar Medical College. This is N. Guttuswamy, Indira Hospital. There you are. You were in shoes, but that's okay. God bless. Rajat Saini from LHMC. Rajat Saini is the name, I hope. Rajat Saini. We'll announce it. Probably he's watching virtually. And then virtually one person presented from JNMC, Dr. Faz. He presented abdomen. Give a round of applause for him also. If he's watching, he'll be there. And today we had just one crossing that mark. And you can guess, this was in extremities. Dr. Ayush Agarwal from BMMC. You did well. Now the two undergraduates presented, and you can score them yourself. We've got both of them because both of them did well. And for them, we were not being there was no partiality. Sanjeev Reddy, is he here? He made a very good presentation. Come, Sanjeev, quickly. Sanjeev Reddy is from BMMC. He's a huge undergraduate student. He's an intern now. God bless you. And Omar, he's from Aurangabad. So that's the list. God bless you. So we actually have these people declared as scholars. I think you can clap for them harder. You've made an attempt. And before I conclude, like every year, we have something to say about what we did. And I'll start with Dr. Ratna saying something. And then hopefully we'll try to wind up and we'll declare what we need to be doing throughout the year.
Thank you so much, sir, for having me here. And I've been attending this program right from the time you started from Years Together. And I'm not here, perforce is visible from the fact that I've been here on all the 4 days. And it's not that I was here on the board to sit on the dais on all the days. I was still here because I would be happy to be sitting on any of the last benches also to be listening to whatever was happening. The best part of the program is that it's an interactive program and everybody goes back home with the right message. It's not just that somebody is just presenting, going with a few comments. I think there's a lot to learn from this, right from academics to attitudes and even skills and operative procedures, personality development, and so much encouragement happening in spite of so many times I feel that I'm losing my patience, but then I see that you're handling the students so coolly still in completing the case. And I have thoroughly enjoyed this scrubs also, and very happy to learn from you, sir. Thank you so much.
Thank you so much, Madam, for being part of the scope when I started. And the same story would happen towards the end. I'm sitting, of course, she's the only one I'll have around. Most people would be, there once in a while, and naturally the priorities are different. And personally speaking, like every year, it's thoroughly enjoyed by every one of you and especially me. Every year, it's a matter of joy for me. I just keep doing it because I think it is necessary. But more than that, I feel that this is something which is um, kind of compulsive in me. I would like to share it every moment. If I learn something today, I would like to share it with you. And secondly, I have never learned to be diplomatic about things. So I'll tell you frankly, if you're hopeless, you are hopeless. If you're good, I'll tell you you're good. Because what I learned as a mentor and as a mentee was that you should be truthful to your students. And more than that, you should be honest to them. We owe it to them to train. And when I was looking at the students making their presentation, I was not just angry at what they were doing. I was not angry at all. I was making them realize that it is a mistake, but it's not entirely their mistake. A lot of it has got to do with what they learn, how they get a chance to present. There is no bad student I've ever met in my life. So frankly, I will not be honest with you. They're only bad teachers. So we thought of providing a platform many years ago to start on the same pedestal everybody. You can see people from various colleges and you can't make out who is better than the other. Same applies to all those that are sitting here. So I don't think institutions make people. I believe that people make institutions. So there's nothing like X is in one institution, so he's got every reason to be good. No. At every step, you need to keep working hard. It's a very long journey. And in the journey, it doesn't matter when you were sleeping, as long as you wake up and you start walking, because you may take off at any place. So never be afraid of what you are. Make your mistakes so that you can learn out of them. There are no mistakes, as I said, they're only lessons. Don't keep repeating. And when he was mentioning about his presentation in first year, even his presentation in first year, it has changed. They've improved, and it's so good to see them progress. It was so good to see some of my students who are now as faculty. So they are joining the course, and they are joining the course as a faculty because it is a mission. And we are going to start soon with regular teaching courses, including basic surgical skills, which I always wanted to do. I've done virtually all over, but we'll start with that. And you'll all get a chance to do hands-on as an extension. And now I'm in an institute where it is possible to do many things beyond the usual limitations of a institution which is government. So I have thought of a program which will have some kind of a recurring, training programs happening. So it's not just once or twice a year. That's what you have seen in the past. You've seen it thrice. It'll be more frequent and in different forms. So thank you all for making it special for me every year and making it worthwhile. So we put in an effort and we want to see the results. So I have it on evidence that people have done well after this course, but they've done well generally because of themselves. They came here because they wanted to get better. All of you want to get better, and this is just a platform to not only share your information, which you come preoccupied with, but also to share your ignorance. I don't know this, so please teach me. This is one platform we will do it. So thank you all very much. Congratulations to all of you. And we always have a group picture of all those that are present at the end, which goes on our website. So if you could all come over and you are going to do it, Surya? Yeah. Please come. Come onto the dais. How do we arrange it? Do it here. Those who don't want a picture can go also. It's okay. No, we put a chair. I think that will be easier. I have a suggestion. Remove the table. हाँ. ये टेबल हटा दो बस हो जाएगा. उठा लो आयुष. उसके नीचे मेरा वो होगा लैप बैग वगैरह. Background. What do you suggest? Better? और उधर ले लो. It will be better. iPhone? It's an iPhone. You can switch this on. How do you come into the picture? Come. So once. Yeah.